breast cancers. And currently there is improving evidences that there are more number of cases coming up due to improved diagnostic techniques, and it is said that usually the prognosis may be a little bit worse than the unilateral breast cancers. So our objective was to evaluate the demographic profile and the dosimetric profiles of the bilateral breast cancer patients treated using helical tomotherapy. So as I mentioned earlier, it's a retrospective single institutional study. We took all our data from the electronic medical records from the 2018-2015, and all bilateral breast cases were taken. So we had around 19 patients. The mean age was around 53 years. The mean follow-up was 19 months. Majority of the cases were postmenopausal, and majority of the cases were also invasive breast carcinoma of non-specific type, that is the ductal carcinoma. And there were left side 16 cancers, and on the right we had 14. Lobular carcinoma was just 2 and 4. So coming to the pathology, on the left we had majority of the cases luminal B, same as on the right, and equal number of cases, 4 cases on the triple negative and luminal A on the left side, and we had 5 cases of luminal A on the right side. And we had around 3 cases which were of stage 4, and majority of the cases were stage 3 in our cohort, and grade 2 was the most common histology that was found in our set of patients. And when it comes to the treatment details, we were sorry sir, it's automatically. So when it comes to treatment details, we had around it's going on. We can exit slideshow.
meeting.
One slide. Yeah, so coming to the treatment details, we had treated with 40 grain 15 fractions to the breast or the chest wall, and we had also given boost to the required patients. Only 3 patients underwent bilateral wide local excision, that was breast conservation surgery, and around 19 out of the 19 patients, 14 patients underwent at least MRM on one side, and almost 53% of the patients underwent neoadjuvant chemotherapy. So, and coming to the dosimetric parameters, we took D90 and of the left breast and the axilla volumes. The D90 was covered by around 94% and 96 on the right side, and D95 was 92% and 94. If you see the axillary volumes, D90 was around 97% and 98%, and D95 was 94 and 96. So this is one of the dosimetric color wash profiles. If you can notice the small white spot, that was the only hot spot. I mean, even in the other slices we had very small tiny hot spots. Otherwise it was a uniform color wash, and that was the only 42 gray volume. Others were all 40. The whole red is the 40, and then we have the 38. The small blue volume that you see is the 30 gray volume. definitely the low dose lung bath would have happened if I switched on the 5 gray or the 10 gray volume a bit more. That is one of the disadvantages of treating with helical tumor. And this was one different case where on the left side we had a lymphoma and on the right side we had invasive breast carcinoma. So simultaneously we treated with 30 gray on the left side and 40 gray on the right side. So this was just one interesting case. And coming to the OARs, when it comes to the lung volume, actually it was a slightly higher side. We had the mean dose of bilateral lung around 13 gray. V17 and V20 were well under the limits, 24% of V17 and 18% V20. So, and with nodal irradiation, it was a bit more, as we expected, it was around 13 to 14 gray. And coming to the hard dose, the range was 3.2 gray to around 8.5 gray. The 8.5 gray came into the picture because we were also treating IMN in 3 patients. So when the IMN irradiation was included, the hard dose went up by a bit. So that was around 8.5 gray, and with the recent nodal irradiation, it was just around 5 gray. So these were the other OAR constraints that we could manage. All the Dmax of esophagus, spinal cord were well under the limits, and the homogeneity index was close to 1. And when it comes to toxicity, we had no grade 2 skin toxicity seen in the acute skin reactions, and it was majority of the cases had grade 1 skin reactions. And when it comes to late toxicities, there are 5 patients with grade 1 subcutaneous fibrosis. And we couldn't compare exactly our data with any other data. There is one paper, bilateral press paper from the DMH by Jabasama. But the only thing is, I don't know whether we can directly compare, because that paper was done on a 50 gray 25 fraction schedule. Our study is being done in a 40 gray 15 fraction schedule. So we may not be able to directly compare them. So we had relatively comparable values is what we could infer from this, as the mean lung dose were close to us. And this was the mean comparison of bilateral lung doses and the hard doses. And our cohort majorly consisted of node positive, luminal bay, HER2 negative cases. Invasive breast carcinoma was no specific type. And the adequate coverage was seen in terms of D95 and the hotspots of 105 being less than 2% hardly. And mean lung dose was 13 gray and hard dose was 5.9 gray. With IMN it was a bit higher. And we had 50% of the cases with almost grade 1 skin toxicities, and there were no grade 2 toxicities observed. So helical tomotherapy achieves a good dosimetric outcome with respect to PTV coverage and OAR study. Thank you.
How many were synchronous?
Out of the 19, I think around 14 to 15 of them were synchronous bilateral.
15 of them, that's a good number. So the rest 4 were, that's the time gap.
Time gap was more than 6 months actually.
But all your calculations were adjusted to that or?
We had to adjust the calculations accordingly. We had to take the cumulative of both the doses from the plans, and we came to this conclusion.
Okay. That's a good exercise. Yes, sir.
You need to put a pitch and a modulation factor.
You were satisfied with this study, but given a choice, would you prefer 15-25?
Currently in our institution, we have been practicing 40 gray in 15 fractions, and the toxicities were also much lesser. So I think I might prefer doing 40 gray in 15 fractions with a boost.
What were the luminal status of one and the other? Were they different? One triple negative, one luminal A?
It was different, sir. It was in both the majority of the cases were luminal B, and we had triple negatives on the left side. Triple negative on the left side. Either side had triple negative, but the number was less. And interestingly, the lobular carcinoma was much less. We expect lobular to be bilateral, but I don't know, because majority of the data was ductal carcinoma. We had very less proportion of lobular carcinoma cases.
Thank you, sir. We'll proceed. Thank you.
The next speaker, Dr. Ilakya Devi. Dr. Ilakya Devi.
topic for today is cross-sectional study on the burden of caregivers and cancer patients and the factors influencing it among caregivers at a tertiary care hospital in Chennai. So my cancer and its treatment significantly impact not only physical and psychological health of the patient but also their family members. So caregiver plays a very vital role in giving financial, physical, emotional and social and take multiple resources to meet the patient's needs. So caregiver involvement plays a very vital role in overall management and prognosis of the disease. Study justification, we have a lot of studies regarding overall survival and disease-free survival of the cancer patient, but let's study to quantify the burden of the family. So this study created a path to focus our attention on the caregiver of the family and provide a better outcome of the cancer patient and quantify the hurdle faced as a family members. My objective is to assess the burden experienced by the caregivers and to determine the factors influencing the burden on the caregivers. Study is facility-based cross-sectional study done for the period of 3 months, which is done in our hospital, Rajiv Gandhi Government Hospital. Data collection was done during Zaret-Berlin interview questionnaires, analyzed with the SPSS software version, and chi-square test and odds ratio was used to test the level of significance and relate the strength of association. So the sampling is done using conceptual sampling method with 110 participants. So these were the questions asked to the patients. Our results were the age varies from 19 to 15 years, and 60% were female and 84% were married. Out of the 80% had children, and 66% were employed, 35% were illiterate, and 40% had primary school education. When coming to the perception of the income level, 81% has to spend more than their income, and 89% had difficulty in covering the medical expenses. When coming to the kinship caregivers, 35% were spouse and 32% were children. So 59% had caregiving duration of more than 1 year and 40% has caregiving duration of less than 1 year. 94% has negative impact in their daily life. So caregiver burden was 90%. Out of the caregiver 90%, 75.5% more than one burden, 64% has economic burden and 64% has psychological burden. Out of the economic burden, 36% were having difficulties in covering their daily needs, and 26% experience economic burden because they have lost their job because of the caregiving. When coming to the psychological burden, after 59.1%, they had a psychological burden of 30% because their close relative is sick, and 29% has a psychological burden because of the social stigma. 55% has experienced physical burden, and other burden were calculated by 57%, which includes difficulties in seeking the appointments, medicine procurement and transport related burdens. So when comparing to the economic burden to the duration of caregiving, more than 1 year had a very significant impact with a p-value of 0.07, and when their expense is more than income, it comes around 78%. When we compare the economic burden with the duration of caregiving, the p-value is 0.07 and the odds ratio is 3.3. When comparing the economic burden with the perception of income level, when the income is when the expense is more than the income, the odds ratio comes around 7.3%. When comparing the psychological burden with the duration of the caregiving, it is also significant, and the psychological burden has a negative impact in their life. The odds ratio for comparing the psychological burden and the duration of caregiving is 2.8, and the odds ratio for comparing the psychological burden with the negative impact in life is 15.7. When we compare the physical burden with the duration of caregiving, more than 1 year of duration of caregiving has more burden than less than 1 year. For the p-value, when comparing the physical burden with the duration of caregiving, the p-value is 0.01 and the odds ratio 5.3. So So we compare the overall caregiver burden with the duration and the dependency of the patient for their daily activities, which is very, very significant in our study. So the p-value comes for the caregiver burden and the duration of caregiving is 0.01 with the odds ratio of 9. And the dependency, the caregiver burden increases with the dependency of the patients for their daily activities, which is less than 0.001%. The odds ratio comes around 14. So when we compare my studies with the parent paper like Pavasi et al. And the Mishra et al. In Pavasi et al. Mishra et al. All have the caregivers experience burden. In our studies, 90% experience burden. When comparing the Pavasi et al. And Mirashi et al., the duration of caregiving impact on the daily roles was statistically significant, which is similar to a study. And the duration of caregiving of the patient dependency was significant. Predictors of caregiving burden was significant with similarity with our studies. So the conclusion, cancer strikes more than just the patient. It touches every life in the family. So our study highlights a majority of caregivers experience burden. Out of them, 75% experience more than one type of burden. So caregiver burden was significantly associated with longer duration of caregiving, dependent cancer patient, and the perception level of income and a negative impact in life. So addressing caregiver burden is essential not only for the well-being of the caregivers, but also to ensure consistent high-quality care for the cancer patient. So timely identification intervention can improve outcomes for the both caregivers and patients. So recommendation, we have to give counseling service and encourage shared caregiving duties. Social welfare support can be encouraged and the caregivers can be given training and education system. Financial aid can be given by government or NGO for the chronic caregivers. And further research must be conducted to track caregiver burden over the disease scope. These are my references. And thank you.
In which language did you give the questionnaire?
Tamil, sir.
Any other questions? Any other questions? Next, we move on to the next
Thank you, sir.
candidate. Dr. Balalakshmi, Christian Medical College.
Good morning to all. So today I'll be presenting a review of outcomes after postoperative EBRT in thymomas. So thymomas are slow-growing indolent tumors which are typically managed by surgical excision, and postoperative RT has shown to increase the survival outcomes, especially in patients with locally advanced disease and with close or positive surgical margins. So the aim of the study was to evaluate the patient characteristics, the treatment tolerability and the early oncological outcomes of patients who had thymoma and received postoperative RT in our institution. So this was a retrospective study of 33 patients, including the patients treated from January 2020 to May 2025. So all of these patients were symptomatic at diagnosis, with almost 45% of them presenting with myasthenia gravis. And next common complaint was cough and chest pain, and some patients also presented with Good syndrome, autoimmune hepatitis and SVC obstruction. So the predominant WHO pathological subtype observed in our cohort was AB followed by B2, and some of them did have a mixed B2 and B3 also. So these patients were predominantly Masuka-Koga stage 2B, and when the same cohort was staged with AGCC 9th edition, they were predominantly stage 1 disease. So 15% of them had to receive neoadjuvant chemo in view of borderline resectability, and surgical histopathology showed a positive resection margins, R1 margin predominantly followed by R0 and R2, and 3 patients also received adjuvant chemo. So the common chemotherapy administered was cisplatin and etoposide. So the indication for RT and the decision for the postoperative RT was guided by the recommendation of the multidisciplinary tumor board. And the common indications in our cohort was posterior margin R1 resection, R2 resection, and even in case of R0 resection, we had given post-op RT in view of extrathymic adipose tissue invasion, and in 3 patients in view of recurrent disease. So we had treated them predominantly with conformal radiation technique, with doses ranging from 45 to 50.4 gray delivered in 25 to 28 fractions, and 2 patients received concurrent chemo in view of gross residual disease, which was a weekly paclitaxel carboplatin regimen. So this is a table showing the median OAR doses in our cohort, and as you can see, in almost all of the patients we were able to achieve the dose constraints as recommended by the guidelines. So all of them completed the treatment without major interruptions, and though acute toxicity was seen in 33% of the patients, it was all grade 1 toxicity, with radiation dermatitis being the most common. There was no grade 2 or more toxicity reported, and also during the time of follow-up, there was no late toxicity reported. So 3 patients were lost to follow-up out of 33, with a median follow-up of 7.5 months. 93% of them were found to be disease-free at the time of last follow-up visit. So 4 patients recurred, and 1 of them had died in view of disease progression. 2 of them developed local regional recurrence, which was treated with repeat excision followed by systemic therapy. 1 patient had developed a distant metastasis to bone, which was histopathologically confirmed and treated with palliative radiation therapy followed by systemic therapy. So coming to the characteristics of patients who had recurred in our cohort, they were diagnosed with predominantly locally advanced disease 4A, 4B, and they had posterior surgical margins R2 section, and the pathological subtype commonly observed was WHO type AB. The median overall survival was 11 months, and the median progression-free interval was 7 months, and the disease-free survival at 1 year was 89%, and overall survival was 95%. So, literature review of postoperative EBRT in thymoma is largely retrospective, and all these studies do show that there is a benefit in stage 2 and above, especially with close and positive surgical margins. So the overall survival and the disease-free survival in our cohort, though it was not exactly compared, as in it was published studies were 5-year and 10-year overall survival. We had only calculated for 1 year, 2 years, but it was still comparable to that data. And published studies do show that most of the patients have grade 1 toxicity, with grade 2 and above being reported based on the radiation modality. But in our study, we only had grade 1 toxicities. So to conclude, our experience does suggest that postoperative RT in thymoma is a feasible modality, and recurrences of these patients predominantly occurred within 1 year post-treatment. So there is definitely a need for close follow-up, and we do need in the future more prospective studies with multi-institutional collaboration with longer follow-up data to better define the high-risk subgroups and also the benefit of EBRT owing to the disease rarity. These are my references. Thank you.
Any questions from the forum? I have a doubt. You said your recruitment is May 2025 till then. Then how can you say about the overall survival? How did you include them in your... The US is saying something about the overall survival.
That was mainly for the patients who had completed 1 year post-treatment.
So then you cannot...
See the recurrences, how many were symptomatic recurrences? Which means like they had myasthenia again or...
So only 1 patient out of the 4 was symptomatic. I developed a distant recurrence. He had bony pain, lower back pain, and that is how we found out. Others were routinely diagnosed during the follow-up CT imaging. Thank you.
So the next we call upon Dr. Kanmani, Mohammed Institute of Medical Sciences.
morning everyone. I'm Dr. Kanmani, second year postgraduate from Sri Mogambiga Institute of Medical Sciences. I'm here to present my research paper on the topic, Role of Prognostic Nutritional Index in Assessing the Tolerance to Radiation Treatment among Head and Neck Cancer Patients. The aim is to evaluate the role of PNI in assessing the tolerance to radiation treatment among patients with head and neck cancers. My objective was to assess the effect of PNI on treatment completion rates and treatment breaks, and to assess the effect of PNI on acute radiation-induced toxicities. It's a single institution observational study with a sample size of 43 patients. The study was done in the Department of Radiation Oncology, Sri Mogambiga Institute of Medical Sciences. The duration of study was 12 months. The study participants' inclusion criteria: age above 18 years, ECOG performance status 1 to 2, T1 to T4 node positive diseases, head and neck squamous cell carcinoma undergoing radical chemoradiation, and exclusion criteria was post-operative cases and metastatic diseases. PNI was derived from the formula 10 into serum albumin plus 0.005 into total lymphocyte count per millimeter cube. So PNI less than 45 was grouped as low PNI, and PNI more than or equal to 45 was grouped as high PNI. Patients were examined every week for RT reactions, weight monitoring, and routine blood tests. Table 1 summarizes the baseline characteristics. The mean age was comparable between the groups. Males predominated both the groups. The majority of the patients had stage 4A disease followed by stage 3 and stage 4B. Overall common subside was oral cavity, and 62.5% of patients received IMRT technique. And dropouts due to non-nutritional cause was 7.5%. The results. Table 2 summarizes the treatment outcome variations based on the PNI category. The blue bar represents low PNI and the orange bar represents high PNI in the bar chart. And 95.8% of the patients with high PNI had completed radiation therapy compared to the low PNI group, suggesting that patients with high PNI are more likely to complete the treatment without interruptions. And treatment discontinuation rates was 30.8% in low PNI and only 4.2% in high PNI, supporting the role of nutritional status in treatment tolerance. Treatment breaks was slightly higher in the low PNI group compared to the high PNI, but the difference was much small. Table 3 shows the distribution of toxicity grades among the PNI category. Patients with high PNI had higher grade 1 toxicities, whereas the grade 2, grade 3 and grade 4 toxicities were more frequently observed in the low PNI group. Stating that this bar chart demonstrates that patients with low nutritional reserve are more likely to develop higher grades of toxicities. The table 4 shows the association of PNI classification and feeding intervention. 84.6% of the patients in low PNI group required dry tube feeding compared to 54.2% in high PNI group, supporting that the low PNI patients they required more feeding interventions compared to the high PNI group. So table 5 summarizes the key outcomes based on the PNI classification. RT completion rate was much higher in the high PNI group with a p-value of 0.04, and discontinuation rates was higher in the low PNI group compared to high PNI group, which was only 4.2%. The treatment rates were slightly higher in the low PNI and did not reach statistical significance. Grade 3 and higher toxicities were 46.1% in low PNI group and 8.3% in the high PNI group. 84.6% of the patients required feeding intervention in low PNI compared to the high PNI. So conclusion, patients with low PNI group demonstrated lower RT completion rates, higher treatment discontinuation, increased incidence of grade 3 and higher toxicities, and significantly higher need for feeding tube support. And these associations were statistically significant, and they align with the previous evidences supporting malnutrition contributing to increased treatment-related toxicities and poor treatment tolerance. So pre-treatment PNI assessment is a simple, non-invasive and an objective tool to assess nutrition and immune status. And these patients are to be prioritized for early ITU assessment, regular weight monitoring, and proactive enteral feeding support. So limitations of my cohort, the sample size was small, so generalizability of the findings might not be correct, and the groups were unequal in size, so there is a potential for bias. Lack of long-term survival data, and it's a single sector cohort. These are the references.
Just go back to the reference, please. Thank you. Go back to the reference, please. PNI is a very interesting map here. PNI is a very interesting thing you have taken up. Well constructed one. The references for PNI is very, very less in literature.
Yes, sir.
And your calculation, did you compare it with any other fixed, normally whatever we follow, BMI, or yesterday we had a very good paper on the C3 measurement in according to CT scan. So have you compared with any of those or just with literature?
Just with literature, sir, because this actually PNI, the first time they spoke about PNI was in 1980s. And Osteoradionecrosis came with this formula in 1984, and those people presented a paper on patients who underwent gastrointestinal surgeries, oncology patients. And in that patients, it was very significant. The low PNI patients didn't do well post-operatively. And the first study I saw it in the ESMO paper, and that also had significant results. So and I was drawn towards this. The literature was very less for this.
Very interesting.
Thank you, sir.
So, what were the subset of patients which you were treated? Was it common in same or it was different subsets?
Different subsites, sir. Only head and neck cancer patients.
No, I mean to ask, is this oral cavity, oropharynx, hyperpharynx, like that?
It is all the patients.
So how would you say that, the reactions will be entirely different when you do that? And it is not the same technique which is used.
Yes, sir. Actually,
So obviously the patient will have more higher grade reactions than the. So you cannot compare everybody in the same zone, right? So I think you should probably would have compared same set of patients with same kind of technique, then probably we could assess that better. I
yes,
think
sir.
you should do that next thing.
Yes, sure, sir. I'm going to follow these patients for survival. Maybe as you said, I'll follow the patients separately if I could get more patients. Then I'll
And same technique, that would be
Yes,
better.
sir.
Thank you.
Can we call the next speaker? Shivani from Madras Medical College. Pre-treatment pan-immunoinflammation value efficiently predicting survival outcomes in high-grade glioma patients receiving radiotherapy and temozolomide, a single institutional experience.
Good morning to one and all present here. Myself, Shivani, a postgraduate from the Department of Radiation Oncology, MMC. I would like to give an oral presentation on pre-treatment pan-immune inflammation value efficiently predicts the survival outcome in high-grade glioma patient receiving radiotherapy and temozolomide. The glioblastoma is the most common and aggressive adult brain tumor with low median overall survival despite maximal resection followed by radiotherapy and temozolomide. It has various biological markers which predicts the prognostic variability. Systemic inflammation plays a key role in tumor progression, and composite indices using the peripheral blood count can be used as a prognostic value in several cancers. This study tries to investigate the prognostic significance of pre-treatment pan-immune value in newly diagnosed high-grade glioma patient receiving standard chemoradiotherapy. My aim is to evaluate the predictive significance of pre-treatment pan-immune inflammatory value in patients with newly diagnosed high-grade glioma who receive post-surgical radiation therapy and concurrent plus adjuvant temozolomide. It is a retrospective study conducted in the Department of Radiation Oncology MMC in 33 patients between the year January 2020 to May 2023. My study includes a patient between the age of 80 to 18 and ECOG of 0 to 2, histologically confirmed high-grade glioma diagnosed according to WHO classification, existing pre-treatment blood investigation which lies the baseline of my study, and no direct evidence of active infection or delayed wound healing post-surgery, no prior immunosuppressive disease history. Exclusion criteria: prior history of radiation, absence of temozolomide administration during either concurrent or adjuvant treatment phases. A retrospective cohort study was conducted in 33 patients who was diagnosed histologically confirmed high-grade glioma who underwent adjuvant radiotherapy and temozolomide at our institute. Pan-immune inflammation value was calculated, which is the product of platelet, monocyte, neutrophil divided by lymphocyte. The primary endpoint was determined as a potential link between the pre-treatment pan-immune value and overall survival results, defined as the interval between the initiation of the RT plus concurrent temozolomide and the date of the death and the last visit. Result: among 33 patients, 36% were female and 64% were male, and at the end of the study, 33% were alive and 66 expired. These are the descriptive statistics of the variables used in my study, that is platelet, neutrophil, monocyte, lymphocyte, and PI value comes around the mean of 275 plus or minus standard deviation. This table shows the survival comparison between the PI value group. Among 33 patients, 24 patients who had a low PI value of 385 had a mean survival days of 435. And among 9 patients who had high PI value had just survival days of 137. So from this, the log rank P value comes around significantly. This slide shows the Kaplan-Meier survival analysis of the study. This shows the statistical difference between the two PI value group. The red line depicts the high PI value group and the blue line depicts the low PI value group. The red line shows a steep decline in the survival probability, and the overall median survival rate just falls within the first 200 days, whereas the low PI value group shows a gradual decline over a longer period. So the log rank value and Kaplan-Meier curve of this study shows that the difference was statistically significant, indicating that elevated PI value is associated with poor overall survival in high-grade glioma patients. Discussion. The patient with high treatment planned value has significantly worse overall survival compared to those with low PI value. PI value remained an independent prognostic factor in multivariate analysis even after adjusting for known variables like age, performance status, and extent of resection. Rationale of this study is glioblastomas associated with highly immunosuppressive tumor microenvironment, elevated neutrophil, platelets, and monocytes, which are the components of PI value, can promote the tumor growth and angiogenesis. Low lymphocyte count suggests the weakened anti-tumor immunity. Hence, the PI value reflects the pro-tumor inflammatory profile. The clinical implications are PI value, since it is derived from the routine blood investigation, it makes it affordable, non-invasive, and easily reproducible. And further, it could be used for risk stratification before initiating treatment and identifying patients who may benefit from close monitoring or more aggressive or novel therapies. And future directions of this study may be prospective multi-center study needed to validate the findings, explore the integration of PI value with molecular markers, assessment of PI value post-surgery in predicting the survival outcome, to investigate the role of PI value in predicting response to immunotherapy or novel treatment protocols. So the conclusion is this study emphasizes on the novel comprehensive pan-immune value, which is an affordable, non-invasive, readily accessible, simple to count, and reproducible biological marker, which was independently able to stratify newly diagnosed high-grade glioma patient into two groups with significant overall survival difference. Thank you.
Any questions?
So what is the time frame when you started evaluating for this?
So I calculated 2 years overall survival.
Then what is the PNI value of
Pre-treatment, sir.
pre-treatment, pre-surgery or pre?
Post-surgery, before starting RT and was
But in the last slide you said you have to do it for post-surgery PAV.
that if possible, it can also be done for that.
But all patients get post-surgery only, na?
I suppose surgery.
So basically, this counts will keep changing during the course of chemo. Did you have a look at how it varies every week?
Wasn't done in
And whether you compared this with pre-adjuvant, how it is, whether it changes? That's a good exploration point to look at also.
Okay, sure.
Patients were on steroids?
Yes, sir.
That would change the values?
Yes, sir. Due course. Yes, sir. But I just assessed only the pre-treatment values.
Include all those into your criteria.
Oh.
So that you can assess it better.
Okay,
If
sir.
anybody is following the study, please make sure those components are brought up.
Sure, sir.
So even post-operatively, no, so the patient will be on steroids. Like immediately after the surgery, the surgeons will definitely put on steroids. So that might also blind your value. Maybe we should compare this with pre-op value as well.
No, sir. My inclusion criteria included patient not on any immunosuppressive drugs or drug history, disease
I
history.
am 100% sure 33 patients will be on steroids post-operatively.
It's not your study, ma'am. Generally, who was following them, please follow it such a way that it's not before surgery itself.
Because the decompression after the surgery for all patients, the neurosurgeon will put on steroids. DEXA will be a standard protocol immediately after surgery.
Yes, sir.
See with the gender variation.
Sir?
Gender. You have seen for age, performance.
Yes, sir. Yes, ma'am.
The gender also. Male, female.
No, ma'am, just male predominance was there. Over glioblastoma, but for this study I didn't see any.
That's what you can look into that also.
Okay.
Tissue larger sample. It looks quite interesting to do.
Okay, nice presentation. Next we call upon Dr. Prashanthi Balasubramanian. So, from MMC, addressing the uncertainties of the dancing part. Makile present panna.
Good morning everyone, this is Dr. Prashanthi from Madras Medical College. Today is about addressing the uncertainties of the dancing cord, moderated by the faculties of Madras Medical College. Coming to introduction, accurate delineation of organ at risk is critical in head and neck radiotherapy, where the spinal cord's steep dose response necessitates precise contouring. Traditional spinal cord outlining on CT suffers poor visualization without T2 weighted MRI and intra-observer variability of up to 2 to 3 mm and under-presentation of positional shifts is observed. Hence, contouring the bony spinal column as a surrogate addresses these limitations. It offers clear and reproducible boundary inherently encompassing potential cord motions due to setup errors and anatomical changes. By contouring the spinal canal, the spinal cord receives lesser dose in preventing late toxicities such as radiation-induced myelopathy. Next slide, please. Next slide. My primary objective is to compare the dosimetry between spinal canal and cord PRV and to establish the spinal canal contouring, the ease of spinal canal contouring. My study design is a retrospective study done at Madras Medical College with a departmental registry, and it is represented as mean as standard deviation with the help of paired sheet square test, inspection of QQ plots and Shapiro-Wilk test. My methods and methodology is a comprehensive review of institutional study was undertaken. Image acquisition was done by taking CT simulation of patients with head and neck malignancy, where GTV, CTV, PTV is contoured under VMAT technique. Spinal cord was contoured and a PRV margin of 3 mm was given to the spinal cord. Canal is delineated and contoured from the superior border of C2 vertebra based on the bony anatomy. Constant compliance is given to the spinal canal contouring based on Quantic and RTOG guidelines. Plan is generated and analyzed in Variant Eclipse software and statistical analysis was performed. Thus, a retrospective dosimetric analysis with a sample size of 20 patients under VMAT examining the DIBH parameters, intra-observer variability and plan robustness for both OIR definitions was done. Dosimetric data is collected and analyzed the values of Dmax. Comparison of maximum dose was done, and significantly there was difference between the bivariate samplets were formed in paired groups and the paired sample t-test was used. In the above statistical tool, the probability value was 0.5, which is considered as the significant level. Here I enumerate my results. The Dmax was higher in spinal cord PRV compared to that of spinal canal, with the mean difference of 1.19 grade with a p-value of 0.0008. The Dmax of spinal cord PRV is higher when compared to that of Dmax of spinal canal, but they are well within the Quantic guidelines, and also it is not statistically significant. Here, coming to discussion, here I have contoured the spinal canal. In the next image, I have contoured the spinal cord, and in the third image, I have given a margin of 3 mm, where it can when treating in large numbers, it can lead to difficulty to the physician, and it shows the bony canal is readily identified on CT, reducing the contouring discrepancies and enhancing the planning consistency. Thus, bone matching can be done at least with the help of CT. The clinical benefits are helping in margin incorporation. Canal delineation naturally accounts for daily shifts and anatomical changes, improving safety margins in VMAT. And there is canal-based plans yield Dmax and small volume dosimetrics to spinal cord of up to 0.5 to 5 gray, lower than that of a cord-based plan, blocking its neural protection. Canal contours remain stable throughout the treatment, benefiting the adaptive protocol. And there is also workflow efficiency in a large volume tertiary care hospital with a huge patient load, contouring spinal canal will ease the work of the physician. Next slide, please. The future beholds on the prospective study by mitigating the uncertainties of canal-based planning and may reduce the risk of radiation-induced myelopathy, which is a late toxicity that is manifesting as tingling, numbness, or sensory deficit. In rare cases, progressive neurological deficits is observed. My conclusion is that spinal canal contouring is associated with significantly lower maximum spinal canal dose compared to that of spinal cord PRP contouring and head and neck contouring. Spinal canal delineation, which offers a reliable conservative alternative to direct spinal cord contouring, enhancing the consistency, robustness, and patient safety in higher precision head and neck radiotherapy, such as under VMAT technique. Incorporating it into clinical practice and guidelines is strongly recommended. Its robustness supports adaptive planning. Emerging guidelines favor its use to minimize uncertainties and to reduce the radiation-induced myelopathy. Precisely, I'd like to tell, as contouring the spinal canal is easier when compared to the spinal cord, which needs MRI or CT myelogram, which is again invasive, we will treat cases with bone matching with CBCT. Using spinal canal as an alternative to spinal cord as OIR will be easier in both contouring and treatment execution in high volume centers. Thank you.
Questions from the audience, please. Judges. So that's a good presentation. No questions from the audience. Okay. Shall we move on to the next?
I'd like to extend my gratitude to my faculties of Madras Medical College, to my friends, to my batchmates, Genesis, and to, most importantly, to my professor who has guided me through and throughout this presentation, my professor Dr. Anthony Nityaman, and my family for coming all the way down.
The next participant, Kola Monica Shilly, Madras Medical College, evaluation of liver dose reduction by DIBH in carcinoma right breast patients and its effect on liver function.
What is my topic? To evaluate liver dose reduction by DIBH in carcinoma right breast patients and its effects on liver function tests. Adjuvant radiotherapy plays a key role in carcinoma right breast management for improving the local regional control and overall survival. With increasing survival benefits, the side effects of radiotherapy may overweigh the primary disease related risks and have become the main determinant for survival. DIBH is an emerging technique, though it is being used in left breast and various thoracic malignancies and abdominal malignancies. It is less evaluated for radiation dose reduction to the liver in carcinoma right breast patients. What is radiation-induced liver disease? Radiation-induced liver disease is the most recognized manifestation of hepatic irradiation, and it occurs within 2 weeks to 4 months post-radiation. It manifests as anictic hepatomegaly, ascites, elevated ALP. Histology-wise, it is associated with veno-occlusive diseases and sinusoidal condition. Although it is very less common in the right breast patients, but it can occur with a moderate dose of 10 to 30 gray. And the quantitative recommendation suggests the mean liver dose to be maintained at 30 to 32 gray, with a limitation of volume received by volume receiving 50% of liver volume should receive less than 30 gray, but in left breast, though it is less received, and there is a study called Altinois et al. Which showed that the mean liver dose in carcinoma right breast is to be maintained at 3.4 to 6.2 gray. And this study seeks to fill the evidence gap by comparing the liver doses and the serial LFTs results between the DIBH and free breathing arms in PMRT of right breast, which are treated with the 3D CRT technique. My primary objective to standard free breathing approaches in terms of liver doses for patients of carcinoma radius. Secondary objective is to assess the changes in the liver function test at the baseline during the RT every week and till 6 months after completion of RT. My study place is Madras Medical College, DIBH. Study period 2023 December to 2024 December. My sample size is 23 patients in each arm, the patients were recruited by universal randomization. My inclusion criteria: female carcinoma right breast patients aged 35 to 64 years, which is a histologically proven carcinoma right breast of stage 2 to stage 4, post-mastectomy status, referred for PMRT using 3D CRT with normal CBC and baseline LFTs within normal limits. And exclusion criteria: history of liver pathology or elevated baseline liver function parameters, unwilling or unable to cooperate with DIBH training, diagnosed cardiothoracic condition, treatment defaulted at any stage of radiation, and BMI more than 35 kg per meter square. I have recruited the patients using universal randomization, and the patients which are selected for DIBH are initially trained for DIBH. Then we proceeded with CT simulation for the DIBH patients and free breathing arm patients, and the contouring is done and planning is done for all the patients in both arms. As per our institutional protocol, both the patients were planned for 50 gray in 25 fraction of 3D CRT. And the dosimetric parameters assessed D mean for the liver, V10, V20 and V30 for the liver. Liver function tests were assessed initially at the baseline while on RT and post RT at 1, 3 and 6 months. Next slide. And this is the image showing the movement of the abdominal organs in the free breathing and DIBH. According to various studies, the liver movement in the when compared to the free breathing and DIBH, it's a maximum 5 cm with a minimum of 2 cm difference. Next. And this is the color wash image showing the spillage dose received by the dome of the liver and in the free breathing arm, and there is a DIBH color wash image showing without any spillage to the liver. And this is the image showing the involvement of liver in the PTD in free breathing arm, and when DIBH is being done, liver will be pushed down, pushed inferiorly away from the PTD. Next slide. And these are my results. Mean liver dose for the free breathing arm patients were 4.6 plus or minus 1.2 gray, and for the DIBH it was 1.97 plus or minus 0.9 gray, and V30 was 56 plus or minus 35 ml, and for DIBH it was 12.2 plus or minus 28.5 ml, and V20 was 115 plus or minus 33, and for DIBH it was 43 plus or minus 38, and V10 was 156 plus or minus 49 with for free breathing, and for DIBH it was 82 plus or minus 39 ml. And these are the box risk plots showing the distribution. Though there was a variation in the patient data distribution, the DIBH and free breathing arm, there is a comparatively significant difference between the liver mean dose distribution between the DIBH and the free breathing arm. And this is the V10 difference between the free breathing and the DIBH arm with a negative skewness in the free breathing arm. And this is the V20 distribution in the DIBH and the free breathing arm. And this is the V30 for the liver in the DIBH and the free breathing arm. There is no box in the DIBH arm where the data is entirely conglomerated at the lower levels, and most of the patients has received 0 gray in the DIBH arm. V30 was received 0, and these are the liver function box with the plots for the liver function test. Though there was a significant widespread distribution of the patients with variations in the DIBH arm and the free breathing arm, but they were comparatively less significant. Discussion: existing role of DIBH technique in carcinoma right breast is to spare the lung and heart doses in lung and abdominal malignancies for the motion management. But when DIBH was introduced in the PMRT for the carcinoma right breast patients, liver was pushed inferiorly away from the treatment field, and it reduced the mean dose to 1 to 0.9 gray in DIBH and 3 to 6 gray in the free breathing arm. The maximum point dose received with the DIBH was 15 gray, and with free breathing it was 40 gray. And the volume receiving 30 gray was reduced to 0 with DIBH technique. And the confounding factors like existing liver disease the chemotherapy-induced liver damage were excluded at the baseline itself. My conclusion, DIBH technique in carcinoma right breast patients greatly spaced liver, lung and heart doses. Despite the absence of statistically significant differences in the post-treatment LFTs between the DIBH and free breathing group, the dosimetric advantage of DIBH translated into the observable but though significant subclinical hepatoprotection. Although liver doses were kept under tolerance limits, DIBH still decreases the dose further and volume receiving 30 gray can be decreased to 0 with DIBH. This suggests that liver dose constraints, even when not explicitly mandated in the right breast cancer patients, merits routine attention, and particularly in patients with the pre-existing hepatic vulnerabilities or those undergoing hepatotoxic systemic therapies. Thank you. These are my references.
Thank you. The very layman, can you define radiation-induced liver damage?
Sir, actually, the D mean according to the quantic dose constraints, D mean to the liver is to be maintained at 25 gray. More than
Madam, please. I'm not going to dosimetries. Simple thing is define radiation-induced liver damage. Radiation-induced liver damage. How do you come to the diagnosis?
Sir, it is classical and non-classical, sir. Non-classical will present with ascites and elevated ALP, sir. Classical will present with elevated ASTs. And anitric phase is seen with the non-classical, icteric phase is seen with classical.
When does it occur after radiation? It's due to radiation, right? When does it start happening?
2 weeks to 4 months post RT, sir. When the constraints to the liver D mean are not achieved, it can occur at 2 weeks to 4 months.
My goodness God. I'm sorry. I'm sorry for the expression. Then these people already had chemotherapy, right?
But we have eliminated the confounding factor at the baseline itself, and we have taken the patients who are having only normal LFTs.
At baseline.
Thank you for teaching me.
But then after chemotherapy to change, no? It may have some effect, no?
Yes.
That's what sir is saying. Although baseline LFT is normal, when you give chemo, or the low is like immediate.
Yes.
Profit fishing comes some time.
Yeah, but to radiation-induced liver disease, we need a fibroscan, which will be evident only after 6 months post-treatment.
That is the question. 6 months after treatment, but the difference 6 weeks, 2 weeks.
2 weeks to 4 months.
Then that is the problem, Sorry, unfortunately, for more than 20 years, this kind of clinical case scenarios hardly encountered. And as a paper, it's absolutely fine. You have done a lot of work, absolutely done. But in practice, to convert these patients to DIBH, the money and the time involved is going to be so huge that is it a factor that we need to take into our clinical practice? That is the question which I'm asking. I hope my teachers would.
What is the treatment for RALD? Treatment.
Treatment for radiation-induced liver disease.
No issue. Don't worry.
Next we call upon Dr. Saravana Kumar, Madras Medical College, to speak on the hippocampal sparing RT in low-grade gliomas.
Good morning all. My presentation topic is on hippocampal sparing radiotherapy using VMAT to the low-grade gliomas study and neurocognitive function assessment. Low-grade gliomas represent a class of primary brain tumors that predominantly affect young adults and characterized by relatively slow progression and long survival rates. Radiotherapy remains the core for treatment of low-grade gliomas, particularly in patients with residual disease following surgery or in those with unfavorable prognostic factors. However, as life expectancy improves with advances in neuro-oncology, attention has shifted toward minimizing treatment-induced long-term toxicities, notably neurocognitive decline. The hippocampus plays a vital role in memory processing, and its radiation dose correlates with the delayed recurrent disease. Recent radiotherapy techniques such as VMAT allow for precise dose modulation and present the potential for hippocampal sparing. The primary objective was to evaluate the dosimetric feasibility of hippocampal sparing radiotherapy using VMAT in low-grade glioma patients. The secondary objective was to assess the neurocognitive assessment post-radiotherapy. This is a prospective study conducted in Barnard Institute of Radiology and Oncology. My sample size is a single-arm study which includes 25 patients conducted between 2023 to 2024. My inclusion criteria are age between 10 to 70 years, KP score of more than 60 years, histologically confirmed low-grade gliomas, ability to complete neurocognitive assessment, willingness to provide informed consent and comply with the treatment and follow-up schedules. Exclusion criteria: history of previous brain radiotherapy, pre-existing neurocognitive disorders, contraindication to MRI imaging. This study included 25 patients diagnosed with low-grade glioma who were referred for radiotherapy. Eligible patients were recruited from the outpatient department of radiation oncology. Patients underwent CT simulation in the treatment position using a thermoplastic mask for mobilization. Simulation CT images were fused with contrast-enhanced MRI scans for accurate target delineation. GTV, CTV, PTV were delineated as per institutional protocol. The treatment plans were optimized using VMAT to spare the hippocampus while delivering a total dose of 54 gray in 30 fraction. The hippocampus was contoured according to RTOG 0933 guidelines. The dose consent applied was Dmax of less than or equal to 17 gray. This image shows contrast enhanced T1-weighted axial image in which the hippocampus was situated medial to the temporal horn of lateral ventricle. The hippocampus then goes superiorly and posteriorly, which the most part of the hippocampus is splenium of the corpus callosum. This picture shows the 17 gray colorless dose, which effectively spares the contralateral hippocampus. This is the VMAT plan. Shows the semi-arc. We used the semi-arc to spare the contralateral hippocampus. For neurocognitive assessment, we done at baseline 1 month, 3 months, and 6 months post radiotherapy, done by using the help of modified millimeter state examination and a Hopkins verbal learning test revised, and a Ray complex figure test, a recognition test, and a model cognitive assessment. The data were analyzed using SPSS version 21. The p-value of less than or equal to 0.05 was considered statistically significant. The results were regarding age distribution. Most of the patients comes under 31 to 40 years. Regarding sex distribution, males were 13, females were 12. According to educational status, most of the patients completed at least a primary school education. The location of the low-grade glioma: most commonly 10 patients were present with frontal lobe SOL. Regarding laterality, right tumors were 13, left tumors were 12. The mean dose of contralateral hippocampal Dmax was significantly reduced with the VMAT plan using hippocampal sparing, and also D mean values of contralateral hippocampus are also significantly decreased. The D mean consent given as contralateral hippocampus as 9 gray. These are the scores, neurocognitive assessment scores. The time point comparison between baseline and 1 month and baseline 3 months, there is no significant decline in neurocognitive function. But between the baseline and 6 months, there is significant decline in neurocognitive function assessment, even though the contralateral hippocampus is bad due to the ipsilateral tumor proximity and the location of the tumors. The neurocognitive decline happened even after 6 months. In the present study, the contralateral hippocampus was effectively spared in 21 patients. The patients with left-sided tumors showed pronounced decline in delayed recall scores compared to those with right-sided tumors. Tumors located in the frontal lobe and temporal lobes can cause subtle memory and executive function impairments due to tumor proximity to the hippocampus. This implies that occipital lobe and parietal lobe tumors, we can effectively spare the hippocampus. Among 25 patients, 4 patients were having decline in neurocognitive assessment after 6 months due to tumor proximity and location. In those patients, the contralateral hippocampus was more than 17 gray. Discussion. The recent development of radiotherapy techniques has made hippocampal sparing radiotherapy possible without compromising the target volume. In case of the ipsilateral hippocampus is close to target volume, we could at least spare the contralateral hippocampus by using VMAT technique. As expected, ipsilateral hippocampal doses were significantly higher due to tumor proximity. The dosimetric analysis validates the use of VMAT as a practical and effective approach to reduce the hippocampal exposure in low-grade glioma radiotherapy. The neurocognitive assessment showed promising results in preservation of verbal memory function. Memory decline was more pronounced in patients with left-sided hemisphere tumors and reinforcing the role of tumor laterality in neurocognitive assessment. In the present study, patients whose contralateral hippocampus was successfully spared generally demonstrated better memory retention, supporting the hypothesis that unilateral protection, especially of the dominant memory hemisphere, can meaningfully impact function. The dosimetric results in this study showed that while contralateral hippocampal doses were kept within threshold, the ipsilateral doses were higher, explaining the SWAN but significant decline in the neurocognitive functional assessment.
You are exceeding the limit.
My conclusion: the hippocampal sparing VMAT is feasible and effective strategy in the treatment of low-grade gliomas. It allows preservation of the contralateral hippocampus without compromising the target coverage. This correlates the better neurocognitive outcomes and particularly in memory domains. These findings support the integration of hippocampal sparing into the standard radiotherapy protocols for low-grade gliomas, especially in patients with favorable prognosis and long expected survival. These are my references. Thank you.
Questions, please.
What made you to include age 10 and above?
Between below 10 years, we can't assess the neurocognition, madam. I conducted four studies now for neurocognition. Less than 10 years, I can't able to do such studies now.
Then above 10 years, it depends on the child.
Yes, ma'am.
So we don't mix up children and adults in the study.
Most of the function tests are just about recognition and some patients may have a metallic prosthesis. That is the only contraindication. Otherwise, there is no contraindication related to the primary brain tumors.
What was the time duration from surgery to starting RT?
After post-surgery, within 4 weeks, we can take this. Taken the CT simulation. After 4 weeks, we started the RT.
So all of them started at 4 weeks?
4 weeks. 4 weeks.
Because your time to from surgery also is another contributing factor.
In different words, what are the ages of those 3 patients? 10 to 20 years?
Mostly 60 to 70, sir. Those with present with more.
Three patients you included in 10 to 20 years age. What are the ages of those 3 patients?
Sir, one patient present with 19, another one is 18, another one is 15, sir.
So then you would have moved to it's more than 14 years. Then this question would have not come. So it's confirmed. And consent is also a problem when you put below 18 or below 14.
The next. Thank you. This presentation is by Dr. Yukta from Sri Ramachandra Institute. Prognostic impact and therapeutic significance of C53 in carcinoma endometrial.
Everyone present here. Endometrial cancer is the second most common gynecological malignancy worldwide, recorded in 2020. The Indian incidence is 2.5 per 1 lakh women. Incidence is steadily rising, especially in urban areas. With the paradigm shift in adjuvant therapy of early stage endometrial cancer is due to molecular status role as a decision-making tool. So the current guidelines in stage 1 and 2 endometrial cancer, in stage 1, it's usually stage 1A, grade 1 and 2 observation, and in grade 3 vaginal brachytherapy is preferred. In 1B as well it is vaginal brachytherapy. In grade 2 and 3 we can consider EBRT, and in stage 2 EBRT with vaginal brachytherapy. With the role of molecular oncology in risk stratification, all of these patients move in into a high risk group in which they require more intensification of treatment. So as per the major molecular status that we look at is the pole mutation, MMRD, P53 abnormality and no specific molecular type. Pole mutation shows good prognosis due to the high tumor mutational burden, and in MMRD there's an intermediate prognosis, and P53 has been associated with poor prognosis. Why the specific interest in P53? P53 is a tumor suppressor gene which is mutation leads to genomic instability. Presence of a mutation warrants the intensification of adjuvant treatment regimens and increases the risk from low to high. This directly impacts the prognosis, treatment-related toxicity and quality of life of the patient post-treatment, and it can be easily analyzed by ISC. According to the recent updates, P53 status by ISC is the recommendation, and mutational analysis can be implemented when the IHC is equivocal. So coming to the background of my study, presently in India the detection and application of molecular tools is not routinely practiced in all institutes. The reasons can be both economical and technical. The present retrospective study is to analyze the prognostic impact of P53 status and its implication on treatment outcomes in stage 1 and 2 endometrial cancer. My primary aim is to analyze the disease-free survival of stage 1 and 2 endometrial carcinoma patients having P53 mutation who receive different modalities of adjuvant treatment. The secondary aim is to compare quality of life in the above-mentioned patient groups. So we have identified 21 P53 positive endometrial cancer patients, and they were retrospectively analyzed. These patients were taken from February to June of 2023. All patients had underwent a staging laparotomy, and the final specimen was microscopically studied. Based on the post-op HP and molecular status as well, adjuvant treatment was decided as per our institutional board protocol. Quality of life assessment was done at baseline, during adjuvant treatment, and 2 years post-treatment as per the Facton scale. And DFS and disease-free survival and overall survival was analyzed at 2 years. So we are taking 21 patients, all with endometrial histology. All underwent staging laparotomy, and as per the FICO 2009 staging, all patients were in stage 1 and 2. Patients were from all 3 grades. LBSI was negative in all patients, and these patients had P53 mutation alone. So, as per the conventional risk stratification, 4 patients were from 1A and grade 1 and 2. In the intermediate risk stratification, there were 10 patients from 1A grade 3, 1B grade 1 and 2, and patients from 1B grade 3 and from stage 2, there were 7 patients which were in the high intermediate risk group. The adjuvant treatment that these patients received in the low risk group was vaginal brachytherapy, in the intermediate was EBRT and vaginal brachytherapy, and the high intermediate, they received EBRT, vaginal brachytherapy and chemotherapy sequentially. As per the current molecular status and molecular risk stratification, all of these patients fall in the high risk category, and this warrants CT-RT for the treatment if they have been taken today. So, out of these 7 patients who received chemoradiation, 1 patient had died and failed distally at 16 months, and the rest of the cohort is alive without event. 4 patients, out of the 14 patients who received radiation, 4 patients received vaginal brachytherapy alone, and 4 patients are alive without event. In the remaining 10 patients who received EBRT, 1 patient died and failed distally 18 months, and the rest of the cohort was alive without event. So, the disease-free survival and overall survival of these groups, the patients who received vaginal brachytherapy was 100, and the patients who received EBRT was 90, and the patients who received CTRT was 85.7. So, we have taken overall quality of life analysis, and the patients who were receiving chemo across all domains tended to have a lower quality of life across physical, emotional, and functional domain. So, as per the current molecular risk stratification, all 21 of our patients needed chemoradiation. The 2-year disease-free survival of these patients, as I mentioned before, was 98.9, 85.7 and 100, and it was not statistically significant. However, the quality of life of patients was best in patients who had received vaginal brachytherapy alone and worst in patients who received chemoradiation. Not all stage 1 patients with the classical endometrial carcinoma with P53 mutation may need chemotherapy. The benefit of additional vault brachytherapy in these patients might have been the answer. So, I would like to take a case scenario. A 62-year-old lady presented with postmenopausal bleeding and had been diagnosed with stage 1A EEC and was grade 2 with no LBSI but had P53 IHC showing positivity. The guidelines recommend adjuvant CT and RT, but based on my analysis, patients with a given clinical background were treated with adjuvant vaginal brachy alone and are doing well with no side effects and comparably better quality of life at 2 years post-treatment. So the role of vaginal brachytherapy in high-risk endometrial carcinoma was not centrally evaluated. With the introduction of molecular risk stratification, there was always more emphasis on EBRT and chemotherapy. In endometrial carcinoma, patients with P53 mutation status, but with stage 1 and low grade, might not need intensification with chemotherapy. The minimum number of patients in the short follow-up are the limiting factors of this study. So we plan on conducting a RCT in these patients and evaluate our hypothesis further.
Exactly what Dr. Ram Madhan said yesterday. P53 alone as a test is of no use. You should do pole mutation rather than P53. Your study also shows that it's of no role. Thank you for the study. Thank you, Dr. Ram.
Exactly, I was going to ask that whether you have planned along with P53 pole and thymomas.
Yes, so we had collected the molecular list, all three. MMR status, pole and P53.
So you have ruled out pole?
Yes, sir.
MMR and
then evaluated only for P53.
Our next presenter, Dr. Anita Raj from MMC on Osteoradionecrosis.
Good morning, sir. Good morning, ma'am. Presentation is all about ORN, and the topic is Osteoradionecrosis in head and neck cancer patients, a single institutional experience. Osteoradionecrosis is the most serious orofacial late complication of radiotherapy in head and neck cancer patients and is defined as an area of exposed devitalized bone through an overlying skin or mucosa in the radiation field that does not heal spontaneously within 3 months in the absence of residual or recurrent tumor. Diagnosis of ORN is a combination of persistent clinical symptoms, confirmatory imaging findings, and history of prior RT. My objective is to evaluate the incidence of osteoradionecrosis in head and neck cancer patients who received radiotherapy for carcinoma of oral cavity, oropharynx, parotid, maxilla, treated in the year 2023 based on clinical symptoms and CT imaging. And this study also explores whether the recent ASCO 2024 recommended mandibular dose of Dmax less than 50 gray remains essential for preventing osteoradionecrosis. Coming to the methods. Among the 270 patients treated during the year 2023 for the above subsites were taken up for the study, and exclusions being death and loss to follow-up. A final cohort of 45 survivors were identified, and follow-up process was organized by tracking them over phone, inviting them for review, and detailed clinical history and clinical examination was done. And the CECT NEC was done for all patients, and based on CT imaging and symptoms, ORN was graded using Notanic grading of ORN, and risk prediction variables were analyzed with prime importance being given to tumor site, mandibular surgery, radiation dose delivered to mandible, and dental extraction pre or post RT. And this is a bar chart that depicts the distribution of tumor site among the study population. And coming to mandibular surgery, among 45 patients, 17 patients has undergone surgery, of which 7 patients undergone mandibulectomy, and out of the 7 patients, 6 underwent pre-RT mandibular surgery, and 1 patient underwent post-CCRT salvage surgery involving the mandible. And coming to dental procedure, all patients underwent pre-radiotherapy dental prophylaxis, with 28 patients have done dental extraction, and 17 patients have done dental scaling, and post-RT 5 patients underwent dental extraction 1 year post-RT. And this is the bar chart that shows the mandibular dose distribution among the study population. With 22 patients, they received more than 78 patients received more than 65 gray and less than 70 gray, and rest of the 2 patients they received more than less than 65 gray. And the mean Dmax of mandible in our study cohort was 69.31 gray plus or minus 48 gray. And coming to the prime essence of the topic, that is Notanic grading of ORN, which is based on anatomical boundaries. Grade 1 is ORN confined to alveolar bone, and grade 2 is ORN is limited to alveolar bone above the level of infraalveolar canal of
extends below the level of infraorbital canal with an oropetinous fistula or a pathological fracture. And with clinical symptoms such as pain, tooth mobility or spontaneous tooth exfoliation, and with the radiological signs of CT such as cortical erosions involving the buccal or lingual surface, often associated with bone fragmentation, has been included. This is a clinical image, OPG and CT imaging of a patient with nodanic grade 2. And this is a clinical image and OPG and CT image of nodanic grade 1 ORN. And coming to the results of the analysis, incidence ORN developed in 2 patients, with one having nodanic grade 1 and other one having nodanic grade 2 ORN. And going to radiation dose, mandible Dmax received by the grade 1 ORN patient was 73.015 gray, and grade 2 patient was 73.204 gray. And coming to the dental procedure, post-RT dental extraction was done in 5 patients after 1 year of RT, but within 2 years post-RT, among whom 1 patient had features of ORN. And impact of surgery, pre-RT 6 patients underwent RT involving 6 patients underwent pre-RT mandibular surgery, and 1 patient underwent post-CCRT salvage surgery involving the mandible. This 1 patient who underwent post-CCRT salvage surgery had the features of ORN. And location, the site of ORN in the mandible didn't correlate with the site of the max dose received in the mandible, and the mean time of onset from completion of radiotherapy was 23.25 months. And discussion, we followed Quantic guidelines with OR dose constraint of mandible as Dmax less than 70 gray in our institution. As per recent ASCO 2024 guidelines, a patient with radiation dose to the jaw of 50 gray or higher should be considered at the risk of development of ORN. But OR incidence in this cohort of 45 patients was only 2 patients, which was 4.4%. High risk was observed in patients who received more than 70 gray of mandibular dose and who underwent mandibular surgery post-RT and who underwent post-RT dental extraction. Though 22 patients received more than 70 gray and 21 patients received more than 65 gray to less than 70 gray for mandibular dose, only 2 out of 22 patients who received more than 70 gray had ORN features in CT imaging with mild symptoms clinically. Coming to conclusion, though all patients had a mandibular Dmax greater than 50 gray, OR incidence was minimal. This is likely due to strict dental prophylaxis followed in our institution. Hence, the feasibility of achieving less than 50 gray as per ASCO 2024 guidelines in Indian low socioeconomic patients with advanced disease at tertiary center warrants re-evaluation. Although 70 gray is the prescribed Dmax dose for mandible, ASCO 2024 suggests less than 50 gray to be the newer constraint for mandible. In a tertiary care institution of an Indian population, the need to restrict the dose to the mandible is open for discussion. Thank you, sir. Thank you, ma'am. These are all my references.
Was there a dental prophylaxis done for all of you?
Yes, sir.
What was the intervention you did for ORN? Once detected ORN, what did you do?
So we have referred the patient to OFM, sir. They have advised them good oral hygiene, antibiotics, and regular follow-up, sir.
Doctor, you were saying within, I think, 2023, it was conducted over a period of 2 years. So once that 45 patients, how many are asymptomatic for the OR?
43, sir.
43, how many are symptomatic?
Only 2, sir.
2 are symptomatic. So routinely you are looking for ORN, even though there are no symptoms, you are seeing.
So for this
particular study,
study, based on CT imaging,
we detected ORN in the CT images
for follow-up and for the response assessment.
What is the time have taken for the patient post dental and chest of starting radiation?
It's approximately 10 to 15 days.
10 to 15 days. Yeah.
Actually, it depends upon the nature of the disease. If that does not intervene with the outcome of the patient, we can wait up to 2 weeks as recommended, sir. But ideally, till the edema subsides, sir.
So at least you have given a week to 10 days time to start radiation. So how many, I think all these 45 receive same technique, or is there any difference in the technique?
Difference in technique is there, sir, but the patients who had one, they were both treated in 3D CRT, sir.
Okay. How many received IMRT in this case? I mean this cohort?
In this cohort, only 5 have received, 5 received IMRT, sir.
So among those 5, anyone has significant OR?
No, sir.
So what is the max dose received by the mandible in that scenario? IMRT, you said 50 gray is the thing we have to restrict. But in IMRT, what is the maximum tolerance dose received by this cohort?
In our study, 70 patients, more than 21 patients received more than 70 grays, sir. 21 patients received more than 65 grays.
No. You said correct only. But thing is that IMRT also, once you are going for a higher technique, the chances of getting ORN will be less. That is the thing I am saying, because your entire cohort, majority of the patients received conformal. Any 2D is there?
No, sir.
So also among these 45 patients?
Sir, 5 patients underwent treatment using IMRT, sir, and 16 patients they went using rapid RT.
16. So total 21 patients went. So in these 21 patients, how many had significant ORN findings on the follow-up CT scans?
No one had, sir.
No one had. So once you are going for higher end, so unlikely to get that one. I think that 50 gray tolerance to the mandible, I think we should rethink on that one. It's very difficult to go with only 50 gray, because oral cavity cancers, if not operable, we should deliver at least more than 70 gray. By using IMRT and VMAT, we can try to avoid. So once you are going for higher end, and the chances of getting ORN very unlikely.
Having a dose constraint of less than 50 grays is difficult.
So can we move on to the next speaker? Time up. So Dr. Bharat Kumar from Cancer Institute. Image-based vaginal brachytherapy.
Myself Bharat Kumar from Cancer Institute, and I will be speaking on image-based vaginal brachytherapy using multi-channel applicators in the management of gynecological malignancies. Brachytherapy remains a cornerstone in curative and adjuvant treatment of gynecological malignancies, especially in cervical and endometrial cancers. Traditional single-channel applicators, while widely used, are limited in their ability to conform to complex or asymmetrical tumor geometrics. In such cases, there is inadequate dose coverage or excessive normal dose exposure. Normal tissue exposure becomes a significant challenge. The development of multi-channel vaginal applicators has addressed this gap by allowing anisotropic dose distribution. These applicators enable differential loading at tailored dwell times to optimize coverage of irregular or lateralized lesion. The aim of the study is, this is an observational dosimetric study which aims to assess the feasibility of using multi-channel flexible catheters and to assess bladder rectal toxicities. An objective is to compare the target coverage and normal tissue doses when compared with single channel vaginal applicators. All patients with gynecological malignancies who required brachytherapy were included in this study, and this is a single arm prospective study, and study population total of 16 patients involving 24 sittings were included. This is a multi-channel applicators. This is a method is first CT scan is done to identify the tumor size, shape and location, and treatment planning. Oncologists and physicists design a 3D plan deciding optimal dose distribution and catheter placement. Applicator customization. Applicator is tailored to patient's anatomy, ensuring correct fit and stability. And channel configuration, catheters are inserted into multiple channels and placed in orientation to achieve precise dose coverage. Verification and adjustment, imaging is repeated with applicator in place to confirm positioning, and plan is fine-tuned before treatment delivery. And the second image is the multi-channel applicator, where multiple catheters are placed around that catheter, and multiple catheters are placed and held in position using an adhesive masking tape, which is made in-house. And the results are out of 16 patients, and 5 patients are in the age group of 40 to 49, and 4 patients are in the age group of 50 to 59.
and 5 patients in the age group of 60 to 69, and only 2 patients were in the age group of 70 to 79. And 12 patients out of 16 had histological parameters as commercial carcinoma, and 4 had adenocarcinoma. And site distribution, 8 patients like predominantly cervix, and 8 patients had vaginal carcinoma. And this chart shows the tumor volume coverage using both a single channel and multi-channel applicator, and the blue one is tumor coverage without catheters, and the orange one is the tumor coverage with catheter, and it is almost identical in case of tumor coverage using both single and multi-channel applicators. Then coming to the rectal morbidity, rectum doses, like when compared to the single channel applicator, rectum dose is quite less in most of the patients, and which is both almost in all patients, like it is less, and the significant p-value of 0.01, less than 0.01. Coming to the bladder morbidity, though it was not statistically significant, we could achieve a less dose when compared to the single channel applicator, which prevents like the bladder dose was less when compared to the single channel applicator. And this image shows the comparison between the use of single channel and the multi-channel applicators. Where the first image using single channel applicators, it's almost symmetrical, and second image, like we can just adjust the dose in order to adjust the position in order to reduce the dose to bladder and rectum. And discussion, multi-channel applicators provided improved dose conformity and organ at rest pairing compared to conventional single channel cylinders. The ability to differentially load channels allowed for dose escalation to high-risk target volumes without exceeding OR constraints, particularly to bladder and rectum. And this approach was beneficial in cases with asymmetric or irregular vaginal cuff anatomy, where single channel applicators may lead to suboptimal coverage. Acute toxicities were minimal and comparable to standard techniques, supporting the safety use of multi-channel use. And treatment planning flexibility was a key advantage, enabling adaptation to patient-specific anatomy and tumor extent. Conclusion. Flexible multi-channel applicators reduce bladder and rectal doses compared to single-channel applicators. Conventional vaginal applicators are fixed size, where multi-channel applicators can be customized to suit individual patient anatomy. They are simple to use, cost-effective, and practical for routine clinical practice, and provide better dose conformity and tumor coverage, improving treatment quality.
Nice presentation. I have 2 things. What was the distance between the vaginal surface and the midline of the catheter when you put the catheter in the circumference of the cylinder?
Sir, it was not standard, based on that patient,
you don't have to be standard, it's a good idea. But what was the distance? Did you measure the distance between the vaginal wall and the center of the catheter? You can work on this. It's a good idea, right?
Actually, it was around the vaginal cylinders with the flexible catheters. It was fixed into place by that adhesive tape. So what is in between the mucosa and the catheter was that width of the tape.
Yeah, that width, if you measure and do, you can still work out on very good dose delivery. Right? And what was the method you used to optimize your dose distribution in the volume, tumor volume?
So tumor volume, based on the
central random and
so it was almost.
I'll put it in a different way. Did you accept any hot spots in the? Did you accept any high dose regions in the vaginal walls? Which means like 150%, 140%.
No, sir.
Didn't measure. You can work on that.
Yes, sir.
And given an option, if you have an interstitial implant or a template and putting in these catheters, which will you choose?
Sir, this can't be an alternative to insert,
No, see, it is not an alternative thing. What you have done is a very good work, but given an option. See, it takes a lot of time sticking the tape, removing it, the catheters, placing and putting the cylinder to the tumor area in the vagina is a difficult task. So you are given an opportunity. You want to do a perineal template or a cylinder like this. Which will you choose?
But this is low cost.
This is low cost.
This is low cost.
Which will you choose? This one.
multi-channel catheters
supplied by the vendor. So probably I think you are doing it as a low cost thing. Two quick questions. One, you said tumor coverage. So what is how did you choose a tumor coverage? One. Second, what steps did you take to ensure that that cylinder doesn't rotate? Because everything you are assuming that the cylinder will not rotate, right? So usually when we put a vaginal cylinder without multi-channel, we don't think about that because we just tie some, gauze. So it doesn't prevent. So did you take any steps to prevent a rotation of that?
No. Prior to that, just based on the individual patient anatomy, just took that into consideration.
I assume that most of these are post-op or microscopic disease cases, right? So did you choose a vaginal length or something for a C endometrium or C cervix, whatever it is? That was. How did you choose this HRCT or CTP, whatever? That's okay. Ram, question was to him. Okay. So it's not, you're not defending his thesis or something, right? The question was to him.
See, you have to work on this thing.
Yeah, so it's not just dosimetry, right? You just don't compare the dosimetry. You have to think about all these things that you are doing as well. Good.
The next presentation is by Dr. Kamalanathan, Madras Medical College.
Good morning all. My topic is on concurrent chemoradiotherapy with the dose escalated CYMRT versus conventional IMRT in advanced upper and middle esophageal thoracic esophageal cancer patients. Background of the study, previous RTOG 8501 established 50-gray chemoradiation as a standard of care in inoperable esophageal cancers, but 50% had residual at 1 year. And this led to dose escalation studies up to 64.8 grays, but there was no survival benefits or increase in local control, and several deaths occurred in the high dose arm period to the patients reaching 50.4 grays. So, but these trials were conducted with 2D and non-CT based era, prior to the implementation of PET and more conformal techniques like 3D CRT and IMRT. And here we use ZIB-IMRT. It is the simultaneous integrated boost IMRT that allows for simultaneous delivery of high dose of radiation to the prostate while treating the high risk lymphatics with the lower doses, which has been shown to be effective in sterilizing the microbes. A primary objective of my study is to compare the local control of tumor in concurrent chemoradiotherapy with the dose escalated ZIB-IMRT and conventional IMRT in locally advanced upper and middle thoracic esophageal cancers. And the secondary objective is to compare the acute toxicities between these two arms. The methods, all the biopsy-proven carcinoma, both squamous and adenocarcinoma of upper and middle thoracic esophagus, eligible under the inclusion criteria were assigned into two groups and block randomized into arm A and arm B. All patients will undergo a diagnostic upper GI endoscopy and PET-CT assessment prior to RT as per STAN guidelines. And 10 cases were recruited in each arm and totally 20 cases were recruited. Inclusion criteria, all the HP proved squamous cell carcinoma of upper thoracic and middle thoracic esophagus, locally advanced from stage 2 to stage 4A, actually from T1B to T4A with the N0 or N+ disease and the non-metastatic disease. And policy of definitive chemoradiation taken by the multidisciplinary tumor board with no history of other malignancies, and patients who are deemed inoperable and also patients who are surgically fit but are not willing for surgeries. The age group was 80 to 70 years, and the exclusion criteria was the patients with deranged cardiac, hepatic and renal parameters, and patients who had undergone the induction chemotherapies and unable to tolerate or not cooperating at any point during the chemoradiation. The arm A, the ZIB-IMRT arm, they received a 50.4 gray in 28 fractions at 1.8 gray per fraction for the regional lymphatics, and with the simultaneous delivery of 56 gray in 28 fractions and 2 gray per fraction for the gross disease. And the arm B, 50.4 gray, 28 fractions at 1.8 gray per fraction per tumor and regional lymphatics. And all the patients received weekly carboplatin of AAC2 with a paclitaxel of 50 mg per kg. The toxicities were assessed weekly, and then at the 6 weeks and 6 weeks after completion of RT, followed by monthly assessment till 4 months using RTOG and CTCI guidelines. And the clinical response is done by using upper GE endoscopy taken at 6 weeks and PET-CT at 4 months after RT in both arms. The primary outcome in clinical response assessment is to compare the post-treatment with the pre-treatment upper GE endoscopy and the PET-CT for percentage of change in tumor volume and SUV max, and by using the RECIST criteria to compare based on CT between 2 arms. Results of my study. The distribution of the age and gender was similar in both arms, with the average age was 55 in control arm and 56 in study arm. And almost all the cases in my study were squamous cell carcinomas, and the grades were mostly, majority of them were moderately differentiated grade, and there is no difference between grade-wise difference between distribution in both arms. And then as per TNM staging, T3N plus disease were 3 patients in control arm and 4 patients in the study arm. T3N0 disease of about 6 patients in the control arm and 5 patients in the study arm, and 1 patient of T2N0 in each arm. The pre-RT SUV max was similar in both the arms, with the average of 13 in and the pre-RT PTV volume after contouring, it was around 36 in control arm and 37 in the study arm. All the patients completed full doses of RT in both groups, and only 50% patients in the study arm and 60% in control arm completed full doses of 5 cycles of chemotherapy. It was limited due to the hematological toxicities. The mean duration of completion of treatment was 46 plus or minus 10 days in the control arm and 47 plus or minus 9 days in the study arm. The OR constraints comparison, there is a slight increase in the heart mean dose in the study arm, but it was statistically insignificant. Only 1 patient has received more than 26 gray. Heart V30 was achieved, and it was averaged 12%, and the lung V20 and 20 gray and V30 gray were well within constraints. The post-RT change in PTV volume, the post-RT SUV max was 6 in both groups, and it is not statistically significant. The percentage of reduction volume, it is 56% in the control arm and around 78% reduction in the PTV volume post-RT in the study arm, which is statistically significant with the p-value of 0.024. And based on RECIST criteria, the control arm, 8 patients had partial response and 2 patients had stable response, and the study arm, all the patients had partial response. And
you're running out of time, make it fast.
And the most common toxicity encountered was leukopenia, which is 60%. And the radiation esophagitis, all the patients had grade 2 esophagitis, and none of the patients had more than grade 3 or more, and there is no radiation pneumonitis was observed during the study. And the discussion, the baseline data were similar between the both groups, and the pivotal finding was a statistically significant reduction, greater reduction primary tumor volume in the SBRT arm of 78%, while compared to the conventional arm, which is 56%, and is statistically with a p-value of less than 0.024. And the PET-CT incorporation improves the GTV delineation and facilitates the SBRT based on metabolic heterogeneity. However, the SUV mass has no significant correlation with the tumor. The most common toxicity was leukopenia of grade 1 with insignificant rise in grade 3 toxicity in the study arm, but it correlates with the number of chemotherapy cycles received. And the acute esophagitis, there is no grade 3 or more in both arms. There is no radiation, and all the heart mean dose and heart V30 were well within the constraints. There is negligible acute cardiac consequences. And conclusion, dose escalated IMRT is possible without significant increase in toxicities. And dose escalated SBRT with concurrent carbon based chemo is significantly improves the local control in patients treated with definitive chemoradiation. And the limitations, although we attained a significant reduction in tumor control, the sample size was not large enough for generalization of results, and there is no long-term follow-up, which should be improved by large RCTs. And the recommendations that should be large-scale multi-institutional studies and should be done to verify the statistical significance and assess the long-term overall survival and progression-free survival benefits. Actually, my reference was from Venkat et al. Study. It was a neoadjuvant chemoradiotherapy escalated up to 56th grade, and it was again done in TMH with TMH in definitive chemoradiation setting.
I have a small suggestion only. In one of the slides, you put post-RT PTV volume. You know, that's a confusing thing. PTV you get primary tumor volume.
It was no sir. Yes.
No.
Yes, it is GTV volume.
Post-RT PTV volume. No. PTV is primary tumor volume according to you. But in RT, it's a different thing. So don't put them in one slide because whenever you short something, please make sure what you do.
Sir, your SIP included your SIP included gross this boost, right?
Yes, a 0.5 centimeter margin from GTV was there.
So how do you get a gross disease in the esophagus? How did you contour? You don't get the gross disease, right? You get the gross length of it.
Sir, actually, we fused with PET. The GTV delineation was done using the PET, and the blooming in the PET is also included within the GTV.
Well, even PET, there will be metabolic active, inactive areas also. But how exactly you can draw a gross disease like any other site? Like in a liver or anything, can you draw exactly the gross disease?
Exactly not.
It's not possible. So probably gross length or something would be ideal. To boost for SIP and also.
So any literature suggests describing those to the esophagus
So there is no literature, Artigo studies, but they were up 60 gray and above, sir. All those literatures were 60 gray and above.
So how will you stage the esophagus? How will you stage the esophagus? What modality help you stage the esophagus?
So we use both the, actually for perfect T staging we need an endoscopic ultrasound, but it was not available in study. So mostly we concluded as T2 or T3 disease. So we use PET, and the gross thickening were more. So we cannot make it as T1. So we made it as T2 and T3.
So you said all patient in partial response, no patient achieved complete response.
Yes.
So how will you
suggest? Actually, it was comparison between the CT, sir. Few patients only post-treatment biopsy. Though there is a thickening in the CT, the biopsy came out as only necrotic tissue was present, but there is thickening in CT. So, this criteria was based on CT comparison only, sir.
Here, you quoted two PET regarding process, right?
Yes, sir.
What was the stricture weights in both the papers? See, it's such a esophagus really encountered a lot of strictures.
Yes, sir.
And it's a very difficult thing to handle post.
Actually, it was neoadjuvant chemotherapy which was escalated to 56 gray. And they underwent surgery, sir. They included patients who underwent surgery only, sir.
So that's
so
what
that's
because normally brachytherapy also when we used to give, we used to undergo a lot, and we used to encounter a lot of strictures, and we used to have perforations also, and we used to have T-waves. So I think you need to look at complications more than I think responsibles.
Yes.
Thank you. Next presentation is by Ajita Sri, Madras Medical College.
Good morning everyone, myself Ajita Sri from Madras Medical College. I am postgraduate here to present my paper on individualizing palliative head and neck radiotherapy using a survival score. So my primary objective is to develop and validate a survival score for patients with advanced squamous cell carcinoma patients who are scheduled for palliative irradiation. My secondary objective is to identify the key prognostic factors associated with 6-month survival in these patients and to evaluate the utility of the score in clinical decision making for tailoring individualized time-appropriate palliative radiation schedule. So, I would like to elaborate on palliative irradiation. So, palliative irradiation as defined by RTOG, it focuses on managing symptoms and improving the quality of life for patients with incurable cancer rather than aiming for a cure. It utilizes targeted radiation to alleviate pain, bleeding or other discomfort caused by the cancer, and it often involves fewer treatment and lower dose of radiation compared to curative radiation. So my study justification is advanced squamous cell head cancer patients ineligible for curative treatment receive palliative radiation for symptomatic relief. This heterogeneous population lacks validated survival scores for palliative irradiation, creating clinical need for practical prognostic tools to personalize RT regimens based on expected lifespan and prevent inappropriate treatment intensity. Optimal palliative RT regimens remain undefined, varying by different patient factors. So studies including quad-shot regimens, Christie regimens, Hyperfractionation and Pascoria regimens demonstrate bed ranges of 25 to 60 gray across different fractionation schedules. Our institutional protocol employs 3 palliative regimens, which includes 30 gray in 10 fractions with bed dose of 39 gray, and 39 gray in 13 fractions with bed dose of 50 gray, and 48 gray in 16 fractions with bed dose of 62 gray. Based on these findings, we used a comprehensive prognostic tool used in Mayo Clinic USA designed by Radis et al. To calculate the appropriate dose schedule with 6-month survival in the patient's group. So my inclusion criteria is patients with advanced squamous cell carcinoma of head and neck cancers and patients who are treated with palliative irradiation and with the patients with complete data available. And my exclusion criteria is patients without complete data and patients receiving curative intent treatment and patients with non-squamous cell carcinoma histology and patients with metastatic diseases. So, 68 eligible patients were reviewed and variables collected include ECOG performance status, pre-RT hemoglobin levels and primary tumor sites which are classified as oropharynx, hypopharynx, larynx and oral cavity with flora of mouth. The 6-month survival rate for each variable category was determined using patient survival data. Each category 6-month survival percentage was divided by 10 to create a factor score. For each patient, the score from these 3 factors were summed to generate a total score ranging from 8 to 15 points. So this is the factor score according to the variable respectively. The prognostic groups were divided into 3. Group 1, which is 8 to 9 points, comes under poor prognosis, and Group 2, which is 11 to 13 points, comes under intermediate prognosis, and Group 3, which is 14 to 15 points, comes under favorable prognosis. So this is the age distribution which clearly shows the majority of the patient comes under 41 to 60 years and the male predominance is more. So this is a bar graph for the patients who received 48 gray who survived more than 6 months, comes mostly under the favorable prognosis and some in the intermediate prognosis. And this is a bar graph which showed the patients who received 39 gray and who survived more than 6 months majorly comes under favorable and intermediate prognosis group rather than poor prognosis group. And this is the bar graph for the patients who received 30 gray and who survived more than 6 months comes under the intermediate prognosis group and no one in the poor prognosis group. So my statistical analysis was conducted using the Kaplan-Meier method and log-rank test. A p-value of less than 0.05 is considered statistically significant. So this is the RT regimen showing the patients who received 30 gray, none of them survived more than 6 months, and for the patients who received 48 gray, majority of the patients survived more than 6 months, which is approximately 92.5%. And my cutoff value of my score is less than 12 and more than 12, which has the accuracy of 77% and which has a significant p-value. So we have used binary logistic regression to compare the survival score and also the 6-month survival. With each 1 point increase in survival score, there is associated with more than twice the odds of survival. And we have compared multiple linear regression for variable RT regimens along with the survival score. With patients receiving 48 gray, there is average increase of 3.7% points increase in survival score, and the patients who received 39 gray, there was an increase in 2.74 points in survival score. So my conclusion is this tool supports individualized treatment planning, enabling selection of appropriate radiotherapy regimens based on life expectancy, and helps avoid both undertreatment in patients likely to live longer and overtreatment in those with a limited prognosis. Patients were stratified into 3 prognostic groups with significantly 6-month survival rates and median survival times, allowing physicians to estimate prognosis more accurately. So my future directions can be attempted on prospective study to avoid biasing, and it can also include factors such as tumor staging, toxicity profile, and various fractionation regimens in order to define an appropriate palliation dose. So these are my reference papers, and thank you.
Open for discussion. Any questions?
So what are the stage diseases are included?
So stage 4A and stage 4B with the other factors such as T4B, N2B, N3B diseases, and tumors with fungating mass, fistula, and patient.
So you divided 3 arms. So which arm you put? What difference you made?
Initially, we plan for the patients for the 30 gray and 10 fractions, and depending on the prognosis and performance status after the 30 gray, we proceed with the further fractions.
So what is your daily fraction?
3 gray per fraction.
Any more questions? Then proceeding to the next.
Palliative RT, once we are planned for palliative fractionations, we will try to cover only the gross tumor volumes. Thinking that, as you quoted, that life expectancy less than 6 months. But in your volumes, you said locoregional disease. You are contouring regionals also, I mean, not involved nodes also. Subclinical disease also, are you addressing your back?
No, sir.
No. And how you select oropharyngeal cases? Because oropharyngeal cases will have good response to RT. So how you select the oropharyngeal subset for palliative fractionations?
The patients with poor performance status and the poor complaints patients who comes with advanced diseases.
It's based on performance status. Yeah, okay, fine.
We call upon the next speaker, Dr. Karthik from Cancer Institute. It's a comparison of single fraction versus multiple fractions painful bone metastasis.
Myself, Dr. Karthik from Cancer Institute. I'm going to talk about the comparison of 8 gray single fraction versus 20 gray and 5 fraction RT in the treatment of painful bone mets. Bone mets are most common in the breast, lung, and prostate primaries. Bone is the third most frequent site of distal spread after the lung and the liver and the lung. The most common affected site include the vertebra, pelvis, ribs. The bone mets leads to skeletal related events which causes intractable pain, pathological fracture, spinal cord compression, hypercalcemia, and functional impairment. The pathophysiology of bone mets involves a complex interaction between the tumor cells, bone marrow stromal cells, and the bone microenvironment. This disrupts a balance between the osteoclast and osteoblastic activity, promoting the bone destruction or sclerosis depending on the tumor type. The management is multimodality, which involves the analgesics, bisphosphonates like zoledronic acid, and RANKL inhibitors like denosumab, radiotherapy, surgery, and systemic therapy. EBRT is highly effective with pain response rate of 70 to 80%. It acts through the direct tumor cell killing, reduction of inflammatory mediators, and stabilization of microfractures. My aim of the study is to evaluate and compare the clinical outcomes of 8 gray single fraction versus 20 gray and 5 fraction of external beam radiotherapy in patients with painful bone mets. The primary objective is to compare the pain relief provided by the 2 fractionated regimen using the visual analog scale. And secondary objective is to determine the change in the analgesic requirement post-treatment and to evaluate the need of re-radiation at the treated site and to assess the treatment compliance and tolerability in both the arms. Methodology: this is a single institutional prospective randomized 2-arm clinical study done with a sample size of 30, and the study population included the histologically confirmed primaries with radiologically evident bone mets. The inclusion criteria is age above 18 years, histologically confirmed primary malignancy with bone mets, painful bone mets with documented baseline pain score, ECOG performance status of 0 to 3 with radiation field, not involving less than 3 anatomical sites, no prior radiotherapy to the site. And exclusion criteria include the primary bone malignancy, spinal cord compression, prior radiotherapy to the treatment site, and surgical stabilization. There are 2 treatment arms. Arm A is 20 gray 5 fraction, and Arm B is 8 gray single fraction. The patients were alternately assigned to the either arm. Pain assessment was done using the visual analog scale before and after treatment. Pain response was categorized as no response, mild, moderate, or complete with more than 2-point reduction considered clinically meaningful pain relief. Results: there are 15 patients in each arm, and most of the primaries in my cohort were breast, lung, and the prostate, and some included from the GAG cervical cancer. and renal malignancy. And most common metastatic site is vertebra. The initial pain treatment score in each arm in arm A, most of the patient, about 70% has moderate pain and 30% has severe pain. And in arm B, about 80% has moderate pain and 20% has severe pain. And the analgesic requirement by the treatment arm, most of them require the strong narcotics like morphine in both arms. The radiobiological rationale for a 8-grade single fraction, the BED is around 26.9, and for a 20-grade 5 fraction, the BED is around 46.9. This graph shows the pain score trend over the time for RT. In 8-grade single fraction arm, there is a significant reduction in the pain score in the initial first week, but in the 5 fraction arm, there is a significant reduction only after the 2 weeks. But there is in the long run, the 8-grade, 20-grade arm showed a much pain control. The pain-free interval, the 20-grade arm showed a significant longer pain-free interval compared to the 8-grade arm with a p-value of less than 0.001, and it suggests more durable pain control with fractionated RT, and the analgesic requirement significantly reduced in both arms. And there is one patient in the 8-grade arm who received the re-radiation after 1 year of treatment. Both 8-grade single fraction and 20-grade 5 fraction are effective and safe in providing pain relief for patients with bone nets. The 8-grade demonstrated a faster pain relief, with most patients experiencing improvement within the first week, and this will be suitable for patients with limited life expectancy or logistical challenges. 20-grade, though require multiple hospital visits, provide a significantly longer pain-free interval. No acute grade 2 or higher toxicity are observed in both the arms. So both the options are both the treatment regimens is a viable option, and 20-grade can be considered in the patient with good performance status, better survival rate, weight-bearing bones, and better compliance. And 8-grade can be used in a patient with poor performance status, limited life expectancy, logistical constraints, and rapid pain relief. And so the treatment choice can be individualized based on the patient performance status, prognosis, logistical access, and patient preference.
Questions, please. And did you assess the progression of the disease subsequent to your pain relief? Since you said vertebrae was involved, did you assess the progression? How was the progression of the disease?
Only the pain thing.
How many patients required the re-radiation with your 8-grade arm? How many patients required re-radiation following 8-grade? How many?
One.
Only one patient. At the interval of?
11 months.
11 months. Okay. What was the primary for that patient?
GAT.
GAT with vertebral secretaries. Okay. Which primary injury? Pancreas. Okay. Okay,
thank you. Last paper, Dr. Kanuri Asha from Ramachandra Institute of Higher Education.
Good morning, I, Dr. Asha from Sri Ramachandra Medical College. I am here to present my oral topic on precision and Gier fractions redefining standards in prostate cancer. Prostate cancer is second most common malignancy in world, being most commonly seen in age group more than 65 years. It has management of prostate cancer has multimodality approach, but in intermediate and high risk prostate cancer, radiotherapy plays a major role. Over past few decades, conventional radiotherapy has been the gold standard, but however there is increased interest towards the hyperfractionated RT. This is due to its low alpha by beta ratio, which means a large dose for fractionation enhances tumor control without increasing toxicity. Aim of my study is to compare recurrence and toxicity between moderate and conventional hyperfractionated RT. My primary endpoint is biochemical recurrence-free survival. Secondary endpoint is outcome quality of life outcomes using IPSS score, GI and GU toxicity based on RTOG grading. Coming to treatment protocol, we have taken 18 people and divided equally into 2 arms. All patients received androgen deprivation therapy and radiotherapy according to their risk stratification. Coming to methodology, 18 patients were retrospectively analyzed in a time period between 2022 to 24 in our institute and are divided into 2 arms. Moderate hyperfractionated arm, people received 70 gray in 28 fractions, whereas conventional arm people received 80 gray in 40 fractions. Inclusion criteria, patients who were diagnosed with adenocarcinoma of prostate with WHO performance status 0 to 2, including intermediate and high risk categories. Radiotherapy planning, patient is kept in supine position, pelvic thermoplastic mold is used for immobilization, planning CT image was taken following bladder protocol. Daily CBCT image has been taken and we have delivered our treatment with the PNI. Coming to contouring guidelines, in conventional RT, whole pelvis received 50 gray. Prostate with seminal vesicle has received extra 10 to 20 gray, while prostate has received extra 10 gray. In hyperfractionated arm, whole pelvis received 50.4 gray in 28 fractions. In the case of nodal positivity, up till 56 gray, and prostate with seminal vesicles has received 70 gray in 28 fractions. Coming to patient characteristics, 55% of the patients in the both arms came under the group of 60 to 70 years and 44% in 70 to 80 years. Baseline PSA, in the majority of people it is more than or equals to 20 nanogram per ml, 88% in the conventional RT and 66% in the hyperfractionated RT. Coming to risk stratification, 55% in the conventional RT are in high risk and 44% in the hyperfractionated RT came under very high risk group. This is the biochemical recurrence-free survival graph comparing between hyperfractionated and conventional RT. Hyperfractionated had 100% recurrence-free survival, whereas conventional RT has 89% recurrence-free survival. Toxicity were compared at 3 months, 6 months and at end of 15 months. Coming to gastrointestinal toxicity, majority of the patient had grade 0 and grade 1 toxicity with no acute or late grade 3 or grade 4 toxicity. Coming to genitourinary toxicity, majority of the patient had grade 0 and grade 1, but one patient in hyperfractionated RT had grade 3 toxicity at the end of 15 months. This is the quality of life compared with IPSS. 1.78 in the hyperfractionated RT arm and the mean value is 1.33 in conventional RT arm. This is the IPSS score we have used to calculate the quality of life. Coming to discussion, moderate hyperfractionated RT yields biochemical control comparable to the conventional RT without increasing significant toxicity levels. The findings are consistent with existing literature like CHIP Hypro and RTOG 0415 trial. This study supports the growing pattern of shift in prostate cancer radiotherapy towards hyperfractionation. Hyperfractionated RT is non-inferior to conventional RT in intermediate and high risk group. That is what my study conclusion, which showed no similar biochemical recurrence-free survival and similar toxicity compared in both the groups. These are my references. Thank you.
You don't have any, doctor, you don't have any Indian study to compare?
That is what we adopt actually now.
You can even hypofractionate and follow PAW-PARTY protocol by Veda. 72 gray, 23 fractions. it gives equivalent results. And intermediates, you can even hypofractionate and follow chip protocol. 60 grain electronic fractions. So I think even you can even more hypofractionate because it's a low risk disease. I wonder why you still practice 80 grain 40 fractions.
Retrospective analysis, sir, which is followed
So now
in
you're
our
following only
institute.
72.
17. Now we have started ultra hypofractionation, sir. With 36.2 grain 5 fractions, we have started ultra hypofractionation.
You call it SBRT.
Yes. Yes.
Thank you.
What were the gastrointestinal and genitourinary toxicities you have analyzed?
Most of them had grade 0 and toxicity.
Which gastrointestinal toxicity?
They had increased bowel movements. Most of the patient had loose stools, ma'am.
Okay. Genitourinary?
Genitourinary increased nocturia they have, and pain during micturition and increased nocturia.
Do you have scores for pain during micturition or DIBH scores? Toxicity. You have mentioned some grade 1 and grade 2 toxicity, no? So which RTOG toxicity grade you are mentioning about? The genitourinary complications.
Grade 0 1, ma'am. Only one patient had grade 3 toxicity on follow-up. Patient came with the hematuria.
So that was a very enthusiastic participation from all the postgraduates. Congratulating all of them for their very active participation. And all the judges and the participants, they have questioned them thoroughly so that all our doubts are getting clear. Thank you for that.
Thanks to the organizers for giving us the opportunity to judge these lovely papers.
We now conclude the session with giving mementos. We call upon Dr. B. Antoinette Mary Nithya Ma'am, Madras Medical College, and Dr. S.P. Srinivas Sir, Kaveri Cancer Institute, Trichy, to felicitate the judges. Judges Dr. Sajjad Kumar Sir and Dr. Satish Babu Sir. Call upon Dr. Devnayaram Sir to felicitate the chairpersons. We move on to the next session, paper presentations for faculties. When experience meets evidence and academia meets action, you know the papers are going to pack a punch. We are about to hear from a lineup of faculty so sharp, even their PowerPoints have citations. And to chair the session, we welcome Dr. Sudhakar, Blessing Cancer Center, Kanyakumari.
morning to all. For the past 2 days, a lot of scientific programs are happening. To add more and more things, now it's a unique program, but we have expected more presenter for these faculties. But unfortunately, I feel there is no competitions. So my work is very simple. So now I welcome the presenter.
Good morning, everyone, and respected faculty. I want to present our work regarding MRI-guided CT-based volume planning for brachytherapy, an approach for dose escalation carcinoma. So we know that CTRT is the standard of care for locally advanced disease. But point A, if you are planning for a point A disease, point A based brachytherapy, we often miss residual disease, and we may not able to escalate dose to the residual disease. So from embrace, we know that if you are able to deliver more than 85 grade 2 CTV, HR, D90 and more than 95 for residual disease, the local control, 3-year local control is more than 96%. When tumor volume is less than 36. So even IBS, Jacastro, CT based contouring guidelines, they gave 4 environments for dose escalation IGABT. So we took one of those environment, a pre-BT environment using an MRI just before the brachytherapy, and taking the information from MRI and contour those things onto the CT to escalate the dose for GTV residual. It is different. We know that MRI brachytherapy is the gold standard, but there are a lot of resource constraints. We may not have MRI at our center, or like we may not have the brachy suite in the same MRI building to do an in situ planning. And also, as ma'am was rightly quoting yesterday, it needs a lot of work to take an MRI in situ and shift the patient again for the planning. And so we did a pre-brachy MRI and see whether it was feasible enough to escalate the dose to the residual disease. So we took 56 patients, still stage 3C2 were included, and we took a pre-brachy MRI just 2 to 3 days before the brachytherapy. And the day before the brachytherapy, we saw the volumes, AP, mediolateral and cranial caudal, and we took diseases confined only to the cervix, because we are only having the intracavitary applicators as of now. So we draw the volume on it, the GTV residue and the CTV HR, and the same thing was transferred on the next day when we took a CT with the applicator in situ. So we wanted to see whether we were able to escalate the dose to CTV HR and GTV residue, and we also compared it with the point A based volumes. This is our patient characteristics. Most of the patients are 2B and 3C1, and we delivered close to the 40 patients. We delivered para-aortic node, and half of the patients received para-aortic node boost also. And at 3 months, we saw 51% has complete response. 1 patient progressed, 1 stable disease, 3 still in regression. This is an ongoing trial, and we are able to deliver more than 50%, 5 cycles of chemotherapy. So this is what we did, and this is a small volume disease. We took an MRI, and we are not registered with planning CT, because planning CT has a tandem and it doesn't have, so it cannot be directly registered and contoured. So we did it on it, and we measured the volumes, and we did the same thing. We transferred the same thing onto the CT and matched those volumes, whether the same volume we did it on CT. So this is for a small volume disease. This is for a large volume disease. If you can see, there is a uterine extension also upper level. So if you follow the Jacastro thing, if you take only the lower 2/3 of lower two-thirds of the uterus as a CTV-HR, when we are doing a CT-based planning, we might miss this kind of tumors which has long extension into the upper uterus. So you can see this, we were able to push the dose to DTV-HR close to 109 gray and CTV-HR close to 86 K, which is what similar to the embrace has achieved, and with a limited toxicity. So this is and we were So we were able to achieve what embrace has achieved with the just pre-breaking MRI. So so the strength of the studies is it may suit for low resource settings, and we were only able to achieve residual disease confined to cervix, but because extensive disease needs an hybrid applicators with interstitial and intracavitary. So in first few cases we are struggling to contour on CT, but after some 5 to 6 cases we were able to do that. So in conclusion, MRI before just brachytherapy is a practical workaround to enable target dose escalation to GTV-HR and GTV residue and CTV-HR, especially in a resource limiting settings. Yeah, these are our references, and thank you.
What is the maximum dose you have escalated to the point A?
Point A we were able to achieve 80 grays, sir.
How much?
80 grays. Because this is a small volume disease, we were able to achieve 80 gray to this. But if the volume is more than 4 centimeters or something, then we might need to to give that dose, we might need to come down on point A, sir.
You expected any difference in toxicity between these two?
No, sir. No, sir. This because we have taken a small volume disease, we have not seen much, sir. We wanted to see the feasibility whether this pre-brachytherapy MRI can help in dose escalation or not. So we need to see these things in the same setting in a high residual disease, high residual setting also, sir.
Because your pre-brachy MRI is without applicator and your CT based is with applicator, and did you do any contrast to delineate the uterine vessels to make out the cranial most extent of the HRCT?
No, sir. No, actually we measured the craniocaudal extent in the MRI and we tried to replicate the same on the CT. And as you said, there is a little discrepancy, but we were able to do that. AP, bilateral and craniocaudal we collected, and the volume also we have collected. We tried replicating the same thing onto the CT. When we contoured, our CT volumes were matching close to 24 cc on both CT and MRI, 24-26.
And again for large volume HRCTB disease, like how far can you escalate the dose in the volume without violating the OAR doses? Because it becomes difficult since you are doing optimization only with an intracavitary applicator. You have it is much of a limitation, right? So how far could you escalate the dose to the HRCTB in large volume HRCTB?
So I have not kept those cases. We have tried some 5 cases freehand needles lateral to the ring and the ovi with 2 needles lateral to push dose to that areas when it is parameter mesial work. But that is not scientific.
It is not included in the study, maybe.
We have not included those patients.
And it is by freehand needle.
Freehand, because we don't have the intracavitary interstitial hybrid applicators. Ideally, for those cases, we should go with intracavitary and interstitial.
Exactly. Okay. Thank you.
Are there any more questions?
Based on the pre-brachy MRI upper extent, you will always make sure that is covered. Before that, we will little bit we will extract control and we will make it.
Thank you, sir. We now call upon Dr. Devanayagam sir to felicitate the chairperson. Let's kick off with our first talk of the day that explores prophylactic cranial irradiation in pediatric leukemias. We welcome Dr. Venkatesan, Salem Medical College, Dr. Sivakumar Ganesan, Royal Mitra Medical College to chair the session.
We would like to welcome Dr. Patricia Manu, Professor, Department of Radiation Oncology, CMC Vellore, for the talk. Please enlighten us, Madam. Thank you.
Yesterday morning, Dr. Vasan started off so much saying we should be radiation oncologist, and today I am here to advocate against radiation. Do not throw stones at me. So I wonder why this topic was given. So let's look at prophylactic cranial irradiation in children in leukemias. So I would like to just go through these topics. We know ALL is the most common cancer of childhood and it is curable disease. Most of them live into adulthood. And CNS disease in them is also very prominent. It's seen like 3 to 4% at diagnosis. And if you do not give CNS directed prophylaxis, almost 30 to 50% have CNS relapse. And if you give, you still have CNS relapse of 2 to 7%. So CNS disease, we all know how it is looked at. CNS 1, 2 and 3. CNS 3 is positive, CNS 1 is negative, CNS 2 is you're not sure. We know why CNS disease is so common in these ALL because of the blood-brain barrier. We know that's one of the sanctuary sites along with the testis and retina. Along with blood-brain barrier, there are other barriers in the brain, blood-CSF barrier, brain-CSF and the CSF-brain barriers. And so the microscopic disease in the brain is not being able to addressed by the systemic agents because of the poor penetrance into the CNS, and so you have increased CNS relapse in these children. When we look at the phases of treatment in ALL, it's a long treatment, almost 2 to 3 years of treatment, but CNS prophylaxis is very important. It comes right in the beginning, soon after the induction. And we know that they are risk stratified, and this is a risk stratification as standard, intermediate and high risk. In the past era, we were giving CNS prophylaxis as prophylactic cranial irradiation for intermediate risk and T-cell intermediate and high risk disease. But now we have other methods for CNS prophylaxis. What are the other methods? We have intrathecal chemotherapy, we have high-dose systemic chemotherapy. And prophylactic cranial irradiation, yes, is one of the methods to eradicate the disease, microscopic disease, which is not really demonstrable, and to prevent the CNS relapse. But if we look at in our population, this is Indian data where cure for these patients have drastically increased in the past decades. And I want you to look at this. In the 80s, cranial RT was one of the treatment for cranial prophylaxis. But in the last decade, no cranial RT. No cranial RT is very clear because systemic agents have taken that role and been able to reduce the CNS relapse. I want to just tell you, even though we have intrathecal therapy, cranial radiation is always better because intrathecal therapy is not distributed evenly in the CNS. They do not go to the ventricular spaces, they do not go to the sulci, but our radiation can reach all these spaces. Then why is radiation not given in these children? Radiation is very minimally used these days for prophylaxis, mainly because of the side effects, long-term side effects. They are all going to be cured and they live into adulthood. You're going to give them neurocognitive decline, endocrinopathy, second cancers. Whereas when you do the high-dose chemotherapy, when you do the intrathecal chemotherapy, you have equivalent results in reducing the CNS relapse. So this is the first meta-analysis that came up in 2016, which studied 16,000 patients. It's from UK, and they demonstrated that when they looked at all the major studies, BFM groups, UK and St. Jude group, COG group, all the studies, when they looked up, the incidence of CNS relapse was almost same when you used cranial prophylaxis by using radiation and other protocols which did not use radiation for cranial prophylaxis. So they concluded saying cranial RT does not impact the risk of relapse in children with ALL treated with the current protocols, the contemporary therapies where you have a lot of systemic therapies. And these are the agents that really made the difference. High-dose methotrexate, citrabine, nilarabine has made really a huge difference in UK. Then this Bilateral and intrathecal chemotherapy when you really tailor it according to the CNS risk. So this is St. Jude. They have come up with total therapy study 16 where they could add on systemic therapy with nilarabine and they could reduce the CNS relapse to just 1.5%. It's both isolated and combined CNS relapse, which is very, very less compared to the previous studies. And when you look at the other studies also, CalGB and MD Anderson studies, they also with their increased systemic therapy, they could reduce the CNS relapse, and these relapses are much less than those regimens which included radiation as cranial prophylaxis. So now UKALL gave their interim guidelines in 2019 where they said no patient with ALL will receive cranial radiation, not even CNS positive patients. Even CNS positive patients they could manage with systemic treatment, and mainly nilarabine has made the difference in this protocol. This is the Indian protocol, iCycle. This came up in 2014, and if we look at the indications in iCycle, they also do not have indication for prophylactic cranial radiation. It's indicated only in CNS 3 disease, and that too if it is persistent CNS disease. That is, even after intrathecal therapy, high-dose therapy, if the disease is not getting under remission, then you give cranial radiation. So the primary role of radiation in management of these CNS leukemia is at relapse for CNS positive and for palliation of symptoms. What happens in our institution? We still give prophylactic cranial RT for very few subgroup, and that is the group where
in our resource constrained settings, we are some of the patients may not receive the adequate systemic treatment that is advocated in the protocols. So if they have not received the adequate systemic treatment, if intrathecal also was not completed, those are the patients case to case basis we select and we give the prophylactic cranial irradiation. No routine prophylactic cranial irradiation in our institution. And the boost prior to transplant also, papers are there that there is no need for boost prior to transplant, but we again select patients if CNS relapse risks chances are high, we boost them prior to transplant. And CNS3 disease, if chemorefractory, we definitely give therapeutic cranial artery. So coming to when you give cranial artery, what are the target volumes? ILROG has come up with very good guidelines in 2018. So one we all should remember, even today our registrars make mistake here. So registrars, please concentrate. If you give cranial artery, you should never make this mistake. The cribriform plate is always missed. Today, even today, I pick this up every time. Cribriform plate is missed. Look at the position of cribriform plate. And temporal fossa usually missed. So never miss this when you give cranial artery. We should remember that leptomeninges and spaces that harbor CSF have to be treated. So never miss the posterior third of the globe, cribriform plate and middle temporal fossa. When you shield, you tend to miss these places. When you give conformal, make sure you that all the meninges surrounding the optic nerve and the posterior retina orbital apex is also included, and all the foramina are included and they are not missed. Make sure these foramina are included in your, it looks like a very simple target volume, whole brain and treat, but you have to make sure these things are not missed. And this is a dose distribution. So technique, VMAT actually has no advantage over 3D CRT in these patients. Just to oppose fields, but make sure it's 4 to 6 MB and don't use higher energy. Reduce hotspots by using field and field. And if you give craniospinal radiation, this is usually practiced in adults, more than 40 years, you tend to prophylactic cranial artery, and in that case, craniospinal is more advocated, and in that case, protons have a role. Hippocampal sparing can we do in these patients? I would say no, but there is no data because we are trying to take care of the disease which is there anywhere in CNS, anywhere in the brain. So I don't think the hippocampal sparing came up in brain mets, where we know that surrounding the hippocampus the incidence of brain mets is low, and that is why you started sparing. I don't think you should spare here, but there is no data on it. And coming to the dose, in case you have to give prophylactic cranial artery, do not give for less than 3 years. But in case you need to give, if it is less than 2 years, even if it is CNS positive therapeutic, you have to give, limit it to 12 gray. And if it is more than 2 years, then you can go up to 18 gray in therapeutic, otherwise 12 gray in 8 fractions, 150 CGY per day, as opposed to adults, 18 gray prophylactic and 24 therapeutic. So coming to the toxicity, the acute is just fatigue and alopecia and pharyngitis, but the chronic are the notorious ones. We have neuropsychological issues, they have their school performance reduced, they have a learning issue, memory issue, neuroendocrine issues, growth hormone because pituitary gets irradiated, hypothyroidism, so growth issues are there, autotoxicity, leukoencephalopathy. So to reduce chances of leukoencephalopathy, timing of radiation with systemic therapy is very important, especially agents like methotrexate. If you have given, you should wait at least for 2 weeks, and if it is an emergency, at least 48 to 72 hours. Second malignancy, of course, cataract and delayed dentition. So these are the long-term effects of cranial irradiation in children. So to conclude, there is no role for prophylactic cranial irradiation in children if adequate systemic treatment and intrathecal therapy can be given. Therapeutic cranial radiation definitely is indicated only in CNS relapse patients, not in the upfront cranial positive disease. Palliation, of course, to reduce symptoms. So prior to CAR T-cell therapy, there is a gap for systemic treatment, and in that gap, if you can bridge it with radiation, these are thoughts coming up. So maybe there can be an emerging role for prophylactic cranial radiation in this setting where you are considering CAR T-cell therapy for bridging it. And adding memantine and seeing that where a neurocognitive decline can reduce is another thought. So these have to be studied. Thank you.
Thank you, ma'am. Thank you for your excellent presentation. I have a query, ma'am. Like post PCA, if there is relapse is less, but if there is serious relapse post PCA, is there any role for re-radiation?
Yes, because you have used very less dose in the first sitting. It's 12 to 18 grain. Whole brain you can give up to 45. So we do re-irradiate if we have given and still there is a relapse.
Thank you. Any questions?
Ma'am, since when you are following this in CMC Vellore, you have any number of patients with respect to this?
The prophylactic?
You are avoiding this prophylactic cranial irradiation.
So it's last almost like 5 to 8 years we have started avoiding prophylactic cranial RT, but we still give, as I said, in some, like many adolescents especially, they do not complete the maintenance at all. So if we are doubtful of such children, if we are doubtful that they will not complete the therapy, if they have not been able to take the therapy because of complications, they have not taken adequate systemic, we still give them. So that's where we differ from the guidelines.
Thank you.
For this enriching and informative talk, we now invite the chairperson to honor the speaker. We invite Dr. Devnayan sir to give memento to the chairperson. We now move on to our next session, a panel discussion on the management of recurrent endemic cancers. We invite Dr. Ambedkar Yadala, RCC Jifla, and Dr. Vedavan, Erode Cancer Center to chair the session.
Morning all. Already we are running time late. So this panel discussion is on management of recurrent head and neck cancers. I will call upon Dr. Ashwin A.N. from Kaveri Hospitals to do the moderation work, and I request Dr. Ashwin to stick on time and the panelist will be announced by Dr. Ambedkar.
I now request panelists to come on to the dais. Dr. K.N. Srinivasan from GVN Hospital, Trichy. Dr. S. Soumya from Cancer Institute, Adyar. Dr. Gunashilan, RCC, Jipmar. Dr. Priyadarshini, MIAT, Chennai. Dr. Muthaya from Coimbatore. Dr. K.C. Jyotish, MMC. Dr. Amudan, surgical oncologist from Concurrent. Dr. Balaji.
Can you start? Good morning. One and all present over here. I would like to extend my thanks to AROI for giving me this
Dr.
wonderful
Balaji
opportunity. Balaji. In the interest of time, I would request the audience to ask the questions at the end. So let me stick on to the timing. So before that, we'll pray to God in Vaginal style, and then we'll start the session. So we know that the head and neck cancer is the 6th most common cancer globally, which is accounting for 30% of all cancer cases in India. And the risk is 1 in 33 for males and 1 in 107 for females. And Northeast India has high incidence. As we all know, the tobacco and alcohol are the most common positive factors. So all the treatment like combined modalities, surgery, radiation as chemotherapy, they afford the 5-year overall survival rates around 50 to 60%, and nearly 40 to 70% of the patients develop recurrence within 2 years. This is data, and 70% of the tumor volumes are either marginal or infield recurrences only, and history of chemo and radiation may contribute to the therapy to the resistance of the recurrences. So what are the risk factors which are associated with the recurrences? Anyone from the panel?
The classical TNM.
Yeah.
The higher the T, chances of recurrence, higher the N, chances of recurrence, and again, post-operative setup, the extranodal extension, perineal spread, all of them are very high risk.
Excellent. Higher staging. If we go to the advanced stage,
surgery, margin positivity.
Margin positivity, yes. And for RT treated cases, it is the treatment interruptions which we are because of due to either it could be due to RT like mucositis and other stuff, or it could be due to hematological toxicity related to chemo. And there is 3.5% of annual growth in the risk of second tumors. This is what the study says. So we'll go to the case scenario. 3 case scenario I'm going to tell you right now. It's like a thriller movie. I'm going to tell the initial thing, and then we'll conclude at the end, and there is a twist in the end as well. So how many of you have watched this? This is out of the subject. This movie, homicide in, yeah, like that. I have put 3 cases. First case, a 68 years old male is a teetotaler with no known comorbidities who is diagnosed with a case of CA oropharynx T2N1M0, who was treated with CGRT in 2011. Total time was of 63 RT plus 3 cycles of CDTP at an outside hospital. He came to us on follow-up. He actually came to us for follow-up only. He was diagnosed with growth in the left upper alveolus, and biopsy was suggestive of squamous cell carcinoma, and PET CT suggestive of growth in the left upper GB sulcus and left paratracheal node. FNAC from the paratracheal node was negative. This is the recurrence. So just keep that in the mind, and then I'll come to that later. And this is second. HPV was not done. So this is 67 years. The first is a synchronous, metachronous primary, and second is a residual disease. 67 years old female with systemic hypertension as comorbidity. She was diagnosed as a case of carcinoma hypopharynx T3N3BM0. Status post CTRT 2022. Completed in September 2022. 66 gray RT was given to the primary and the important node plus 6 cycles of cisplatin with neversuban. This is the radiation portal, dose distribution. And first follow-up, scopy was normal and no nodes were actually palpable. And during the second follow-up, she had right level 2 node which was clinically palpable, and for which CT has been done, which shows right 2 level nodal mass which was encasing the carotid artery, and it was seen by the surgical oncologist for salvage and deemed to be inoperable. So this is the mass which is encasing the carotid artery. And third hit. 53 years old male, this patient was also treated outside and came to us. 53 years old male was diagnosed with carcinoma of right buccal mucosa in 2022. Status post RT-CT to the right cheek and right neck, completed in July 2022. He was on follow-up. PET-CT in 2023, it showed a metabolic active lesion in the left cheek with active left submandibular node, and biopsy was positive. He was given 3 cycles of neoadjuvant chemotherapy outside, and PET-CT in August 2023 was suggestive of progressive disease with appearance of lytic lesion in the sternum, metastatic. So status post RT-CT in 2023. He completed RT-CT in October 2023. He developed a stridor on follow-up in January 2024. He underwent tracheostomy in our hospital, and PET-CT in Jan 2024 was suggestive of lesion in the bilateral buccal mucosa with bilateral level 2-3 nodes and subcutaneous nodules, and increase in the lytic lesion in the sternum, and left first costosternal junction with left pleural metastasis. So first case is a metachronous primary, second is a residual disease, third is a metastatic disease. So this is the PET-CT images showing the bilateral cheek cancer with cutaneous nodules. So we'll keep these cases aside, and then we'll come to that little later how we managed. So what are the factors to be considered before salvage? Anyone? DFS.
First treatment and the second
disease-free interval.
Disease-free.
Yeah. Any other factors? Performance status. Performance status. Excellent.
What salvage options we have got? Whether we have got a proton.
Okay.
Involvement of vessels.
Involvement of vessels. Excellent.
What is it?
Yeah.
What is the present staging? What is
current staging?
Present staging and how the disease has progressed?
Yes.
The time interval DFS is the most important.
So actually the two main prognostic factors is the DFS duration between the first treatment and the second recurrence, and the volume of recurrence now. So larger the volume, or with again an oral disease, is going to be difficult for salvage.
Yeah.
So as discussed earlier, there will be patient-related factors as mentioned earlier. Age, what is the comorbid status, ECOG status of the patient, right? And we come to the treatment-related factors, the dose, total dose of the radiation that was given earlier, whether it was surgery done earlier, and what are the even the T stage and the location of the tumor that plays a major role, whether it is in a location where it could be salvageable. For example, if it is near great vessels or any portion where it is very close to the bones, so that will make us decide whether it could be salvageable or not.
What were the toxicities patient has undergone previously, and what are the residual ongoing toxicities?
And the histology, the change in histology.
Excellent. Second tumor, second malignancy. So it can be divided like absolute and relative contraindication. It can be divided into patient-related factors like three panelists had mentioned: age, comorbidities, general condition. If the general condition is not going to be good, and smoking and alcohol history, whether we need to ask whether the patient is still continuing, because it is going to affect the prognosis of the current disease as well, and whether the patient needs an organ or function preservation, whether what the patient desires, and social support structures, financial support, and most importantly related to the disease related factors, disease-free interval, site of recurrence, primary, whether it is local or loco-regional, and presence of metastasis, whether it is oligometastasis or stage 4C, multiple metastases are there, and current stage and histology related to the treatment related factors. What was the previous treatment given? For example, if it has been like chemoradiation, salvage surgery can be done. And the toxicity from the previous treatment, because the patient has been challenged with cisplatin and more than 200 milligram per meter square has been reached, and patient is having phototoxicity, nephrotoxicity or something like that, then it warrants to stop the further platinum based regimen. And then what are the treatment options right now which are available? Yes. And what is the significance of disease-free interval? Anyone?
If the disease-free interval, say less than 12 months or more than 12 months, it has direct implication on the survival and local control factor also.
Okay.
So the larger the disease-free interval, the better the prognosis, and they are more sensitive to radiation.
Yeah.
Less chance of radio-resistant clones have to be available within the.
Studies have shown that nearly 13% improved survival if it is more than 3 years when compared to less than 3 years. So that is the significance of DFS, and we can Actually, the spinal cord myelopathy part I will come to it a little later. So, what is the role of biopsy? Any surgical oncologist?
Ideally, we want to take it as a recurrent disease rather than persistent disease.
Okay.
So, as far as surgical oncologists are concerned, we would like to go for a biopsy before going for any radical salvage procedure.
Okay. For all the panelists are agreeing on that?
I want to further study for PDL1 status, LAG3, all those checkpoints.
Yes, right.
Because I may add immunotherapy to the chemotherapy.
How much is the time span we are, how practically we are doing biopsy in a recurrent setting? What frequency we are doing, whether it is less than 6 months, more than 6 months, or more than 1 year practically? This is theory.
3 years plus, definitely yes. But within 6 months to 1 year, doing a rebiopsy, I think it's practically difficult. So, at a different site, yes. But within the same area, I think we can skip the biopsy. But for 3 years above, and also a different site, yes.
Usually, practically, we do it more than 1 year or even more than 2 years. Some of the recurrent.
All recurrences are bad, and especially in the setting of HPV positivity, immunotherapy has a role. So most of the recurrences after, if they are HPV positive, they tend to be amenable for a combination immunotherapy.
No, I am just asking whether you de-escalate the strategies.
No, even
Primary itself,
even upfront itself, de-escalation has not been proven. Even upfront, there is a controversy still. There are 3 types of surgical de-escalation. I don't think TARS.
Even nowadays they are telling that even in recurrent HPV positive oropharyngeal tumor, you can do surgical de-escalation if feasible by TARS.
So TARS, by radiation, do you decrease the field? Even primary we don't do. Controversial still, because Indian scenario, it's mixed, not HPV
alone. It is smoking as well.
Different stories. Rest of India is tobacco related and only tobacco related. So we don't de-escalate. And we always, as a medical officer, we want to escalate.
So the predictive role of PDL1, it has shown PDL1 positive patients studies. This meta-analysis has shown that OS has significantly improved with patients with PDL1 positive. So what score you will be taking, sir, Balaji sir? Whether it is TPS or CPS?
Less than 1 or more than 1.
Whether it is TPS or CPS? CPS. For lung alone, you will take TPS. Yes. Okay. What is the significance? Can you just tell me the difference between the CPS and the TPS?
See, the immune cells are very important. For example, in HPV positive cases, the immune component, we have 3 components in the tumor cells, and the stroma, and the immune cells. We take into account because most of the checkpoints are the tumor microenvironment expression of the PDL1, PD1, and even PDL2, LAG3. All these checkpoints are very important in the tumor microenvironment. As far as the tumor is concerned, PD1 and PDL.
Okay, thank you. So, what is the role of imaging? Which modality you prefer, and why you prefer that modality in recurrent setting?
PET and MRI.
MRI
is the one you prefer.
MRI is the one because of the
considering the option of surgery and invasion of adjacent structures, invasion soft tissue involvement. I think
MRI is better in soft tissue delineation. Agreed. And the patients with tracheostomy who are having difficulty, will you proceed with MRI?
So take this better, sir. In case of recurrence, we always think about metastatic disease also. we want to be sure that we don't have disease elsewhere, so we will go for that rather than MRI.
Every imaging has got its role, especially PET has got more sensitivity and 80% of specificity. So as said, to look for the systemic spread. MRI specifically for sinonasal malignancies and base of splinters, where we like to see the intracranial extension or nerve root present, or even to consider the benign condition like nasal obstruction along with the recurrent conditions will look like a tumor. So those with the diffusion weighted imaging sequence with ADS score, they are that which can give us a proper differentiation to know about the recurrence status.
So actually, it's not a single investigation. Ideally, PET is done to find out whether any metastatic disease present or not. But the investigations are tailored to the particular site and particular patient. So the patient may require a combination of investigations. Even ultrasonogram of the neck is very essential for us.
So what we practically do is, we'll ask if the patient is really affordable, we'll ask the patient to go ahead with the PET scan with the MRI screening of the local part. That will be more economical to the patient as well.
I think immunopet is coming. We can see, because even if the metastasis is multicentric and if it is according to the PDL1 expression, it can be immunopet is coming, and we can assess the response after giving immunotherapy combination. So that is immunopet.
And PET can also aid in radiation treatment planning from my perspective. So it all depends on which modality you're going to salvage.
Yeah. So next question is to the surgeon. Although major improvements have been made in the managing patients with recurrent and residual head and neck cancers, a 5-year post-salvage OS ranges from 30 to 50%. So what are the prognostic factors in salvage surgery you will think about?
First, the age of the patient. Once again, performance status, the adequacy of resection, and margin status. Once again, when the recurrence is in the regional side, it is comparatively poor. No, sir. The regional recurrence is having more poor prognosis than this local recurrence.
But practically, what we have seen in the head and neck cancers, like instead of primary, if the node is recurring, it is easy to salvage.
But if the node is operable, it's okay. But if the nodal recurrence, if it is with the extranodal spread or if it is adherent to some adjacent structures, the
adverse
prognosis
cases
will be
always
poor.
carries bad prognosis. So laryngeal site of recurrence has got good prognosis and early stage recurrence, and NC, no previous chemotherapy, HPV positivity, and clear surgical margins. If the surgeon is able to do R0 resection, then it is fine. Less than one node or no extra capsular spread. DFI more than 6 months, which is involving the MGT discussion and no comorbidities and good performance status, and perioperative good nutritional and electrolyte status. These are all the good prognostic factors in salvage surgery. That I am coming it little later. How do you select the patient? What category of patients you will select for salvage surgery?
So first, performance status, sir.
Okay.
The next one is the extent of the disease, whether we can do proper R0 resection.
Okay.
So that's the thing. Then we have to nutritionally support the patient. If the patient is nutritionally poor, then it's very difficult. The post-operative period, the wound complications will be more. And electrolyte, especially in head and neck cancer, the patient will be chronically dehydrated. So we have to go for the check for the electrolyte appearance and all. And most of the patients nowadays, they are coming with either cardiovascular disease or diabetes or both the combination. So we have to optimize that comorbid illness before doing surgery.
So you mean to say the patient who is in good general condition without comorbidities, who is having realistic perspective of cure and preservation of function, these are all the good
they are the
patients.
best candidates for
Best candidates. So that studies have also shown that in toxicity-induced indications for surgery like recurrent pneumonia, aspiration, cartilage necrosis in patients treated for advanced laryngeal and hypopharyngeal cancers, they have a complicated post-operative course. Charlson age comorbidities index has been advocated for model for adequate patient selection. And what is the role of TARS?
So it's ongoing. The indications for TARS is, they are expanding the indications. Previously they thought the TARS is only for T1, T2 oropharynx, but nowadays even they are doing partial laryngectomy with the TARS. The indications are extending beyond T2 to T3. So it's in the evolving stage.
So positive.
So it depends upon the expertise of the surgeon.
Okay. HPV positive.
The most distal part of the area, and which is TARS.
So they are going into the larynx.
But this thing, the visualization which you can get it through the TARS cannot be done it in the normal basis.
Definitely.
So that is another.
The magnification and visualization is better.
10 times magnified. Right? So young HPV positive oropharyngeal squamous cell carcinoma patients who are relatively healthy are eligible for salvage by TARS, and studies have shown that it has got very fewer complications when compared to the open approach on both short as well as long term. So coming to the reconstruction, what are the kind of flaps you will be using and advantages and disadvantages? Can you just enlighten us?
So definitely in a recurrent setting, flaps are better. Even in flaps, if we are using pedicled flap, that is vascularized flaps, the result will be good. The vascularized flap, those days we routinely using pedicled flaps, but nowadays with the advent of microvascular reconstruction, the free flaps are coming in a big way. But the only thing is, for doing free flap, we have to find a good vessel in the neck, because previously if it was irradiated, there will be more fibrosis, so we have to be very careful. So the best thing is, go for a vascularized flap.
Vascularized. So pedicle flaps, like sir has mentioned, pectoralis major and latissimus dorsi flap, they are used for pharyngeal closure after laryngolaryngectomy, and it is reliable, prevents some complications, and the limitation is geometry and the bulkiness, whereas with respect to the free flaps, it is free radial forearm flap or ALTF, which has been used for glossectomy patients. It is well perfused tissue, better healing, and it's pliable, and the limitation is it requires experienced team and special equipment. So what are the complications after salvage surgery?
You can get any form of complications depending upon the patient comorbidity. There is a medical complications as well as surgical complications. Medical complications are even more if the patient was not optimized.
No, I am talking about only the surgical.
Surgical complications, you can get flap necrosis. When you are doing a free flap, the chance of failure is more, and wound flap dehiscence, wound complications, wound breakdown. Sometimes the patient may go for infection and sepsis.
Okay, so it has been classified as 6% for early stage and 30% for advanced stage, and previous CTRT patients, like how you have mentioned, fibrosis and lack of vascular supply, it is 67%, and for the patients who are needing neck dissection also it is 67%, and the progressive fibrosis, wound complications, feeding tube dependencies, tracheostomy dependency are the complications usually encountered after salvage surgery. So what are the high risk factors for recurrence after salvage surgery? Radiation oncologist. This is for the radiation oncologist.
Positivity. Margin positivity is one.
Any other?
The lymphovascular invasion, extracapsular spread, higher stage.
Yes, excellent. So positive margin, even close margin, studies have shown that close margin, positive margin, extranodal extension, multiple presence of multiple nodes, all these things are like at high risk features for recurrence after salvage surgery. We need to give radiation again. So what are the salvage options available in medical oncology? Whether it is chemotherapy or it is targeted therapy, chemotherapy with targeted therapy, immunotherapy or immunotherapy with chemotherapy, what are the options available?
I think it depends upon the certain factors. Naturally, all the three, chemotherapy and cetuximab and monoclonal antibodies, and also immunotherapy is in work, and newer checkpoint inhibitors are also coming.
So how are we going to do that? See, the EXTREME trial had shown that cetuximab, when compared to the chemotherapy, was compared to the chemotherapy alone, and it had shown that it, along with change 2 trials and real world experience, has shown that median overall survival has improved when compared to CT alone. When cetuximab is given along with CT, it is like 10.1 months when compared to 7.4 months, and it is like doubled when compared, PFS is doubled when compared to the CT alone. So what is the current recommendation? ESMO and NCCN says that if you want a rapid shrinkage of the tumor, you need to combine PDL1 with pembrolizumab with chemotherapy, platinum and 5FU. If you don't want that, then you can give monotherapy as well. So the Keynote trial has compared pembrolizumab plus minus cisplatin plus 5FU to the EXTREME regimen. The trial was not the 3 arms. One is pembrolizumab and another is EXTREME arm, another is pembrolizumab with chemotherapy arm. And it had clearly shown that OS was significantly improved with pembrolizumab arm along with CT. When compared to the EXTREME trial, no PFS benefit was shown with the pembrolizumab arm, and the overall response rate was similar between the treatment arms. So What is the similarity between these three actors?
Just a minute.
Yeah.
I hope you will come back to immunotherapy later.
Yeah, later.
Yeah, because one thing is missed out is with chemotherapy is the metabolic therapy which you have not.
That I will come back. Come back. Yeah. So you answer this question, sir. What is the similarity between these actors?
All actors.
All are actors. Were they successful in the first attempt? No. So they were successful in the second attempt, re-entry. Yeah. So coming to the re-radiation, according to the British Association for Cancer Research, nearly 80%, 85% of the patients received RT as a radical. No. The controversy. That's why I told audience questions will be entertained at the last. So whatever the questions you have, you note it down in the phone, and then you can ask me a little later. I will clarify whether it is related to the subject or to the cinema.
Only person is by Tanevar. Never a failure.
So the tumor cells that survive primary RT, they contribute to the radio resistance. That's the thing. So many classification states that best candidates are the patients who are surgically treated recurrences with more than 2-year interval since prior treatment. The OS is nearly 61.9%, whether intermediate candidates are like less than 2-year interval without any organ dysfunction, or 2-year interval but undissected tumors. They have the overall survival of nearly 40%, and the third candidates are the ones we are not supposed to take up for radiation. Usually with organ dysfunction or very short DFS, we are not supposed to meddle with them because anyway it's going to be a poor prognostic. So coming to the modalities of treatment, whether it is brachy or teletherapy, which one you will prefer? A quick answer from the panel.
Depending on the site of recurrence, tumor volume, if it is a smaller volume, within infield which is accessible by brachytherapy, interstitial brachytherapy. So we can actually prefer brachy.
So what are the types of brachytherapy? Like interstitial, we can use it for lip, buccal mucosa, oral tongue, floor of mouth, BOT, valvula, soft palate, tonsil, epiglottis, whereas intraluminal for nasopharynx and ear tumors, mold brachytherapy for external ear and nasal vestibule, hard palate, skin of face, and surface mold with interstitial for hard palate and soft palate and tumors of the nasal vestibule. So what are the factors like Dr. Soumya mentioned? Consider general condition, the type of cancer, extent of disease, location, whether it is accessible, technically feasible, size is less than 2 cm for radical curative brachytherapy, and proximity to the bones, more than 5 mm should be there, mandibular margin, and absence of trismus or submucosal. This is also for technical feasibility, and previous treatment and duration of the previous treatment, gap between the first treatment and the relapse, and dose details of the previous radiotherapy, and suitability, whether the patient is general anesthesia, is fit for general anesthesia for interstitial brachytherapy. These are all the factors which we will be taking into account before selecting the patient for brachytherapy. So it has been shown that the total dose is like 3.5 to 4.5 gray per fraction, and the total doses for radical brachytherapy is 40.5 gray nearly, and brachytherapy boost is 27 gray. And one of the study had shown with 25 patients, overall survival was 77% at 1 year and 68% at the second year. The median follow-up 25 months. But the limitation is tumor volume constraints. Tumor has to be technically small, and technically it is anatomically challenging, limiting the broader use. So which technique you will prefer if you want to, suppose the brachytherapy facility is not available in your center, you want to give teletherapy, which technique you will prefer?
Obviously, we will go for an advanced technique. Since it is a re-radiation, the less spillage, the less volume irradiated is going to be advantageous. And it also have found that usage of IMRT or BMAT, and say in a population where the tumor volume is less than 30 or 40 cc, is definitely going to give a good overall survival advantage as well.
Excellent. So
also the taking to the recurrence pattern, if it's a large volume, complicated type of target, better to go for IMRT or BMAT. It is a small, precisely confined volume with the margins very clear, less than 3 or 4 centimeter. Go for ACBR.
Excellent. So that is, you nailed the point. So 3D CRT when compared to IMRT, the overall late toxicity was 16% overall, but it is mostly in the conformal group when compared to the IMRT group. IMRT and BMAT, they usually offer better tolerance with reduced toxicity when compared to 3D. So the technique when compared to 3D and IMRT, it is usually IMRT or BMAT. And what is the fractionation schedule? Whether it is conventional or you want to go for altered fractionation?
We can go for a conventional fractionation. Even altered fractionation, there is data, but they have found not to have a higher advantage compared to the conventional fractionation. maybe hypofractionation can be considered provided OARs allow for a cumulative bleeding within the acceptable limits and if there are any logistic issues, but conventional is good enough.
So everyone agrees that conventional fractionation should be the goal? Yes. Because of it has not shown any increased survival benefit, but it was adding actually more toxicities. That's the reason why we don't prefer alternate fractionation using the radiation.
Suppose it is replacing the carotid as in the second, then we prefer
Corrected replacement, as it will go only when it doesn't alter the lines of it. It's going to be conventional. But the chance of corrected blowout is high with the SBRT
Yes. What is the target volume for re-radiation? How much is the GTV, CTV, PTV? Can anyone quickly let us know?
For irradiation, just the gross tumor with the margins. There is no role for any elective nodal irradiation or so only the tumor with the margins of GTV to clinical target volume of 5 mm to 1 centimeter and the PTV margin.
Usually it is 5 mm GTV, which is by PET, MRI and objective examination. Yeah, and planning target volume is 3 to 5 mm based on the imaging. So what is the total dose you will give? Is 60, less than 60, 66?
The total dose, the adequate dose, again the TFI is very important and the adequate dose is more than 50 gray at least. So nearly up to 60 gray. So less than 60 gray or the chances of cure will be very less. So adequate
Studies have shown that less than 50 gray, then there's less chances of disease control. So at least 50 to 60 gray depends on the critical ORs nearby, the duration of after what period we are going to re-irradiate now.
Yeah. So it is nearly more than or equal to, right? Some of the studies have shown that it should be of the primary tumor dose more than or equal to 66 gray should be provided the OAR constraints are met to avoid to overcome the radio resistance. Dr. Mutayada clearly mentioned that there is no role for elective nodal radiation because negligible impact on 2-year OS and local control. You have to be very, very careful in re-radiation setting because the complications are going to be more. So we have to respond only to the primary disease. Suspicious nodes need not be, unless it is proven, need not be irradiated. What is the risk of myeloma?
Just to add to the elective nodal radiation, that is a general dictum. But if the recurrence is not in the previous radiation nodal basin, then we should consider giving elective nodal radiation.
What I am saying is in field, already irradiated field only.
Yeah. If it is not in the field, like we need to look into case by case.
Correct.
So let's not take as a
general dictum that elective nodal
radiation is not indicated.
Also the time of recurrence. When we have more than 2 years of recurrence, we can still look into this.
And the risk is more than 20% of getting, the patient is at risk of getting more than 20% of this thing, nodal recurrence, then we have to irradiate. So what is the risk of myelopathy?
So when we are irradiating, when you are considering spinal cord, when it is about the re-radiation, first thing we have to mind is the disease interval from, treatment gap from the first treatment this thing. Because recovery happens from post 2 months, it is around in the range of 20%, and from post 6 months we could consider at least 40% of the recovery from the initial dose. And we have to make sure that the cumulative BED, it doesn't exceed 130 gray at least. So, and another factor is whenever the patient, we make it as a dictum wherever we worked previously, that when the patient comes for irradiation, even if it is the first time irradiation for head and neck, you make sure your spinal cord volumes as low as possible and don't stick to a Dmax of 45 gray. Keep it as low as possible and making an option viable for any re-radiation.
Yeah, re-radiation. That is the valid point which has to be taken into account.
Yeah, and another is that if the previous radiation schedule was 2 gray per fraction, data says that the cord tolerance increases by 25% at a time interval of 6 months. So the time duration also matters when we look in for irradiation for the spinal cord tolerance.
So the point is, whenever we are planning, I am not pessimistic, but we have to think each and every patient will recover and then recur, and then we have to keep the spinal cord dose as low as possible. If the physicist is telling us 40 or 45 gray, we have to tell them to push it a little lower side, so that if the patient comes for re-radiation, it will be easier for us to give more dose to the tumor during the time of recurrence. And nearly tolerance reaches 50% of the original this thing over a period of 1 year, and then longer breaks allow higher doses. And studies have shown that we can go up to 115 gray over 15 months.
It also adds whether there is a complete cross section of spinal cord as received previously, or is it partial?
Partial, yeah. So the tolerance, cumulative dose tolerance have been given. For the spinal cord, it is like 114. These are just theoretical values. Brainstem, it is like up to 81 gray you can go for the optical structures as well. And for the temporal lobe, it is 105, and carotid artery, it is less than 120. So
Dr. Ashwin, another 5 minutes.
Yes, IMRT Sabre, which one you will prefer? They have already mentioned that Sabre volume is like less than 25 cc, then we can prefer Sabre when compared to IMRT, which is usually given for the larger tumors. Systemic agents in Sabre, what is the systemic agents given, sir? Sabre, any idea? Balaji, sir?
Immunotherapy with Sabre.
Yeah, targeted therapy.
Targeted therapy.
Cetuximab, the trials have shown that loading dose along with before 1 week prior to Sabre and day 1 of Sabre and 1 week after Sabre we can give, and it has shown the good response, overall survival, and especially in tumors with low volumes.
Yes, usually ablative dose of any radiation is counterproductive for immunotherapy.
So planning target volume for Sabre is usually 2 to 6 mm from the GTV. Planning target volume. What are the risk pictures for carotid blowout? Quickly, anyone answer? Risk pictures?
And presence of the disease very close to the carotid, the presence of the ulcer and previous irradiation. If it is previously irradiated area, these are considered as risk factors for carotid.
Discuss 8.4% in favor with lethality is around 6%. Skin invasion, an infection near the irradiated area, and more than 180 like what you have mentioned, circumferential involvement of RT and surgical intervention before and after RT, continuous daily treatment rather than alternate treatment. These are all the factors which are associated with carotid blowout. Role of protons I will tell because of lack of time, because RB and LET is like 1.1, so protons can be tried, but the studies have shown that quad shot and then patients who underwent salvage surgery, they benefited more with protons, and the risk of dysphagia and trismus, osteoradionecrosis and carotid blowout syndrome are more with protons. So proton adjunct reactive with protons also shows that there is increased risk of osteoradionecrosis. Neuron capture therapy, it has shown that late toxicities like osteoradionecrosis and intracranial infection, all those things are so when we use boron neutron capture therapies, when no other definitive undissectable head and neck cancers with no other definitive therapies are there, if surgery and radiation both are not planned, then it can be tried at early stages. Coming to the carbon ion therapy, and it also has the brain necrosis, soft tissue necrosis, carotid artery hemorrhage, and the patients who are having tumor close to the optic vessels, optic apparatus, then vision loss will be there or more pronounced. And the meta-analysis had shown that it is safe, but still there are conditions where we see so much of complications as well. So second line options in medical arm. Electrons can be. So what are second line options in platinum refractory recurrent or metastatic squamous cell carcinoma? NCCN and ESMO guidelines says that nivolumab or pembrolizumab monotherapy can be tried in these patients. Other things are like atezolizumab, other durvalumab are tried in clinical trial settings. And this is the Indian trial which exposes low dose nivolumab to chemotherapy, which has shown that metonomic, this is the metonomic chemotherapy along with nivolumab, which has shown the OS from 16.3% to 43.4%, and the median OS is 6.7 months, whereas it is in 10.1 months in case of nivolumab arm, and the median PFS was 6.6 months, and then 6 months in the MCA with this thing arm when compared to metonomic chemotherapy arm alone, which is 4.6 months. So the role of afatinib, it's a lifestyle, it has shown that afatinib significantly decreases the risk of progression or death by 37% when compared to oral methotrexate, but there is no significant improvement in OS. So these are all the ongoing trials. And the Jupiter trial is the one which has to be mentioned, toripalimab along with chemotherapy for recurrent or metastatic nasopharyngeal carcinoma. So always have a MDT discussion, because studies have shown that with the MDT discussion the survival actually improves, because it is So much of ideologies are coming from different people, and then the best possible solution is given to the patient. And coming to the case 1, there is a case of CA left tonsil with RTCT post CTRT in 2011, who was developed left upper alveolus lesion T3N0. This patient received re-radiation 66 days along with 5 cycles of injection cetuximab, and he was found to have desiccated disease on follow-up. He underwent left infrastructure maxillectomy in 2021 August. September he developed recurrence again in the left tonsil and maxilla. We did the biopsy, which was found to be squamous cell carcinoma, which was PD-L1 positive. He received 5 cycles of Pacli carbo along with pembrolizumab till December 2022. PET in January had shown complete metabolic response, so he was continued on pembro till October 2023. But again, the PET CT showed growth in the soft palate and base of tongue. He recurred, so he was started on oral metronomic chemotherapy, and patient still continues to take oral metronomic chemotherapy with a good quality of life, and is still coming for follow-up. Coming to the second case with the residual disease, hypopharynx advanced stage, CTRT, post-CTRT with residual nodal disease. She was PD-L1 positive, started on 6 cycles of chemo and pembrolizumab, and PET was sensitive of complete response. So she was maintained on completed maintenance pembro till March 2024. PET CT in January 2024 showed no evidence of disease, and laryngoscopy showed no evidence of disease in July. She still continues to come for follow-up. So this is the picture of the patient. And third case, a case of metachronous bilateral cheek cancer, post RTCT with for both the lesions, status post tracheostomy. PET CT showed progression. PD-L1 was negative. Actually started on nivolumab with chemotherapy, and after 3 cycles, patient disease progressed and gentrification became very poor. Hence, he was sent on subsymptomatic and supportive care. So take home messages. Look at DFI. Better will be the survival after the surgery. Always think biopsy in more than 6 months, or at least in practical scenario more than 1 year. With give importance to HPV and PD-L1. Patient factors, disease factors, and treatment option should be taken. Treatment-related options should be taken into account before salvage. Staging workup and PD-L1 testing need to be done, because there is no point in giving the local therapy when it is going to be metastatic thing. So always do staging workup and PD-L1 testing. Salvage surgery should always be considered as the first option after chemoradiation especially, and R0 resection should be the primary goal in salvage surgery. Patient selection is very important in any form of salvage treatment. Although brachytherapy seems to be more attractive, it is considered strongly limited with limited tumor volume. Also, it is technically and anatomically challenging. So compared to 3D CRT, IMRT and VMAT actually scores better. There is not much benefit with altered fractionation, so we can go ahead with conventional fractionation. When compared to IMRT and SABRE, trials have shown that IMRT is better, but there is a selection bias. IMRT tumors, whereas SABRE, it is low volume tumors, we can try SABRE. And the volume is GTV for IMRT, GTV plus 5 mm is the CTV, and 3 to 5 mm based on imaging protocol you can give for PTV. Elective nodal radiation is usually not recommended, but it varies from patient to patient. More than or equal to 66 avoid radio resistance. Carotid blowout, osteoradionecrosis, and myelopathy are the dreaded complications. So max dose should be kept as low as possible during the first planning itself, so that we can give more dose during the recurrence. And during the recurrence also, the max dose should be kept as low as possible. Protons, neutrons, neutron capture therapy, carbon ion, these are all the evolving modalities in re-radiation. Both targeted therapy and immunotherapy improves the response rate and survival. Always have MDT discussion before starting the salvage option. Theory and practical scenario are entirely different. Like what we have seen in the theory is entirely different from the practical, because for one patient pembrolizumab has acted like a magical bullet, whereas another patient the oral metronomic therapy is the one which is giving more survival. So theory and practical scenario are different. So third question is so guideline is always a baseline. Keep it as a baseline, and it's not a lifeline. Proper patient selection, meticulous planning, and execution will avoid most of the complications. Thanks for the opportunity.
Thank you, Dr. Ashwin. So now
the floor is
open, and 2 or 3 questions only.
Just to add to Ashwin's nice presentation, like the last line holds good. Patient selection is the most important thing. When there is one good very RPA classification, if you see, they are divided into class 1, class 2, class 3. In class 1, they have 54% 1 year survival. If you have a DFF more than 2 years and completely resectable and no organ dysfunction. Whereas when you see the class 3 patient with a DFA less than 2 with organ dysfunction with a gross disease, that 1 year survival is close to 18%. So patient selection is important as because we take a lot of effort to do RT and we shouldn't go into a fatality. Thank you.
That many classifications I mentioned during the presentation before the radiation. Regarding scenic yeah, it is Nayandara was also successful in the second attempt only, not in the first attempt. Thanks. I thank all the panelists for their wonderful participation and their inputs.
Thank you for the great ideas and energy. Marking the occasion with mementos, we invite the chairpersons to felicitate the panelist and moderator. We also invite Dr. PNI and HNC to felicitate the chairpersons. Thank you, sir. Thank you, ma'am. Our next session is on newer molecular targets and advances in radionuclide therapy. Proof that in oncology, even atoms can be made to fight cancer. We invite Dr. Vishantini Dhanapalan, Vishwabharati Medical College, Kannur, and Dr. Satish Balachandran, Kaveri Hospitals, Trichy, as chairpersons. Announcement: tea is being served outside. Sessions will continue.
Good morning, everyone. First of all, I would like to thank the organizers for giving me this opportunity to be sharing a session which is futuristic topic. When we discuss contemporary radiation oncology, it is also essential that we need to know a relatively rare topic, which is a nuclear medicine related topic. So for which I invite Dr. C.N.V. Harishankar, Senior Consultant and Head Meenakshi Mission Hospital, to discuss the topic. Over to you, sir. Thank you.
I'd like to thank the organizers for giving me this opportunity. So from the previous panel discussion, what I understood is most oncologists here are using PET-CT and they think that it is useful. So that will justify me giving this presentation. So my actual topic is overcoming the shortages, the limitations of FDG PET-CT with the newer molecular imaging, and I will also touch upon the radionuclide therapy. So in 2010, when we started going to several places and giving lectures on PET-CT, we were talking about PET-CT as the molecular imaging modality of choice. But in fact, PET-CT, FDG PET-CT is not a molecular imaging target, it's a metabolic imaging target because it images the glycolytic metabolism. So, it is a radioactive glucose molecule, it is a molecular mimicker and not an actual molecular target. So, but now the things have changed. So when we go and talk about molecular imaging, these were the three things that we were showing. The conventional PET-CT, which is shown in the center, that is the glycolytic metabolism. And we had fluoromesonidazole, which we talked about hypoxia imaging and its role in PET-CT in radiotherapy planning, but I don't think anybody has ever used it. And the third one was fluorothymidine. When I was junior resident in PGI, we had cyclotron by ourselves. We could synthesize FLT and not F-meso and FDG at any time, but we never did it because it did not give much of an actionable information. But the things have changed now. So coming to the molecular targets that we are presently having, these targets are now there. You can do this imaging today. So the first and well-used target was dotanol, that is somatostatin imaging, because neuroendocrine tumor was a relatively rare tumor and it comprised of very little number of cases. It did not come up in that big way. The real change was when PSMA was introduced, which is prostate-specific membrane antigen used in prostatic cancer. And we have targets like exentin 4 for insulinoma imaging, and the big change is FAPI, which I will be concentrating, that is the fibroblast activation protein inhibitor imaging. And we also have commercially available fluoroestradiol imaging for imaging the estrogen receptors. We have DOPA imaging for brain tumors and other tumors, amino acid imaging, which are all currently available. And we also have some newer and very interesting molecules like chemokine receptor 4, that is CXCR4, which is called pentixi4 imaging, which is useful in multiple myeloma, small cell lung cancer, and also in adrenal tumors. And we have alpha 5 beta 6 integrin, which is available readily now, which can be used in head and neck tumors, thyroid tumors and parathyroid tumors. And in US, they are using this FACTC extensively for prostate cancer. And emerging molecular targets are nectin-4, which is an adhesion molecule, which is useful for breast, bladder and melanoma imaging. And checkpoint inhibitors, we can actually identify the expression of checkpoint inhibitors using PET imaging. And we have carbonic anhydrase 9 for renal cell cancers. So what are the real shortcomings with FDG PET scan? Even though FDG PET scan has been used extensively, what are the real shortcomings? It is not specific for malignancy, it is positive in inflammatory lesions. And when the real problem is the tumor biology, when we have low cellular tumors, tumors with mucinous tumors, signet cell tumors, the classic negative in FDG PET-CT is a signet cell CS tumor. And some tumors like thyroid tumors, neuroendocrine tumors, renal malignancies and prostate cancers, they are variably FDG. So, and another problem is patient preparation. Patient needs to be fasting for minimum of 6 hours and they should have euglycemia. When the patient is having uncontrolled hyperglycemia, it is very difficult to do a PET-CT and we have a lot of false negatives. And we have to depend on a medical cyclotron. We have to get the radiotracer from somewhere else. So these are the practical and problems with the FDG PET-CT. So for that, we have an alternative, that is the fibroblast activation protein inhibitor FAPI PET scan. So this is a transmembrane serine protease. It is highly expressed in epithelial tumors, and most of the tumors except for hematological malignancies express FAPI. And this it is associated with tumor ignition, metastasis and prognosis, and this epithelial cells, this cancer-associated epithelial cells or CAPs, they are thought to be like sentinels of any epithelial tumor. Just like how lymph nodes are sentinels for a macroscopic tumor, this CAP is the sentinel for a microscopic tumor. So these are activated during very early stage of the cancer. And they are easily labeled with gallium. Gallium, because we have it in in-house, we can do the imaging anytime. And there is no preparation that is required. Patient does not need to be fasting, patient does not need to have euglycemia, so it is extremely simple and it is a robust molecule. And the imaging takes, like from the time of injection, it takes only 20 minutes. So by 1 hour, everything is over. And only hematological malignancies, FAPI is better avoided. For all other malignancies, it is just better to do FAPI. So this is the initial image which was published in May 2022. It is like a proof of concept. You can see FAPI was tried where a majority of the common malignancies, and it was compared with the FDG, and this study showed that FAPI is positive in most of the malignancies. We have had this luxury to have done FAPI PET scan for even more malignancies than what was shown in the literature. So what are the class indications for FAPI? It is an infradiaphragmatic tumors, especially the hepatic and biliary and signet cell tumor of the stomach, CS stomach. FAPI pickup is extremely high, and any mucinous tumor of the gastrointestinal tract. You can go for even for non-mucinous tumors also we can do, but mucinous tumors it does much better than FDG. Ovary, RCC, we have also tried it in head and neck tumors, CA lungs, and all soft tumors. So on the left panel is the FDG PET-CT image of a case of CA colon post-hemicolectomy, and the patient had liver metastasis for which TACE was done. We can see here, see the PET-CT images. There is a hyperdense area which is the post-TACE changes. So this scan was done initially, and in the follow-up, because the patient had a blood sugar of 500, we had to do FAPI. You can see the difference. In FDG, there is almost like a negative scan, but in FAPI, you can see that black spot. That is actually the residual tumors. You can see the difference in identifying residual tumors with both FDG and FAPI. So this is a case of osteosarcoma. Osteosarcomas are routinely FDG, but the problem in this case was the patient also had is only there in the tumor, and secondary infection, there is no uptake. In all other cases of soft tissue sarcomas like fibrosarcomas, retroperitoneal sarcomas, you can apply FAPI. This carcinoma of breast, we routinely use FAPI. You can see the signal to noise ratio, the axillary nodes are very clearly seen in these cases. Similarly, infradiaphragmatic tumors, like in this case, the carcinoma of pancreas, and even in carcinoma lung. The carcinoma lung, FDG is also equally good, but what is the advantage is that you can see in this patient, there is so much of pleural disease. Identifying pleural disease with FDG PET it's not impossible, but it is relatively difficult. But in this case, you can see on the right side there is pleural effusion, but on the left side there is no pleural effusion. But FAPI is showing clearly the left-sided pleural deposits also. So identifying small disease sites are extremely easy with FAPI PET scan. And we've also used FAPI PET scan in head and neck tumors and also in unknown primaries. You can see in this, the delineation of the involved lymph nodes is very easy with FAPI PET scan. In FDG PET scan, there is physiological uptake in the tonsils, adenoids, and also reactive lymph nodes. But such a problem does not occur with FAPI. So when we are planning for even for nodal irradiation, probably the involved nodes can be easily picked up using FAPI PET scan. And in cases like colorectal cancer, in this case rectosigmoid, you can see the amount of liver metastasis and the small common iliac lymph node which is easily picked up using FAPI PET scan. It is possible to identify these using FDG, but it is relatively easy to pick up with FAPI PET scan. And the classic indication for FAPI PET scan is carcinoma stomach. So these are two images which is pre-treatment. You can see this intense uptake in the of the initial images, and after therapy, the patient has actually progressed. The uptake has significantly increased, indicates that the patient is progressing for FAPI PET scan is signet cell cancer stomach. And other problem with CS stomach is the peritoneal spread. With FDG PET scan, it is extremely for that matter, for any imaging, it is extremely difficult to see peritoneal disease. But you can see the amount of peritoneal disease which are easily picked up using FAPI PET scan. So for any peritoneal spreading malignancy like CA ovary, primary peritoneal carcinomatosis, mucinous tumors of the colon, it is better to go for a FAPI PET scan. And this is a cholangiocarcinoma. You can see this is the site of primary. This is the minimally enhancing CBD, which is very clearly seen in these images, and also the intrahepatic spread, which is also clearly seen with FAPI PET scan. So any infradiaphragmatic tumor, it is always better to consider FAPI over FDG because of relative convenience and ease of interpretation. And other molecular targets which can also be imaged or trastuzumab, this HER2 new expression. In this case, it is labeled with zirconium-89 because this is an antibody. We need a radiotracer with a longer. So this is the upcoming, which is not available commercially yet, but it is an upcoming tracer called carbonic anhydrase 11 imaging agent, which is expressed exclusively in renal cell cancers. You can see the amount of tracer uptake with relatively no background tracer uptake in these images. All these areas, these dark areas are the sites of metastasis. So it is expected that carbonic anhydrase 11 will be the next PSMA PET scan. So this is also going to come up for routine clinical practice very shortly. And regarding the checkpoint inhibitors, these checkpoint inhibitors also can be imaged using zirconium-89, and all these molecules have been labeled with radio tracers, and they will be available in very short time. And these are the number of trials which are going with zirconium labeled checkpoint inhibitor imaging. The problem is every time you cannot be taking a biopsy and finding out whether there is expression or not. So and also there is a lot of tumor heterogeneity. Some areas may express PD-L1 and some areas may not express. So once that initial biopsy and confirmation is done, this imaging can be used for follow-up. Whether the areas where you are targeting therapy, whether they are actually showing PD-L1 expression or not. And the next molecule which is supposed to be very useful molecule is Nectin-4. Nectin-4 is an adhesion molecule, and one advantages of all these FAPI, carbonic anhydrase imaging and Nectin-4, all these tracers are, they are not only for imaging, they are also useful for therapeutic intent. So what is this? Theranostics. So this will be my next topic. Theranostics is a combination of two words, diagnosis and therapy. Take diagnosis and therapy and combine together, that is called theranostics. So you have, we are all aware of what is going on in Russia and Ukraine. Surveillance drone. Surveillance drone will identify whether there is a target for treatment. So that is the diagnostic. You can use FAPI for diagnosis. That will be like a surveillance drone. And when you find a target, that can be targeted for therapy using a therapeutic molecule. So that is what is called as theranostics. So we basically use three types of particles for therapy. The first particle and widely used particle is the beta particle. Beta particle is an electron. It has a relatively long tissue range, but the problem is the linear energy transfer is very less than 1 kilo electron volt per micrometer. Though it can cross few cells and strike other cells, but the energy that is deposited is usually less, because the energy is needed for a DNA particles will cause only single strand. When the more powerful particle is the alpha particle, which has a transfer of more than 100 kilo electron volt. So these will cause double-stranded DNA breaks. So when there is a double-stranded DNA break, the chances of cell kill is relatively higher. And the third particle is the OZ electron producing particles, which are also coming up in a big way. So this is the AROI-TNPY trial, which is the FDA approved agent for prostate cancer therapy, which was published in 2013. This is not available in India. So this AROI trial, they took 921 patients with CA prostate and administered them with this tracer, and it was found that these patients they performed significantly better. That is, the median overall survival was 14 months when compared to the placebo. And in the final, if you see the final result, you can see the overall survival. The patients who underwent radiation therapy, when compared to placebo, their overall survival was 14.9 months when compared to 11.3 months. And also the time to the first symptomatic skeletal event was also higher in patients who underwent radiation therapy. So based on this trial, radium was given FDA approval for treatment of hormone-resistant prostate cancer. These are the final results of the AROI-TNPY trials, where they divided patients into two groups who received docetaxel and who did not receive docetaxel. But the thing was, radium performed much better than the placebo in all the subset of the patients. The real breakthrough in radionuclide therapy diagnostic was in when PSMA was introduced. So PSMA was initially studied in 2012, then they started working on it, and by the time of 2021, PSMA therapy had received FDA, by 2022 it has received FDA approval. So this was the first ever published study of a PSMA therapy. This is a proof of concept therapy from the Heidelberg group in Germany. You can see that this is the initial scan, 2014, the PSA was 387, and then this patient received PSMA based therapy, and by the time of 2015, after repeated cycles, the PSA has reduced to 1. indicating that the patient had responded well. So these are patients who had exhausted all the other means of therapy. They have got androgen deprivation, they have got architectomy, and they have also received docetaxel, and in some cases cabazitaxel also. So they have exhausted all the therapy available, and after that they have got good response to radionuclide therapy. So this PSMA was approved for patient usage in hormone-resistant prostate cancer based on two trials, that is Vision trial and therapy trial. This Vision trial was done in both with centers from both US and Europe, and it was found out that the imaging-based progression-free survival in patients who received lutetium therapy was significantly higher at 8.7 months compared to 3.7 months, and also the overall survival was higher in patients who received PSMA therapy, that is 15.3 months compared to the 11.3 months in placebo. So this was the scientific data based upon which FDA had granted approval for using it as a therapeutic molecule. And similarly, if you see the progression-free survival, patients who received lutetium PSMA had better progression-free survival of 8.7 months compared to the standard of care, which was only 3.4 months. And similarly, overall survival also was better in the PSMA group, that is 15.3 months when compared to the 11.3 months in the standard of care. And the time to the first skeletal event was also better with PSMA therapy, that was 11.5 months compared to the 6.8 months. And this is the therapy trial which was done from investigators from Australia. They basically compared the efficacy of PSMA therapy with that of cabazitaxel, and the endpoint was how many patients had more than half reduction in PSA levels. This was basically done in Australia, and what it showed was patients who received cabazitaxel, 1/3 of the patients had reduction of PSMA level more than 50%, while the PSMA group, 2/3 of the patients who received PSMA had a PSA drop more than 50%. So coming to the other main indication for radionuclide therapy is the peptide receptor radionuclide therapy for neuroendocrine tumors. So these agents were approved for therapy based on two trials called the NETTER trials. The NETTER-1 trial included patients who had well-differentiated neuroendocrine tumors of Ka67 less than 2%. So in these patients, it was compared lutetium PSMA therapy, lutetium dotatate therapy was compared standard of care, which was the somatostatin injection 60 mg, and it was found that patients who underwent lutetium dotatate therapy had better progression-free survival and also better overall survival. Overall survival was better in the interim analysis, but in the final analysis, overall survival was not much different. And based on this information, the same indication, that is lutetium dotatate therapy, was also applied in patients who had higher Ka67, that is intermediate grade neuroendocrine tumors with Ka67 up to a value of 55. Usually with high Ka67 we don't go for a radionuclide therapy, because radionuclide therapy is a slow acting one, and it is thought that these patients should undergo only chemotherapy. But it was found out this in NETTER trial that patients who had even higher Ka67 up to 55%, when they had good somatostatin receptor expression, these patients did lot better than getting only the standard of care. You can see the median progression-free survival was 8.5 months in the control group, while in the 2 minutes. While in patients who underwent lutetium dotatate therapy, it was 22 months. So what is the future? So all this lutetium, iodine, what we are using are all beta-emitting radioisotopes. These, even though they are easily available and they are not very toxic, the linear energy transfer and the incidence of double-stranded DNA break is very less. So the future is alpha therapy. Alpha therapy is alpha-emitting radioisotopes. They have a very high linear energy transfer, more than 100. Usually the cutoff point for causing double-stranded DNA break is 100. So these agents will have more than 100 kilo electron volt per micrometer. So these are ideally suited for causing double-stranded DNA breaks and maximum cell kill. And another problem is because they don't cross more than 2 or 3 cells, the toxicity to other cells is very less. One of the promising candidates which were also used in India was actinium. So you can see the amount of energy deposited by one actinium molecule is 28 mega electron volt when you need only few kilo electron volt for cell kill, but this will cause significant improvement. So last two slides. So you can see here, this is from the literature. July 2017, the patient has a PSA of 700. Only one cycle of actinium PSMA therapy, the PSA has fallen to 70, 90% reduction. 2 cycles of actinium PSMA therapy, another 90% reduction. And by the time the patient has received 3 cycles of actinium PSMA therapy, the patient has become almost like a complete response. So we have to remember these patients have received to this therapy. And similarly, actinium therapy can also be used in patients who failed lutetium therapy. Lutetium is a beta emitter. You can see here, this patient has undergone lutetium therapy, but there is disease progression. But after that, the patient has received actinium therapy and reached almost like a near complete response. So again, the point I like to make is theranostics. So both diagnosis and therapy with the same molecule. You do surveillance with the diagnostic molecule and do therapeutic treatment with the
Thank you for the enlightening presentation, sir. I just have 2 questions. What is the role of FAPI PET in a recurrent setting? Because we are done for 2 head and neck cancers FAPI, so how it is better than PET CT scan in recurrent settings?
There is actually no competition between FDG and FAPI. They are both complementary. So what we usually try to do is we try to do FDG, and sometimes if we think that we are not getting the adequate information, we also do FAPI, and vice versa also. So many times we do both. So it is not like a competition between the 2 molecules. So they are complementary.
Is there any cost difference between FAPI and?
No, ma'am. In our setting, there is not much of a difference. We almost it's the same. So brain imaging with FAPI. Sir, usually FDG PET we don't prefer for brain imaging because background activity, the physiological uptake will be there. Actually, we have a molecule called sestamib, which is time-tested molecule, which is actually very good in identifying recurrence versus radiation necrosis. Actually, it is a very, very simple investigation, and it is a time-tested investigation. We don't even need PET scan for doing that. It's a nuclear medicine technique, a specific technique. Usually in prostate cancers, even with lutetium, we will have some amount of myelosuppression because predominantly it is the bone and bone marrow metastasis these patients have. But it is not a very significant problem. The main problem will be xerostomia. Sorry, ma'am? Yes, ma'am. Lutetium, if it is labeled properly, only when unlabeled lutetium will go to the bone marrow. So that will cause myelosuppression, but when the labeling efficiency is good, usually PRRT patients do not go for myelosuppression. Prostate patients might go for myelosuppression depending upon the amount of marrow that is involved. If they are having extensive bone marrow metastasis, obviously they will have some degree of myelosuppression. Brain tumors, amino acid tracers are available.
It looks, thank you, excellent presentation. Here. Okay. FAPI looks quite promising. So is there few areas where we shouldn't be doing it?
Primarily myeloid tumors like
cervix do we advocate?
Cervix, the problem is there is a physiological uptake in the endometrial and in the uterus. So there are certain tumors that gynecological tumors, treatment naive, and even periampullary cancers, because FAPI has a variable physiological uptake in the pancreas, and we have had problems in identifying the periampullary tumors. But once some treatment has been advocated, in recurrent setting, it is an excellent agent.
Can we target it? Does it FAPI helps in targeting?
Sir, work is going on, sir, but it's not commercially available yet. But FAPI therapy is like
further questions? Thank you, sir. That is a lucid presentation. One last practical question. In day-to-day practice for diabetic patients, because we need them to be euglycemic for PET scan, we kind of tweak the thing by giving one shot of insulin prior to PET scan and then go ahead for want of time and other logistics. Is that a right practice?
Yes, sir. We routinely do it.
That's fine.
Yes, yes.
Thank you. Sir, no.
Thank you, sir.
We invite the chairpersons to felicitate the speaker. We invite Dr. Krishna Kumar sir to felicitate the chair. Thank you, sir. Thank you, ma'am. Next, we move on to Dr. K.M. Roy Memorial Oration. We invite Dr. V. Balasundaram, President AROI-TNPY, and Dr. Balaji S., Secretary AROI-TNPY.
It's my pleasure to welcome Dr. Shumara Prem Kumar to deliver the prestigious KMRI oration. Welcome, madam.
So, good morning to everyone. So, we are moving to prestigious Dr. K.M. Roy Memorial Oration Award. We, the President and Secretary and members of AROI-TNPY chapter and Chairman, Organizing Secretary and members of Organizing Committee of 40th Annual State Conference of AROI-TNPY 2025. We are honored to award this citation, K.M. Roy Memorial Oration Award, on this day of 10th August 2025 for having delivered to Dr. Sumana Prem. Madam graduated MBBS from KMC, Chennai, DMRT and MDRT from Cancer Institute, Adyar. She served as Associate Professor at Radiation Oncology Department at Cancer Institute, Adyar. And now she is a Senior Consultant at Chennai Meenakshi Multi-Speciality Hospital and SIMS Hospital, Vadapalani, Chennai. So we welcome Dr. Sumana Prem Madam to deliver the oration. Thank you, madam.
Good afternoon, everybody. National AROI Secretary General Dr. Srinivasan sir, State AROI President Dr. Balasundaram sir, Secretary Dr. Balaji sir, all the Executive Committee members and the Organizing Committee members, my friends, I thank one and all for this precious oration. Thank you very much. Madras Medical College in the year 1920, and he joined the radiology department in the same MMC as part of his government fellowship. He rejoined the radiology department as a professor. He joined the radiology department and then became the professor. Later on, he had a passion for his subject and teaching, and this led to his eventual tenure as a professor of radiology at MMC. He was the first Indian doctor to complete a specialization in radiology, and he went on to become the Department of Radiology. He was also instrumental in rekindling the IJR and IARI. So this is Indian Association of Radiology and Imaging Association. He rekindled it in 1946, and he was also the editor of the Indian Journal of Radiology. During his long and successful career, he had a vision of developing a medical center dedicated to the treatment of the cancer patients. He worked towards realizing this career, and upon retirement in 1967, we know that he has founded this, what we know now as Dr. Rai Memorial Medical Center in 1962. His lasting legacy has delivered excellent healthcare over more than 6 decades and has many more years to come. So it was a wonderful session, whatever day 1 and day 2. I am an alumni of Cancer Institute, and whatever I am today, I owe it to my alma mater. Dr. Shanta, who wanted me to become a radiation oncologist. My mentor is Dr. Aruna Chandrasekhar. She was a surgical oncologist. So they have molded me to whoever I am right now. Dr. Ariel sir was my teacher of radiobiology. Dr. ISB sir, radiation physics. Dr. Rohini Premkumari, rather the late Dr. Rohini Premkumari, was the one who taught me everything about radiation treatment for breast cancer patients. Dr. Vijaya was also instrumental in helping me understand the biology of how to treat with electron beam. She was the one, in Cancer Institute, it was the protocol. We used to have neoadjuvant concurrent chemoradiation for the breast, followed by surgery, and then post-op party using electrons to the chest wall. Everybody was, those days it was not used at all. Electrons was like, you don't give a completion, the curvature, the chest wall curvature. But we were doing it in those days. And internal mammary region was also part of her treatment at that time. So Dr. Vijaya was the one who guided me in that. Dr. Vasantan sir and Dr. D.V.L.N. Shastri sir were the teachers of other cancers, especially head and neck cancer by Dr. Shastri sir. And I learned from others also, like, how to, even before I became a radiation oncologist, I was working as an OP medical officer for breast and gynec department. So in those days we used to do selectron removal. We had radium removal also in those days. So that was the days when nothing, I was just a medical officer, and Dr. Shastri used to guide me over the phone. Veda sister was the one, and we used to have a safe wherein the radium, he will teach me how to remove it over the phone, and we used to remove the needles and then put it in the lock, the safe, and then Veda sister will take it away back. Iridium, wires were used for implantation. She used to teach me to remove the iridium needles. Sir used to guide over phone, and that is how I learned in those days, even before I became a radiation oncologist. It was really, nice time, and I did enjoy my work, and I do still enjoy my work. I'm passionate about that. Anyway, so that was the time I learned all this, radium And now, I'm going to talk about what are the and the first X-ray cancer treatment was done from 1899. 1901, Pierre Curie, he studied the effects of radium over the skin and thus started using radium for cancer treatment, which is even now valid. Radium therapy centers were established after that. The high energy X-ray was there in 1930s, and that was the time when cobalt-60 units were getting developed. The first cobalt-60 teletherapy unit was in Canada, which helped in better penetration of the radiation, and that was the beginning of the external beam radiation therapy. 1953, the linear accelerators were introduced. 1956, India got its first cobalt-60 teletherapy at the Cancer Institute, which was from the AE of Canada. Computer-based treatment planning was emerging since 1960s, and this integration revolutionized the treatment planning accuracy. Manual planning, I think all of us know manual planning. So many of us have done manual planning. Hand-drawn treatment plans on paper with simple geometric calculations using slide rules. Still, even now I have, ISB sir had given me a 360-degree protractor. I still have those, and the papers of the geometric calculations, percentage tectosine calculations sir is given, and I still have preserved it anyway. So that was the time which we started with all that. Then everything 2D planar imaging was done with X-rays with limited anatomical visualization. Uniform dose distributions were assumptions. So the challenges was actually based on the knowledge of external anatomy and basic geometric assumptions, leading to significant uncertainty in dose delivery to the target volumes. Thereby, there was more radiation to the normal tissues. This is for the papers. Anyway, so the process of planning included a physical examination, palpation, X-ray localization, and manual dose calculations using the PDD tables. And beams were also simple. You had either a single or opposed arrangements. Later, revolution started with the computer-assisted planning. Since between 1960 to 1980, automated dose calculations could be done. The first radiation therapy planning computers were introduced with automated dose calculations. Isodose curve generation was done. Multiple beam arrangements could be used, and treatment planning systems were introduced during this period. With the advances in mainframe computers for dose calculations, digital beams, data storage, automated isodose planning, there were improvements in planning. You could use multiple field techniques with wedge field optimization, and the basic tissue heterogeneity corrections could be done. But still, we were relying on 2D imaging and anatomical assumptions, though the computational power improved the planning and accuracy. This is just a thing, okay. So the integration of CT enabled through 3D treatment planning and anatomical visualization, which was a game-changing technology. The CT scanner's integration with treatment led to true 3D treatment anatomical visualization. Thereby, you could have accurate tissue density measurements with precise target volume. The precision started improving from that time. Precise target volume delineation and 3D dose distribution calculations. Now we have come to sub-millimeter accuracy, right? So there were breakthroughs in the period of 1980 to 2010 with 3D conformal radiation in the 1990s, which had beam shaping with MLCs, conformal dose distributions, beams, IU planning and DIBH analysis. Planning concepts also came into play, like we had a GTV, CTV, PTV, OARs, and this was the era which marked the transition from 2D to 3D planning, dramatically improving the precision of treatment and sparing of the normal tissue. In the 1990s, from 1990s onwards, it was very rapid. You started having intensity modulated radiation therapy, and dynamic multileaf collimators were introduced with segmental MLC tomotherapy introduction with robotic delivery systems. There was revolution in QA also, portal imaging systems and pre-treatment verification with dose verification, thereby leading to IGRT with onboard imaging systems, KV, MV and CBCT, real-time tumor tracking with daily setup verification and correction and motion management also. More advancements occurred later in the 2000s with introduction of SBRT, SRS, VMAT, respiratory gating. Particle therapy was starting to be used. Proton beam therapy had the BRAC advantage. You had the advantage. Planning also became like adaptive planning. You can use plan of the day approaches with online plan adaptation and dose accumulation techniques, and with change in the anatomy, you can monitor the change, anatomy change. Integration of all these increase the precision. So the precision era was even more precise. You had, I think in the morning we had all these sessions, MRI guided radiation therapy. AI was there, I think, yesterday. So AI and machine learning, advanced proton therapy with the pencil beam scanning and IMPT advancement leading to superior dose distributions and reduced integral dose. Hyperfractionation and ablative RT were also developing in this era. A word about the particle therapy. You had proton, which has the BRAC advantage, minimizing the exit dose. Carbon ion, as just now I think sir mentioned, which has higher RBE, which is effective for resistant tumors. And by that 2024, there were 120 proton facilities all over the world and 14 carbon ion centers. This is more applicable for pediatric and skull base and liver and prostate tumors. So, personalized medicine. Actually, Dr. Shanta ma'am used to always say, treatment is individual based. It is tailor based. That is what we all used to say, right? That is what I think, when you say personalized medicine, that was the first thought that comes to me. So it is always individual. It is not a blanket one. You don't use a blanket planning for everyone. So biological planning with functional imaging integration, biological target volume definition with radiomics and genomics, thereby a personalized treatment planning. Reflection machine is, I think, it is going to come soon. So the biological radiotherapy uses multiple PET images with separate patient visits. You create a unique biological treatment volume for this, and then the plan optimization and treatment delivery is done using PET images. We already are using fusion of the PET images for treatment planning. This is more, I think it will help us in giving a more precise treatment. However, the challenges were inter and intrafractional organ motion, treatment plan complexity and delivery time, adaptive planning workflow integration. There was a burden on the quality assurance and cost and accessibility of the advanced technologies. These are innovative solutions with automated systems and advanced imaging, and just now we were talking about molecular imaging integration also. all of this requires a team-based care. So the upcoming technologies, I think the topic of AROI this time was revolutions, right? So the revolutionary upcoming technologies are flash radiotherapy, MRI guided proton biology guided radiation, and radioimmunotherapy, and many others. Flash radiotherapy is using a dose rate of more than 40 to 100 grams per second, milliseconds delivery. The mechanism is by hypoxic protection of the normal tissue. And preclinical results have shown that 40 to 70% less normal tissue toxicity. The clinical trials were started in 2020. Expansion is ongoing. So all of the advanced technologies have been integrated, wherein they finally come to the, actually we have theranostics and adaptive radiotherapy, right? So MR guided proton, precision oncology, AI, combination therapies, everything has led to all this right now. So future vision is wonderful for radiation oncology with AI control systems and personal radiobiology, nanotech integration, which has a targeted destruction. And we are planning, which virtual actually planning is, as somebody said, no, torsos, they have in surgery. We are going to have that also in our planning. So when we are going to do, we are planning, there is going to be more precision, and it is going to be really easy for us to do the planning. So the future of radiation therapy planning is fully automated, AI-driven systems that deliver personalized treatments with unprecedented precision and minimal side effects and optimize patient outcomes. So that comes to the sub-millimeter accuracy, which everybody will tell right now, with less toxicity and more normalcy, better local control. But the cost, I do not know. Cost of these advancements are more, but the cost of the complications are less, which leads to a lower healthcare things. So, from Röntgen's discovery in 1895 to AI-guided therapy, radiation oncology has definitely transformed cancer treatment. The future advancements also will improve the outcomes further. Radiation oncology is constantly and rapidly evolving, bringing hope through innovations. I founded when I was in the Cancer Institute. I was interacting with my patients in the OPD, and which led me to feel that, what the personalized medicine, and they say that, reducing the anxiety. The virtual reality says you can reduce the anxiety of the person. So that is what I found when I was interacting with the patients in the OPD, and that led me to form Cancer Patient Support Group SAKI. It was in December 2002. I founded this, and we used to conduct meetings every second Saturday, creating awareness for the patients about cancer, the various treatments available for cancer, and the complications of those treatments, and how to overcome the complications. I have introduced Yoga Nidra in the institute, and Reiki pranic healing was also introduced along with music therapy. So all this was possible with the blessings of the then chairman Dr. Shanta, and Dr. Rajkumar was the director at that time when I first founded this Saki. And the greatest, I think all of us know how it feels when you see the patient doing well and they come back to you. Another better satisfaction is when the when the patient has passed away, the relatives come to you and still acknowledge you and always include you in the family. So that was one, and this is a picture of with the Saki. Thank you very much for the opportunity, and thank you for patiently listening. Thank you.
Thank you, ma'am. We now call the chairpersons to honor Dr. Sumana Prem.
We now call upon Dr. Devanayagam to we now next move on to the debate about SBRT in prostate cancer, and we invite to chair the session Dr. Madhulika Vijaykumar ma'am, Concurrent Medical Center, Coimbatore, and Dr. Bhanupriya ma'am, Privaram Cancer and Research Institute, Chennai.
Hello everybody, I welcome Dr. Satish Srinivas sir, our mentor, Sri Ramchandra Medical College, to be the judge for the debate.
Good afternoon one and all. A sincere thanks to the organizers for this invite. It's a pleasure to be a part of yet another AROI. And a very important topic for the postgraduates and for radiation oncologists today. It is a bread and butter topic, which is prostate cancer. And it's my pleasure to invite the two contestants, Dr. Anand, Senior Consultant Radiation Oncologist from Koyi Medical Center, and Dr. Harish, Clinical Lead and Senior Radiation Oncologist from Apollo Cancer Center, Vanagaram. And they will be debating upon a very hot topic today, which is how much to give in prostate and how to give. We are moving over from the era of conventional fractionation on to hyperfractionation in prostate. At one end we have the moderate hyperfractionation, and at the other end we have the ultra hyperfractionation. Both have their own advantages and disadvantages, and we have dynamic speakers to extol their virtues. It's over to the two contestants. I first invite Dr. Harish to extol the virtues of moderate hyperfractionation in prostate cancer.
Good afternoon, everybody. First of all, I want to thank our organizing committee for giving me this wonderful opportunity. Without much wasting time, today let's see the discussion about the role of hypo versus ultra hypo in CA prostate. So, as already known in the debate, today the talk will be like, let's see. both type of radiation are very important, and let's see how the discussion goes and what our judge decides and guides us. So in radiation to prostate, now the upcoming treatment modality is either 20 or 5, and I am going to talk about the benefits of 20 fractions. So the two landmark trials which were comparing the moderate hypo, which is 20, versus a conventional 36 to 7 weeks treatment protocol. The two landmark trials were CHIP and PROPHET trial. So we all know that CHIP trial was published in 2016 in Lancet. It included almost around 3,000 people, 3,000 men of intermediate high risk. These were the three arms: conventional, moderate and extreme hypo. And there was an update in the ASCO via JCO in 2023. They found that the 10-year efficacy and comorbids were almost equal or better in our hypo when converted to convention. So here we can say that instead of convention we can go to moderate hypo. The next trial is the PROPHET trial, which was published in 2017 in IJR-OVP. Again they had two-arm trial, conventional versus hypo. Again here we found that biochemical failure rate and the late grade toxicity in GU and GA were almost comparable and much better with our moderate hypo when converted to conventional. So this again had an update in May 2025 where the quality of life was analyzed, and they found that patient who received hypo had better when compared to not better, almost same when compared to our normal conventional hypo. So these two trials, instead of going to conventional, you can jolly well go to our hypo where the patient benefit is almost better or comparable. So coming to toxicity analysis in 20 fraction, both in CHIP and PROPHET, we can see that the acute toxicity was better with 20 fraction. And survival also, it was very better when compared to the two, like conventional hypo, it was better in hypo. In all, survival across the risk group. This is the main thing I want to highlight here. So moderate hypo studies suggest that 20 fraction has mature data which has more than 10 years of long term. So now coming to the other one, which is our 5 fraction SBRT. So again there was two trials with conventional 5 fraction versus our conventional radiation. So HYPO-RT is a multicentric randomized 3 phase 3 trial in which they had two arms. One is SBRT versus our conventional conventional radiation, and they found that toxicity was higher in the 5 fraction arm, which is almost 3 times more than your normal conventional radiation. So the conclusion was fewer the fraction, the toxicity was very high. So coming to other landmark trial, which is phase B trial, again randomized phase 3 trial which has multicentric. They also had two arms, whereas SBRT followed by conventional radiation. Again they found that the toxicity problem was more when patient had SBRT treatment. So toxicity was, now late toxicity data is still pending, but the early signs are signaling towards the more GI issues in SBRT arm. So there was a update to the JCO 2014. This is a trial published in JCO 2014 where they compared head-to-head SBRT versus IMRT in CA prostate. The samples had some around 1,300 SBRT and 2,600 IMRT, and they found that the GA toxicity were more when the patient had SBRT when compared to IMRT. So all these studies tell that when you are using SBRT, the chance of morbidity is likely to be high. The concern is in way of acute GA and GA toxicity. So there was and also increased hematuria risk. So again, as I told, GA, GU more in hyperfractionation when you ultra hyperfraction, whereas moderate hyperfraction the morbidity was less. There was one more trial called Signal trial. They found that bowel morbidity leading to quality of life was poor in SBRT arm. Coming to erectile dysfunction, which is the most common concern in Western country, they found that preservation was better when you had 20 fraction moderate, but the patient suffered erectile dysfunction when they had SBRT, which was again statistically proven. So coming to cumulative dose, there was a meta-analysis in 2023 oncologist trial. They all again same telling, whenever you use SBRT, the amount of late GU and late GA was higher. And one more important thing, post-RT, the toxicity had reversed in 20 fraction. The peak was in only 1 to 3 months maximum. But whereas in SBRT, it prolonged even after 3 years. So these are the main concerns when the patient were not comfortable when you use SBRT for the prostate treatment. So overall, coming to biochemical failure rate, we can see that whenever the modern hypo was used, even the 10-year data and phase B trial both showed there was a significant amount of low biochemical failure rates. So critical note, 20 fractional trial included all higher risk group, even include high risk group. So SBRT data predominantly used low and intermediate data. So overall survival 5 fraction with phase B trial non-inferior metastasis free survival, high trial again told the tender is towards the intermediate risk group. So there was no mature data whenever there was SBRT because still need long-term data to come. Coming to biological evidence, we know that alpha beta is less for our prostate. We have to push more dose. The same time, if you try to push more dose with SBRT, there are a lot of toxicity. So there was an update in 2025 for yearly toxicity analysis, and they found that the patient who had SBRT had higher bowel morbidity and higher urinary morbidity. So incidence of both acute and late toxicity were higher with the use of SBRT. Even quality of life was worse when the patient had SBRT as a treatment arm. So there was a concern, what to use now. My basic concern when I treat my patient is, these are things comes to my mind. How do I manage the toxicity? How do I explain about them the survival? What to tell about the quality of life? And what is my clinical and biological concerns? So when you put all this together with evidence, you can tell the patient that 20 fraction is more convenient whenever you have a choice to use this. So let's see what the guidelines tells. Even the 3 guidelines, what we usually follow like NCCN, ASTRO, ISTRO, all they tell that 20 fractions is better. NCCN category 1, 20 fractions is recommended. ASTRO, 20 fractions is recommended. Even ISTRO, 20 fraction is preferred when compared to SBRT in all risk groups. So 20 fraction remains the standard of care according to me, and even for data which has very good mature data survival of more than 10 years. Superior GA and geotoxicity profile compared to your SBRT. Validated across the all high risk groups. Practical implementation easy. Cost effective and standard of care, and refining radiation protocols are coming up now. Thank you. These are my key references.
Thank you, Harish. So that's Harish's version of how he would treat a prostate cancer. Now we asked Dr. Anand to come forward and speak about SBRT in prostate cancer.
There was 2 two Arnolds, one with a pistol and one with a shotgun. So I am the shotgun. Right. So till it loads. So I'm not going to contest few things. I'm not going to contest that 20 fraction is the current standard of care. I agree with that. I don't agree with the concept that Harish had selectively shown certain toxicities and conveniently omitted certain toxicities. And there is also a selective bias in showing, the outcomes. I will tell you why. So this is, sorry, background. Yeah. So this is the editorial way back in 2020. We said like, should 555 be the standard of care for all the 3 cancers, right? So we'll go ahead with prostate. We are now going to deal only with the prostate. So this is just a bit on history. 7 to 8 weeks of conventional, 7 to 8 weeks of conventional radiation. Those escalation studies happened way back, then led to certain trials in the moderate hypofractionation, which reduced the total treatment time to around 4 weeks, and then the list of trials which is evaluating how to reduce it further to around 5 days to 7 days. So these are the trials. I'm not going into the details of these trials. Okay, what happened? Okay, so what happened was dose escalation showed that there is a slight increase in the toxicity, but there was a better, sorry, my voice is not going back. So the dose escalation trial showed that there is a slight increase in the toxicity, but there was also an improvement in the PFS. So we will agree a slight increase in toxicity if we are improving PFS. Be very clear, right? So we don't need to like afraid of toxicities. If we have to accept an improvement in survival or improvement in the convenience if we are going to accept a small amount of acute toxicity. And then came the moderate hypofractionation trials, right? The non-inferior to the conventional fractionation, but a comparable toxicity. This is what Harish had enumerated, 20 fraction trials. And what we are going to talk about is the ultra hypofractionated or SBRT trials, which, they are also non-inferior as far as the biochemical progression-free survival is concerned, with a comparable 6 years toxicity. We don't have a 10-year toxicity, but that's a timeline, right? So I will base my topic on 3 topics. We all know prostate is a cancer of older people, right? Imagine a 70-year-old gentleman with comorbidities coming to hospital for 20 days, right? If I can treat the same gentleman with 5 days, with the same toxicity, the same outcome, obviously it is logical that we have to choose a 5-day treatment, right? So I will base my topic on the safety, efficacy of SBRT trials, and as Harish told, query long-term data. We'll see about what long-term data we have. So NCCN in 2014 said it's a potential option, but 2022 onwards, SBRT is now one of the standard of care option for localized prostate cancer. And you can see this is the NCCN screenshot. It can be offered across all the risk groups as per the NCCN. Let's go to what the evidence is. So PACA was the first trial of SBRT, which compared aortic prostatectomy with SBRT, which showed that SBRT had a lesser GU toxicity than the prostatectomy. So this established that SBRT is one of the good treatment options for prostate cancer. Coming to PSB and hypo-RTPC, conveniently it was only hypo-RTPC that was shown, PSB was not shown. The difference is hypo-RTPC used 3D-CRT. I don't know how many of us still use 3D-CRT for prostate, not even for a moderate hypofractionation. And these people used 3D-CRT for SBRT. Okay, so that's something that is outdated. We cannot compare some old shutter TVs to LED TVs. So hypo-RTPC is out. We don't even talk about hypo-RTPC. PSB and hypo-RTPC are the 2 SBRT trials. This used low and favorable intermediate risk groups, and this used an intermediate risk group. I agree, but then none of these included high risk group. Let me come to that. So what did this trial show? Both of them showed non-inferior to the conventional fractionation. There is no head-and-head comparison of SBRT to a moderate hypofractionation trial. Though in PSB, investigators were allowed to choose from a conventional fractionation or moderate hypofractionation in the control arm. So almost 40-50%, half of the patients, if I remember correct, half of the patients had moderate hypofractionation in phase B trial. So there is a head-to-head comparison, though it is not in the trial design, right? So the people in the control arm in phase B received moderate hypofractionation. So non-inferior as far as the biochemical free survival is concerned. And there is, I agree, there is a cumulative grade 2 or higher toxicity in the GU, right? Was higher in the SBRT arm. I agree with that. But, we should not, what about that, right? So I think Harish is more concerned about these acute toxicities. Let's see what happened in the acute toxicity. What Harish is talking about, that one single point. What's the pointer? You can't see a pointer. So you see that. So this is, sorry. Oh, you see that right bottom graph? There is a red line peaks at the end of RT. This is the acute toxicity he is talking about. But what happens after 3 months? Again, it's going to go normal. Yes, there is a little bit higher toxicity in the time when the patient finishes radiation. I agree with that. If you see a physician scored toxicity, there are a lot of papers on why physician scored toxicities always overestimate toxicity in prostate cancer. So this is a physician scored toxicity which was always higher, acute toxicity, compared to your moderate hypofractionation. But if you see the quality of life, the patient reported toxicity, the global health QOL, pain, everything scored higher in SBRT, probably because they are coming lesser time to hospital, right? So now people may talk about, as said, that late toxicity is what I'm concerned about. For moderate fractionation, we have 10-year data. We don't have such a long data for SBRT. I agree, because it's a new technology, right? But there are long-term data available, though I also have to agree that these are all selection bias, because these are all institutional prospective data, not randomized data. But you see the numbers, it's around 2,000 people. I can show you the 10-year toxicity. Okay, so see the control rates, 10-year control rates across all the thing. You can see the overall survival is upward of around 85 to 90% at around 10 years, right? And the toxicity. The toxicity is most of the time comparable or at times even lesser than the moderate hypofractionation studies. This is your PROFIT trial, RTOG trial, CHIP trial, CHASE trial. All these are moderate hypofractionation arms. This is the SBRT, the last bar graph is the SBRT data, which shows that the toxicity, both GU and GI, are lesser. Though again, the validity of this data is questionable because this is not a randomized data. So again, another query raised was, what about high risk prostate? What we are seeing are not low risk and intermediate risk. Most of our patients are high risk prostate. Do we have a data for high risk prostate? There is a real world data, again not a randomized data, 38 prospective studies, around 6,000 patients, where 40% of the patients were high risk patients. The only problem with SBRT is still we have not tailored on the appropriate dose fractionation. So people use multiple dose fractions, somebody use 5, somebody use 7, 36.25, 40, a lot of dose fractionations are there. But if you see a cumulative late toxicity, grade 3 toxicity, which we are really bothered about, is around 1 to 2%. Which is same as MF. We don't need to worry about grade 1, grade 2 toxicities. We have to accept that, right? So this is our Indian trial which is going on, the PRIME trial. They have published their acute toxicity data, which is the 90 days cumulative toxicity. This was presented in EASTRO 2023, the Indian trial, where this is a patient exclusively done for high risk patients. So Harish was saying that moderate fractionation used high-risk prostate in all their trials, whereas SBRT is not using. But conveniently he ignored that CHIP trial had only 15% of patients as high risk. Though they included in the trial criteria, patients are not there. Okay. In fact, the moderate hypofractionation, the data is even weaker for high-risk patients, whereas we have an exclusive trial for high-risk patients in India. Right. So what they showed was the high acute toxicity, 90-day cumulative acute toxicity was not very different between moderate hypofractionation and SBRT. But what is more important is exclusive to India, right? We see patients more post-EURP, which is not seen in the Western trials. So don't copy the Western trials because they don't see most post-EURP, and post-EURP we know the toxicities are higher. And there is an paper published from the part of that PRIME trial, which showed 114 patients from moderate hypofractionation, 89 in SBRT. If you see, the toxicities were higher if you do a TURB, but your grade 3 toxicities in SBRT was actually lesser because most of them were grade 2. So it's an inversion. The red line is an SBRT which was lesser grade 3 but a higher grade 2. Right? So what is our current scenario of SBRT? Do we do SBRT in India? This is a 2019 survey done from 88 respondents across India, Indian data. Okay, we don't see low risk prostate less than 5%. 75%, 78% of radiation oncologists of this 88 centers. Probably this is a biased survey because probably the 88 respondents were from high volume centers, but 78% are reported using IGRT, which is commonly CBCT, 78. And you have to agree that CBCT was the only mandated IGRT in all those SBRT trials. Nobody used fiducials, nobody used spacers, right? So 15% of them were using SBRT for their prostate cancers, and 5 centers were using it more than 50% of their patients. This is 2019, which is 6-year-old data, but I'm sure post-COVID most of us have evolved, right? So are we still stuck in the history? Okay, so we have shown that it is non-inferior to moderate hypofractionation in low and intermediate risk. Okay, probably it has a better biochemical free survival. There is an emerging level 1 evidence in high risk and node positive cancers as well. And how much of these patients were represented in the moderate hypofractionation is the question, because CHIP trial had only 15% of high risk patients. We have an option of choosing from every other day or a once weekly regimen, because there is a phase 2 data which says that every other regimen has lesser toxicity with equivalent control. So you patients coming from long distances, you can tailor it. Ask them to come once in a week, just as they come for chemotherapy for 5 days. Slightly higher physician rated grade 2 toxicity, I agree. But these trials are not powered to test that. Yes, there was a high toxicity. And there is no excess toxicity post TURP compared to my moderate hypofractionation regimen, which is our problem. So, I would like to excuse.
So we heard the shotgun loud and clear. Now it's the chance for the revolver to post his riposte.
So Anand sir made my job more easy. He accepted he is providing toxicity. He doesn't have long-term data. There is no randomized trial, and people yet to accept this protocol. So it made my job easy. Let's see my rebuttal and evidence for the same. Next. So, sir, you told 5 fractions more convenient. Sir, already 20 fraction made my 6-week job to 4 weeks. So patient are more convenient by 5 or 4 fraction. But toxicity definitely minds. Patient, if I give choice, you be with bleeding or you want to come 2 more weeks, he will choose 2 more weeks. He won't choose to take the morbidity. So toxicity is always a convenience. Patient will definitely choose safety over the speed. Coming to cost effective, 20 fraction equally cost effective. If he SBRT, patient has to spend on his fiducials, spacers and MR planning, which can be conveniently avoided in our 20 fraction. So definitely it is cost effective. His future? No, still, as he told, maturity is not there. Only long time is 6 years, so we need to wait. So future, long way to go to tell that 5 is better than 20 fraction, because most of the data doesn't use for high risk, only few patients has been included. And coming to BED, I want to highlight here, people think SBRT is more BED, definitely not. If the BED where what you receive is only 2-1, whereas in 40 fraction it is 255, 253. So again, the local control will be much better when you go for 20 fraction, when you control to high HBRT.
Both are SBRT, 45 and 36 in
Sir.
Just this lesser, 180.
I think that's better, sir. So coming to this, my all 4 cleanser, more convenient, cost effective, higher BED, moderate safer, 5, definitely no. I will tell that all the evidence with the clinical listing, 20 fraction supports when it is compared to 5. So the best, so when 5 fraction can be acceptable, only the best candidate who want to take the risk of toxicity, you can give 5 fraction to him, and you can use only for low risk with evidence, and you need expertise to have the good delivery of the treatment without any morbidity, and patient who refuses a long course. These are the only 4 criteria where you can take SBRT as an arm with guarded morbidity and prognosis. But whereas in 20 fraction, it fits all size. Coming to low risk to high risk, you can easily and effectively use that one. No need for any fiducials or spaces for me. I have a very good 10-year proven data. Toxicity points are very less. So ultimately, 20 fractions was scores over 5 fractions in all the regards and with evidence. So coming to efficacy, what you told, safety, what you told, late toxicity, everything is better with my 20 fraction with the evidences. So points to remember, 20 fraction is the gold standard until 5 fraction to prove its place. Equal term, vaccine even compared to it. Safety in even high risk people. Real world feasibility without traditional speaker. With the spacers. So 20 fraction remains the best balance of efficacy, safety and accessibility for treating prostate cancer across all groups. Thank you.
Thank you, Harish. So over to you, Anand, for the final remarks.
Harish can accept, no data for MFI. So there is no data in high-risk patients in moderate hypofractionation because the CHIP trial had only 10%. I want to reiterate that again. Okay, so CHIP trial did not have any high-risk patients. Though included in the trial design, they should have patients, right? So anyway, so my rebuttal, okay, I'll keep it short because it's shorter. 20 days visit versus 5 days visit with equivalent control, right? And it is safer because it has similar efficiency, no difference in the QOL scores, there is no difference in grade 3 GU toxicity, GI toxicity or erectile dysfunction. What is different is the grade 2 acute toxicity. And I just remembered a story when laparoscopy came in. My surgeon said that நம்ம மெனக்கெடுறதுக்கு என்னைக்குமே கஷ்டப்படக்கூடாது, பேஷண்ட் கம்மியா இருக்கிறது கஷ்டப்படும். Okay, so if we are thinking like we can spare our time, by not sitting in the console, that's not the right way to do it. We have to extra work so that the patient becomes convenient, right? That's going to stay. And what if we had this debate in 2016 before the CHIP trial? People would have been debated. Harish would have talked for conventional fractionation. I would have talked for moderate hypofractionation. It is just a matter of time. Maybe in 5 years' time, we will get the mature data. And even 5 years before, the CHIP data did not mature. CHIP data had the same data. So the data is not going to change after 5 years. I believe that the data 6 years and 10 years is not going to be much different because the QOL scores normalize, the toxicity is normalized. There is no need for extra capex. Okay. We don't need extra capital expenditure. We don't need fiducials. We don't need spacers. We don't need any softwares. All these trials, the base B trials, used the simple IMRT. They did not even use ARCs. They used IMRT. They did not use fiducial. They did not use spacers. Okay. So there is no difference in the radiotherapy workflow. Any simple IG IMRT that you do for any other site is enough to do a prostate SBRT. This is not an SBRT. We are not creating dose gradients. Nothing. Okay, the resources are actually spared for both patients and healthcare system. We have to take that time for the 5 days. We don't need to sit in the console for 20 days. We can finish in 5 days to do an online registration. That is the only thing that is required. So it is shorter, it is safer. It is safe. I will not say it's safer, it's safe. And it is a very smarter move to convert to 5 fractionations because you will finish off the treatment faster with the same efficacy. Yes, we will have to work a little bit higher for the patient's convenience. And I agree that it is the standard of care is moderate hypofractionation as of today. That is the...
Thank you. I will ask my 2 moderators to give their opinions and then we go for the judgment.
We are looking into a new standard, which is 5 fractions as Dr. Anand said. So everything has a learning curve, so we are still looking into that. So any institution which has got a robust IGRT and motion control and can give strict dose constraints, and also patient selection is important. So we can use new standard of 5 fractions.
So firstly, I appreciate both the speakers. We had a nice time. We enjoyed the session actually. I would say, I think the radiation department is one such department where there was a lot of evolution in the past decade. So even further hyperfractionation also can happen. Brachytherapy can happen in prostate. So many things are there for us to experiment. So ideally, patient thought process is also so important, which also has to be taken into account. The same thing has to be discussed with the patient and the family members and their interest. What is their choice, 5 days or 20 days? That also has to be discussed with the patient family. Thank you.
Okay, so there's a lot of PGs here, and I'm very happy to see a full house close to a lunch session, and I think we have to thank the 2 participants for drawing the attention of the audience to this topic. Now, what has to be understood is hypofractionation in prostate is not a new concept. This started in 1962. If you look at the evidence first came from UK, where 7 gray per fraction into 6 fractions was being practiced. And at 3 years, this article which came from, I think, Thomas Hospital, from UK said that it is doable, there is no increased late toxicity. So we are not looking at anything which happened over the last decade or so. What happened is brachytherapy took over. And in fact, all this information which they gave went into the fractionation schemes of HDR. So when we had the century turn from 1999, 2000, early part, it was brachytherapy which was dominating in prostate cancer. And in fact, you can share a lot of different, similarities between SBRT and HDR brachytherapy. Both are doable, right? Now, coming over to the hyperfractionation question, the most important thing is the BED, what you can give with hyperfractionation. And I think it's unquestionably the SBRT which gives you a definitely higher BED. No other form of fractionation can deliver that BED to a prostate. This organ can tolerate that dose, this organ needs that dose, and you don't have to worry about rectal toxicity because its alpha beta is it's definitely higher than the prostate's alpha beta. So its BED going to remain the same, whether you give 6 gray or 7 gray, the BED to the rectum and the bladder remain the same. So you have to exploit the differential for the advantage of the patient. But for that, you need to have a robust treatment protocol. You need to follow IGRT daily. You need to have proper patient selection. Doesn't mean that it's low risk, intermediate, high. It has been shown that in all the 3 segments, SBRT is doable. In all the 3 segments, even moderate hyperfractionation is doable. But you have to follow the proper bladder protocol. You have to have tighter margins. If you're doing SBRT, your V37 or your V17.5 have to be very strict if you want to bring down this toxicity. So your physics team has to be good. You have to have good contouring skills, and your image illumination you have to use, PET with MR fusion. Because the question comes in high risk, which nodes are you going to treat? How are you going to deliver the whole pelvic radiation? All this, definitely your PSMA PET is going to have a big role there. So as of today, moderate hypofractionation might be the standard, but it's definitely going to be challenged. The scenario is similar to breast cancer, where APBA is close on the heels of your moderate hypofractionation. And probably 3 years down the road, and for this, we have our own Indian data. It's not like in other sites where we have to quote Western data. We have data from Calcutta, we have data from Bombay. We have 2 Tata hospitals which have been practicing this SBRT and have shown that although there is an increase in the acute toxicity, say as early as 2 weeks post-radiation, this flattens out after 3 months. So the late toxicity curves are almost similar. Now we want to wait for the 10-year data for them to announce that for the Indian population, definitely SBRT is going to be doable. So as on date, Harish is yes, right, but probably the future belongs to Anand. I think that's the way this debate should be concluded. Thank you.
Thank you, sir, for your perspectives and arguments. We invite the chairpersons to honor the debaters. We also invite Dr. Devanayakam sir to facilitate the chairperson and judge.
Just to the audience, can you just name these 2 famous personalities who displayed here? Anybody? Any wild guess? Ben still hand? So any correlation from today's talk? Both are the CA prostate and both had radiation treatment, but I'm sorry, I don't know whether they are 5-factor or 20-factor. Excuse me for that. Next slide. I want to take this today's platform to just announce that we are going to organize our AMP conference state level next month at Apollo Vanaram. I invite all of you to be there and give your valuable inputs. I especially want to encourage the young radiation oncologists. Please be a part of this and have academic fees. It is going to held on September 26-27, Apollo Chennai, Vanagaram. Welcome. Thank you.
We move on to the last session. The last and final session of 40th AROI-TNPY is on late effects of head and neck cancer, radiation and how to avoid them. For this session, we call upon Dr. Vijay Veeran, GKMC Salem, Dr. Suresh Kumar, Rennie Hospitals, Pollachi as chairpersons.
Good afternoon, everyone. I call upon Dr. Arun Kumar sir, Professor Radiation Oncology from Cancer Institute, Araya.
Good afternoon, everyone. So I first thanks organizer and RI team to give this opportunity. So my topic is on late effect of head and neck. Radiation treatment technique. So pharmacological method might be working principle of radio production. It's not widely used due to demonstration of the radioproductive effect. So pilocarpine is a muscarinic agonist. So currently is the drug of historical bullet. So coming to the parotid sparing technique. So it is important to spare single parotid even the conventional technique. So 3D CRT, it is a cumbersome. So only option is intensity modular radiotherapy. Coming to some evidence, like it's a passport trial. So it is a multicentric UK trial. So done in 2003 to 2007. 94 patients randomized to conventional radiotherapy versus parotid sparing IMRT. So xerostomia at 1 year, 74% in IMRT and in parotid sparing, and so parotid sparing 74% in IMRT, and 2 year it is 83%. So no difference in PFS or OR survival. It favors the IMRT arm. Coming, it's a in this study recommends sparing of one parotid appears to eliminate the xerostomia. So in single parotid we have to give less than 20 gray. In both parotid mean dose less than 25 gray. A lower mean dose to parotid gland usually resulting better function, relatively less than 10 gray. So coming to submanual sparing, submanual gland secretion is important for immune stimulation, especially contributed to the substitute sensation of moisturization in mouth. So two options is there, one is glandulopexy and submanual gland sparing. So but it's not widely used because too close to the lower level to neck node. So coming to evidence in this study, so it's a prospective non-randomized trial shown feasibility of submanual explant in selected subset patient all treated with parotid sparing IMRT, contralateral submanual also spared, mean dose less than 25 gray. 1 year after radiotherapy, these patients has less observed xerostomia compared to in patients who have both submanual gland spared, that is more than 25 gray. So in this study concluded preservation of submanual gland function shown depend on the mean radiation, that is threshold dose of less than 39 gray. So this study recommends sparing of at least one parotid gland appears to reduce the xerostomia risk and increase the stimulated and unstimulated cerebral function. So it is its mean dose less than 35 gray will reduce the xerostomia. So coming to radiation induced dysphagia. So radiation induced dysphagia is a late face due to the fibrosis of pharyngeal constrictor. So risk factor include eye days to swallowing structures like pharyngeal constrictor, larynx and cervical esophagus, concurrent chemotherapy, large volume T1 re-radiation. So prevention strategy include IMRT or VMAT technique, limiting the dose to pharyngeal constrictor, larynx and esophagus, and concurrent swallow therapy. So start during the radiation. So in this study, total 96 patients were evaluated. Primary site oropharynx, hyperpharynx, oral cavity, nasopharynx, maxillary, unknown primary. So 85% underwent definite, but 50% post-op. So volume of receiving larynx more than equal to 50 gray, and the volume of inferior constrictor receiving more than equal to 50 gray were similar to with the aspiration stricture. So in this study, so out of 200 patients, 83 patients treated with IMRT at night. So this peg tube dependency increased with when the mean dose to larynx more than 41 gray. So volume of 60 gray more than 24%, and volume of 60 gray receiving more than 12% inferior constrictor, volume of 65 gray more than 70% inferior middle constrictor, and the volume of 65 gray more than 33% is superior pharyngeal constrictor. So in this study, Esposal developed a concept of DOS structure, that is including the tongue base muscle, floor muscle, superior and middle pharyngeal constrictor, and Caregiver muscle and proximal. Sparing these structures, we can avoid the radius-induced dysphagia. So in this study, performing the pre-treatment swallowing exercise produced a measurable improvement in post-treatment swallowing function. So coming to osteoradionecrosis, so it is characterized by the necrosis of bone tissue which fails to heal for minimum 3 months. So progress to extensive bone destruction, so average it is more than 2 years post-radiation. Risk factor include eye radiation to the mandible, poor dental health, dental extraction after radiotherapy. Lifestyle risk factor include smoking, alcohol and diabetes. So prevention strategy include pre-radiotherapy dental evaluation. So remove any tooth with poor prognosis, especially mandible, at least 14 days before the starting radiation. Maintain excellent oral hygiene. So minimize the post-radiation therapy. Use of advanced radiation delivery technique like IMRT and multidisciplinary care coordination. So in this study, so onset of ORN of mandible was yearly, that is median 10.8 months. So incidence is IMRT it's 4.6%. Surgery to mandible, pre-RT tooth extraction to smoking, treatment dose is an important risk factor. Suggesting D mean dose less than equal to 37 gray, so reduce the ORN risk. So in this study, Delphi process highlighted maximum dose less than 30 gray as a dose volume constraint to prevention of the ORN. So in this study, demonstrate the different dosimetric parameters with mandibular ORN, such as mean dose less than 37 gray, so volume receiving 44 gray less than 42%, volume receiving 58 gray, so less than 25%. So this is the picture. First shows the conformal technique. So second is IMRT. IMRT is better mandible sparing than the conformal. So this is the ASCO recommendations. So 2024. So dental assessment by dentist before the radiation. Extract the iris teeth more than 2 weeks before the radiation. Advanced radiation technique should be IMRT or IMPT should be employed. Reduce the mean dose to the volume are receiving more than equal to 20 gray without compromise the tumor control. So coming to trismus refers to the opening of mouth, typically defined as maximum interstitial distance less than 35 mm due to fibrosis of mastitis muscles, that is pterygoid and masseter, and ligament in the temporal mandibular joint. So prevention strategy include prioritizing the dose sparing mastitis muscle, initiate the structure jaw exercise before the start of before or during RT, continue more than equal to 3 months, use low tongue dippers are. So in this study, 81 patients are treated with the RT were analyzed. The masseter, pterygoid and temporalis condyles are delineated. Steep dose to effective relation to mean dose to masseter and pterygoid muscle. Every additional 10 gray dose to pterygoid muscles increase the probability of trismus of 24%. So mean dose to more than equal to 36 to 37 days strongly recommend with the early onset of trismus. So in this study, it's a prospective study. It is concluded mean radiation dose to temporal that is less than 40 gray reduce the risk of radiation-induced trismus. So starting in it's a jaw exercise study. It's a Danish randomized control trial, 58 head and neck cancer patient. So there is a two arm. One is the jaw exercise group and a control arm. So the control arm have the more prevalence of temporal joint disorder. So coming to hypothyroidism, so it's a late effect of hypothyroidism affects 30 to 50% of head and neck cancer patient. Median onset is 1.52 years post-RT, both subclinical and biochemical. Subclinical hypothyroidism I already present soon post-RT in 1 to 5 years. So in this study, so it's a V30 as the predictor of radiation-induced hypothyroidism. In this study, 100 patients, 52% developed clinical hypothyroidism with median follow-up 47 months with thyroid function. All patients treated with 3D conformal technique. A total median dose used in this 60 gray. D mean thyroid volume and whole thyroid gland irradiated to 30 gray was statistically significant predictor of hypothyroidism. So in this study, so V45 of 50 gray can be useful dosimetric radiation including induced hypothyroidism. So in this study concluded the patient who received mean thyroid dose less than 30 gray had significantly lower incidence of hypothyroidism. So coming to lymphedema is characterized by chronic swelling and functional impairment caused by accumulation of lymphatic fluid in the interstitial space due to impaired lymphatic drainage. So higher BMI, higher end stage were independent prognostic factor. So in this neck dose limiting ring reduce the head and neck cancer lymphoma early in carcinoma, dosimetric and clinical radiation study. So in this study concluded dosimetric modeling shows dose limiting ring anterior and posterior region less than 16 to 20 gray correlates with the 60% lower incidence of external lymphedema. So this is the ring structures anterior and posterior neck. So here coming to hearing loss, radiation to hearing loss, the most sensory neural hearing loss, high frequency, high radiation dose to cochlea, concurrent cisplatin based chemotherapy, younger age and smaller cochlear volume, reversing hearing are the risk factors. So in this study concluded it's a comparing study between the IMRT, Rapidac and tomotherapy. This concluded Rapidac achieved better dose sparing in the sparing compared to the IMRT. Reduction of mean dose Rapidac is compared to IMRT was 3.4 gray. So in this study, the cochlear dose of less than 35 gray associated with the significant lowering hearing loss compared to higher dose. This is the pediatric study. The pediatric patient who received less than 35 gray mean dose to cochlea, no pediatric patient developed the sensory neural hearing loss. So this is the contact study, contact table shows for parotid and mandible, larynx and pharyngeal constrictor and cochlea. So take home message: xerostomia can be prevented by the parotid sparing and sublunar sparing if oncologically safe. Dysphagia can be prevented by the limiting dose to the DOS structure. Osteoradionecrosis can be prevented by limiting dose to the mandible and with modern radiotherapy technique. Trismus can be prevented by the limiting dose to the masticator muscle, temporal joint and jaw exercise. Hypothyroidism can be prevented limiting dose to thyroid gland when it is oncologically safe. Lymphedema can be prevented by the neck exercise, dose to the limiting ring to the anterior and posterior region. Hearing loss can be prevented by limiting dose to cochlear and inner ear. So conclusion, late effect of head and neck radiation are common but largely prevented with modern radiotherapy like IMRT, IMRT, VMAT and tomotherapy. So thank you.
Thank you very much, sir. Nice presentation. Any questions from the audience?
Only one question. It's practical. You have told all the side effects, chronic side effects, like xerostomia and other things. There is one more which can mimic a skin disease. I think you know that phenomenon. Radiation recall.
Radiation recall, yes.
I have seen a case. that was, say, after 2 years it has come, but after radiation, it has come after 2 years. First it was treated as dermatitis. Then because of that telangiectasis, then it was referred to a vascular surgeon, and he told it is vascular, and he treated. And finally, after 2 years, the patient came back, and he told me, sir, now only one doctor told it is it may be due to radiation. Then that was the time which we diagnosed as radiation recall phenomenon. It is a non-infective inflammatory disease, and it can be simply treated with mild corticosteroid treatments. Thank you, sir.
Okay, thanks. Thank you.
Thank you for this.
Thank you, sir. We now invite the chairperson to felicitate the speaker. We call upon Dr. Dainayagam, sir, to felicitate the chairperson.
Good afternoon all. First of all, I thank you each and everyone for your active participation and cooperation till the end of this 40th TNPY 2025 conference. பொதுவாக எல்லாருக்கும் ஒரு நன்றிகள். சரி, I request our President sir and our Secretary sir to come on it. Sir, Krishna sir. So many, I congratulate the active participation of the PGs for the posters and the papers. Actually, judges வந்து சார் எல்லாருமே இல்லை, அதனால அவங்க சார்பாக என்ன சொன்னதுனால சொல்கிறேன். ஆக்சுவலி த போஸ்டர் ஜட்ஜஸ் அவங்க ஒப்பீனியன் என்னென்னா, எந்த கான்ஃபரன்ஸ்லையும் இல்லாத அளவுக்கு இந்த தடவை போஸ்டர்ஸில் ரொம்ப நல்லா ப்ரெசென்ட் பண்ணியிருக்காங்க. அதனால நீங்கள் ப்ரைஸஸ் வந்து கன்சிடர் பண்ணணும் சொன்னதுனால we have considered 2 more prizes for the posters. அந்த ஓரல் ப்ரெசன்டேஷன்லேயுமே எல்லோரும் நல்லா பண்ணதாக தான் சொன்னாங்க. அந்த கண்டென்ட்டு, அவங்களோட டிஸ்கிரிப்ஷன், அவங்களுக்கு கேட்ட கொஷின்ஸுக்கு எப்படி ஆன்சர் பண்ணியிருக்கீங்க, என்ன அந்த கண்டென்ட்டை புரிஞ்சுட்டு பண்ணியிருக்கீங்கன்றதெல்லாம் பேஸ் பண்ணி தான் மார்க் போட்டதாக சொன்னாங்க. ஸோ ஃபர்ஸ்ட் ஆஃப் ஆல்
Good afternoon. By convention, the Professor Kalavati Award goes to the organizing secretary, Dr. B. Rajkumar. So you become Vice President of AROI-TNPY chapter. Yeah, This Vice President post for AROI-TNPY chapter is for 1 year. That will be for Dr. Rajkumar. Dr. Kalavati Award goes to Professor Dr. Devanayan sir.
Now we go for prizes. The third place for oral presentation goes to Dr. Ajita Sri MMC. இப்போ அவங்க இல்லைன்னா அவங்களுக்கு போல யாராவது வாங்கிக்கோங்க. MMC Dr. Ajita Sri. Oral second prize goes to Dr. Vishnu MMC. Sir, this is cash prize. The third prize, the cash prize is 2,000 rupees from our side. For the second prize for oral posters, it is Professor MJ Award for 2,500 cash prize and 3,000 from our side. Dr. Vishnu. யாராவது வாங்கிக்கோங்க. இப்போ ப்ரைஸ் சொல்கிற அளவுக்கு கூட உங்களுக்கு டைம் அட்ஜஸ்ட் பண்ண முடியாமல் போயிடுறீங்க. அப்புறம் அங்கே அவங்க சொன்னாங்க இவங்க சொன்னாங்கன்னு மட்டும் கேட்டால் எப்படி? The oral presentation first prize goes to Dr. Vinayak Badmanabhan from Kanchipuram. This is Professor Padam Singh Award from AROI, State AROI side 2,500 rupees and from our side 5,000 rupees cash prize. Kanchipuram. Posters. E-posters, third prize goes to Dr. Wasim Fatima of MMC, cash prize of 2,000. Second prize goes to Dr. Balaji Tamil Selvan, MMC, cash prize 3,000. Balaji Jagannathan. Sorry, Balaji Tamil Selvan. Sorry. The best e-poster award, Dr. Bhubalan Award from State AROI, cash prize of 2,500 and 5,000 from our organizing side goes to Dr. J. Priya of Kanchipuram. Kanchipuram Vinay first prize at the oral. So extra 2 award கொடுக்க சொன்னாங்க. So poster consolation prizes. First prize goes to Girvani of RCC Trivandrum. Cash prize of 2,000. There is certificate. Actually Trivandrum யாரும் இல்லைன்னு நினைக்கிறேன். அதை எடுத்து வச்சிருங்க. Consolation prize for e-poster one another person is Dr. P. Kavita of Cale Park Medical College, cash prize of 2,000. KMC and another more 2 special awards from our State AROI side, Dr. Yukta Gummadapu of SRMC, Dr. GSL Award, cash prize of 2,500. Another special prize, Dr. Bharat Kumar of Adayar Cancer Institute, Dr. Sastri Award of cash prize 2,500 from State AROI-TNPY. Now we move upon to fellowship. Sir.
We had the fellowship interviews yesterday. 8 to 10 PGs came, out of which we've selected 6. 3 will be paid fellowships, 2 from AROI and 1 from the organizing committee. They've offered to give fellowship as well. Other than that, 3 people who will have non-sponsored fellowships. Dr. Sanjay from AIMS Kochi, he wanted to go to Rela Institute for a sponsored fellowship from the AROI side. Sanjay. The next sponsored fellowship is for Dr. Neelima from GRH Roypeta. Dr. Neelima. Dr. Bhavani from Adayar Cancer Institute. Dr. Kavi Aragi from GRH Roypeta. Dr. Godson Titus from Adayar Cancer Institute wishes to go to Tata Memorial Hospital, sponsored by Alex sir. Dr. Shivani from Adayar. Some of the prize winners are here. Dr. Balaji Tamil Selvan from MMC.
Vishnu. Ajita. Overall prize winner, the prize goes to MMC. 27 number of participation in e-posters and oral together. 27 pages have come here. All the pages can come. MMC pages, all the pages can come. Please, please. All the entire team can go out for a group photo, please. Thank you each and everyone. You all can.
A big thank you to Professor Dayanand sir and Rajkumar and entire team, General Medical College, Radiation Oncology, and the entire organizing team of everyone. Thank you all.
We thank Professor Dayanand sir and Rajkumar, the entire team for organizing one of the best AROI state conferences.
The sponsors felicitation. Sponsors, company sponsor felicitation. Simpla.
और फोटो
Anakas.
मैम கொஞ்சம் உள்ள வர
Swan Pharma, Bionim, Propax, Theranos, JH, Nest, Retiro,
அங்க பாருங்க
Atley,
ப்ரோ அங்க வைட் வந்து இங்கே கேமரா பாருங்க இங்கே பாருங்க ஓகே கொடுக்கணுமா சார் இங்கே பாருங்க ஓகே சார் நீங்க பாருங்க விடிங்க பாருங்க ஓகே சார் ரெடிங்க பாருங்க. ஓகே.
அவர் கேமரா வாங்கி கொடுத்தாங்க இப்படி தான் இருப்பீங்க. அது வரைக்கும் ஃபோட்டோ எடுத்து இப்படி தான் எடுத்துருக்கீங்க. எனக்கு முன்னாடி ஆட்டோங்க நீங்கள் வச்சுட்டு விட்டீங்கன்னா அதுவே கிளாஸ் தெரியாதுங்க. சனங்கியில் ஒரு பையன் இருக்கான், அவன் சேர்த்து விட்டா நினச்சிக்கிட்டு நீங்கள் இருக்கீங்க.
வரேன் ரெண்டாங்க சார்.
ஆமாம் லைட்டாக கேமரா வெயிட் எடுங்க. இந்த ஒரு
வரலாறுமா கொஞ்சம் நெருங்கி அம்மா அந்த ஸ்டாண்டு கொஞ்சம் நோட்டிருங்க. மைக் ஸ்டாண்ட்
போடி
ரைட். ஓகே போதும்.
ஓகே ரெடி. இங்கே பாருங்க.
ரெடி கேமரா பார்த்துக்கோங்க. ரெடி ஸ்மைல். ரைட் ஓகே. சார் கொஞ்சம் வைடு வந்துங்க சார், கேமரா லைவ் பண்ணி. ரெடி கேமரா பார்த்துக்கோங்க. கொஞ்சம் நோண்டுக்கும் ஓகே கொஞ்சம் நோண்டுக்கும். இது பாருங்க
கொஞ்சம் அப்படி சேர்ந்துருக்கீங்க நல்லா சார். ஆ ஓகே
ஓகே சார்.
வெளியே நம்ம இங்கே